Sir, to you. Nalin sir.
I think we have lost audio visual. Implants are in the OT, no?
I think there is a reduction from their end. It is being fixed.
Just tell him to put the. This is a little too loose. I am always scared that this will fall off. Tell him to put the the infant feeding tube on this.
infant feeding tube लगाना है.
Nalin sir. Nalin sir.
He has this thing.
Not audible.
कोई भी इधर कोई
बड़ी नमस्कार.
लिग्नोकेन एड्रेनालिन लिया है.
Plastic is fine.
कौन प्लास्टिक होना है?
Repeat.
24 number, yeah, 24.
Nalin sir.
और 3cc है लोअर लॉ.
Yes, sir.
3cc का है रहता है नहीं. हाँ वो 2cc वाला है बट द लोअर लॉक वाला रहता है.
अरे नहीं.
Starting. Huh? Yeah, I don't think there's audio visual there, but we'll start.
सुनाई दे रहा है.
Yes. Once this implant is in, just remind me to infiltrate that before we close so that it gets time to act. Yeah, do you have a tegaderm? Tegaderm offside, just cover the nipples. Tegaderm or offside, whatever, small one. Yeah. नहीं बड़ा वाला नहीं, छोटा छोटा. Just for the nipple. Okay, we'll cut it into two parts. We always cover the areola because that's contaminant. काटो ना इसको. This is new to me. How does this work?
Oh, actually, this is all that is left. Ma'am, get one more.
Wait. No. That's all right. That's all right. Kato, please. We need to cover the. Chalo, shall we start? Yeah, I need a mop, please. And no gauze pieces, no gauze pieces, only mops. Yeah, और इसको जरा please saline में ये करके देना. Don't give dry mops, please. Antibiotic gone? Chalo. We are good. If you are all right, I'm good. 15 number, blade, please. चलो starting दोनों को हमको एडिसन टूथ फोर्स से मिलेगा.
We are just
Operative, please. On hand.
On hand.
Second hold करो.
Hello, are we audible? Inside the OT, are we audible? Can Milind sir hear us?
Yes, I can hear you. Can you hear me?
Yeah, sure. Loud and clear. So the camera, can there be a better view of the camera?
No, sir, there's no need, sir.
Can there be a better view of the camera? We can't see the incision being made properly. Can there be a different projection? And I think Lakshmi sir has some questions to Milind sir.
Yeah. So he was asking me about the
That's for-
position of the arms
Yes, sir.
inside. So if we are doing a subpectoral insertion, then we keep the arms at 60 degrees. But if we are doing a subfacial, as we intend to do in this one, then usually we keep it at 90 degrees. It really doesn't matter. It just keeps the arms out of the way of the surgeon.
Okay, sir. Thank you.
Yeah, catch paw, please. Uh, Light थोड़ा सा बेहतर. Slightly better than this.
We are not being able to see the point he is working at. Can there be a better view?
Yeah, they're trying.
Okay, sir.
Sir, what type of anesthesia means general anesthesia and hypotensive anesthesia should be given here or something? Any?
No, not really. It's not necessary hypotensive. Anything normotensive anesthesia is good enough. There are certain surgeries like facelift and all where we prefer a little bit of this thing. Okay, now I don't know whether you can see it. I'm on the fascia.
It's visible, sir, now.
Can you see it?
It's a silt, sir. What was the infiltration, sir, given to you, given on the intramural report that was?
I'm sorry, I can't hear him properly.
Infiltration has been given.
That was
Yeah,
the
so this is just 2% lignocaine adrenaline.
Rupicacan, sir, are you given, sir? Rupicacan for
Dr. Misra, I can't hear you very well. Your voice is echoing, so it's.
okay, sir.
Hello. Am I audible? Hello.
This side.
Is there an echo?
Yes, there is an echo. So what you say becomes very.
ट्रेवल कुछ कमाओ.
Understand.
कहाँ से एडजस्ट होगा? हेलो.
अभी ऊपर खाली सर.
Transmission problem.
लाइट थोड़ा सा अंदर आना चाहिए. Okay, larger retractor, please. Yeah, give me one more. Yeah, otherwise what you can do is light cord लगा के ना light cord अंदर डाल दो. Just hold the light cord on top. Light is not coming in. Medial side.
Hello. Can there be a view from the foot end of the patient? Because not being able to see the plane that he is going in.
एक काम करो. वो आपका इधर लगाया हुआ था ना दूसरा वाला with the infant feeding tube. Anyway, we will be नहीं वो नहीं जो आप हाँ ये दे दो. See, this is the reason why we use this. You see the here it's at this junction. Yeah, this junction is where it causes the problem. So what this does, It covers this junction. Yeah.
वो लाइट डाल दो सोर्स का बस वरना आस दिख रहा है उन लोग हाँ वो मानो गाना यू गो दिस साइड यू कम टू दिस साइड लिव आना हाँ नहीं हाँ yes because they are not able to see anything
नहीं एनीवे अंदर दिखना बहुत मुश्किल है.
हाँ
Hello, are we audible? Hello,
Yes, I can hear you.
is there still the echo?
Right. Yeah, I know there is a echo from your side as well. I can't hear what you're saying. Illuminate it, please. छोटा वाला illuminated. ये इसको fit होएगा. Give me that.
नहीं हो रहा सर.
नहीं.
रिड्यूसर होगा रिड्यूसर
ठीक, no problem. No problem. आप retract करो खाली. I'll this thing and
I can hold it, sir.
yeah. Can you do that?
Yes, sir.
Only thing is that
और एक रिट्रैक्ट कर दो
Can you, is it okay, sir?
no, one second, I'll hold it. In fact, I want a slightly bigger one next.
नेक्स्ट टाइम दे
Usually in the subfacial plane, you are a little, you have a little bit of a adherence up to the nipple areola. Once you get beyond the nipple, light please. If you prefer to do all the dissection
Namaskar.
with pottery only.
Sir, situation is
Breast थोड़ा सा soft ये है.
हाँ जी, audible to you?
So it will bleed.
Sanjay,
यस यस
audible, no?
हाँ ऑडिबल यू आर ऑडिबल
Okay. Meaning, sir, why you opted for subfacial in this case? What is the advantage? Why have not planned for subductal means subductal?
What is he saying?
He's asking which plane, what's the plane?
Yeah, so we are in the subfacial plane.
क्लियर होने
Indication of these patients are for subfacial.
He's keeping his mic too close to his mouth. उनका ही हो रहा है sir.
Section नहीं हो रहा है.
इसका मुंह बढ़ा दो यार. Section थोड़ा बढ़ा दीजिए.
वो illuminated मिलेगा. Just 2 minutes.
ये ले लीजिए.
We're trying to just fix the audio visual a little bit. So Dr. Misra's voice is echoing continuously, so I can't hear what he's saying.
Hello, sir. Now it is better, the voice quality.
Yes, a little better.
Sir, Sunil here. I just want to convey the query Dr. Misra had. Sir, he is asking that any specific reason to choose this subpectoral plane over subfacial plane over subpectoral.
Yeah, so see, there are some disadvantages of the subpectoral plane. The advantages are all obvious to us, is that basically you're getting a nice cover over the implant. But it means that you have to cut the pectoral muscle, what we call the dual plane 1, 2, and 3. And cutting the muscle is not a good idea, especially in a young athletic woman. because first thing post-operatively it's quite painful, and the other thing is that really it is not a dual plane. You know, the lower third of the implant is anyway in the subglandular plane. Yeah, so this this dual plane 1, 2, and 3 are a little bit of a misnomer. They're not really all that this thing. However, if the patient's chest wall is such that you can actually see the ribs and there is no decent soft tissue cover, then putting a circular implant in such a case in the subfacial or a subglandular plane just creates two balls on the chest wall. Then you don't get the upper pole slope. Then you are forced to do it in the subpectoral plane. As far as subfacial versus subglandular is concerned, I think the subfacial plane is a pretty good, you know, it's a nice robust plane. People say that, you know, it is just a very thin fascia like galea and, you know, there is nothing there. But no, it is. It's quite a good plane there. And it has all the advantages of the subglandular as well as the subpectoral. It gives you a nice smooth outline over the implant at the upper pole. At the same time, there is one more sort of plane between the gland and where you are dissecting. So it has all the advantages that I think. So that is why we prefer the subfacial plane.
In between, you can show the illuminator to the audience.
Okay, sir. Thank you for the clarification. I think it clears the doubts amongst all the audience.
We are just waiting for the illuminated retractor to connect. Okay, so now this is the retractor I have got from Mumbai. I have no financial interest in this, but I think I got this from Jalandhar Surgicals, if I'm not mistaken. Yeah, it's a very if you see the working end of the retractor, it's quite thin, and it's less than 3 centimeters. So it goes very nicely. It's got a lovely curve, so it completely you know, takes care of the breast as you're lifting the whole thing. And then there is of course the illumination at the end. So you need a fiber optic cable for this. So once you go you know, up to the level of the nipple areola, the rest of the dissection is done partly by the retractor itself, because above the nipple areola, the subfacial plane is a little more sort of gossamer. It's not as thick. And the rest obviously is done by you know, cautery. As far as possible, we prefer not to do any finger dissection. Although, you know, in the subpectoral plane, that's possible. You can very quickly do a finger dissection. But here also, it's not very, it doesn't take a lot of time as soon as you have good illumination. ये वाला, ये पहले ये वाला बैठेगा.
Sir, can you recall, please, the price of this retractor for the audience?
This one is, I think, around when I bought it. This is 10 years old. When I bought it, it's around, I think, 15,000 rupees.
Much reasonable.
Sorry?
Much reasonable price.
Yeah, reasonable. You can also get a similar retractor from Germany, from a company called Medicon. And that retractor is in Indian rupees, it is 65,000.
Oh, yeah.
It's exactly the same, exactly. But you know what we have in India called Jugaad.
Yeah.
So this company from Jalandhar has made this nice Jugaad. It looks exactly the same. Little bit, maybe a little bit of polish is a little better on the German one, but you know. Yeah, first class. Perfect. Thank you. Here, Abhijit. Sure. We'll keep one of these.
Yes.
And this one.
Big one is not required, no?
No, we'll, as we go a little deeper, we'll take it. No, I'll hold it. Sure. Pottery, please.
This is helping illuminating.
Sorry?
So this is helping to show the deeper structures.
I don't know whether the camera can see it.
Are you able to see?
No, it's unless you put a endoscope now, it's almost impossible to see the dissection. So I'm not dissecting with my hand now. What I'm doing is just to see where I have reached as far as the lateral this thing. It was very easy to go too lateral. So I'm just making sure that I know where my lateral dissection is. I know where my medial boundaries are, and I've reached here. Yeah, it has taken probably about 10 minutes to do so. It might be a little slower when you start, but otherwise it's not a problem at all. And I'm sure all of you guys do breast augmentation practically as much as we do. So this is nothing very special. The medial extent of the dissection is much more important than the lateral extent. Yeah, lamba wala dal sakte hain. Can you connect that? Just please put the tip back again under. And this oh isko usne tipka vipka diya kya? हाँ, तो मेरे को वो वाला देना अभी, the bigger one.
Can we see someone?
Yeah, see inside.
Sir, can you please elaborate these incisions? Most of these incisions are there. Inflammatory, transaxillary, and
Okay, you want to know how where the incision is placed?
which means incision you follow means this inflammatory, and in which conditions you follow for nipple transaxillary
Which conditions I follow?
nipple areolar complex, NAC.
Which conditions you follow? Nipple areolar?
Yeah, this one.
Areolar or transaxillary?
No, I've never used transaxillary except in 4 or 5 cases, and I've repented in every single one of them. Because
Sure.
the dissection from the transaxillary side in the upper 2/3 of the breast is very simple, and that's not a problem at all. But you're always at a quandary, or you're always a little doubtful how low to go. More
Yes, sir.
often than not, you'll end up going too high, staying too high.
Okay.
So it's not a good this thing. The other thing is that with the transaxillary approach, the implant tends to remain high.
Okay, sir.
Doesn't sort of descend down because your dissection is never completed fully. The periareolar route I've never done. I'm sorry, I've never been trained with the periareolar route. But anyway, most of these patients, if you see, unless fitting, आ रहा है light आ रहा है? इधर light है, निकल गया. Chalo, we'll just see whether it works. Otherwise, we'll hold this thing separately. No problem. Yeah, एक बार try करो आप. अगर बैठता नहीं है तो we will just go on. हाँ बस हो गया ना, अभी और कुछ करने का जरूरत नहीं है. बस that's it बस. Yeah, or can this illumination become a little bigger, more? Maximum per maximum. हाँ, first class. Bus. Good enough. Sure. Yes. No, I'll hold.
You are taking your experience on this inframammary incisions. Can you please again, sir, you stop?
Yes, sorry, what was that again?
You are talking about this inflammatory incisions experience, sir. Advantage and also this disadvantages.
Experience.
Means advantage, your experience advantage.
I don't understand what you're saying.
What is the experience in inframammary
वो जो बात कर रहे हैं, या फोन करके बोलिए उनको कि उनका माइक का वॉल्यूम बढ़ाना है.
Sir, he is interested to know, as per your experience, the advantages and disadvantages of different incisions. Whatever you have used.
No.
Like you were talking about transaxillary who are not happy.
Yeah, so see the inframammary incision is actually a natural incision to take, because you are creating you're putting an incision in either the old inframammary fold or the new inframammary fold that you have created based on the size of your implant. So it's a natural incision. What it allows is to give a pocket from the bottom to the top. So you are in complete control of your dissection pocket. And because you have lowered the inframammary crease in some cases, you know exactly how the implant is going to sit and that the implant is not going to migrate anywhere. Your pocket is absolutely, precise with your inframammary incision. Now, when we started out, when I was in training, when we used to see Dr. Pandya operating and other people are in their incisions, even of the stalwarts used to be 8 centimeters, which, now we have got down to about 4 centimeters because now our implants are highly cohesive gel. They're not going to rupture. Yeah. And of course, you can use the Keller funnel, this, that, and the other, but of course, we don't use the Keller funnel. That's a different matter. So, okay, now I don't know whether you can see this.
Yeah.
Can you see my finger?
Yes, sir. We can see, sir.
Dr. Rao, can you see my finger?
Yes, sir. We are able to see.
Yeah. So I don't know whether you can see the extent of the pocket, but this is where my camera, please. Yeah. So I'm at the lateral extent of the pocket. If you see the line, can you see the line there?
Yes, yes, sir.
The lateral line, can you see?
We can see the elevated tip of your finger probably on the
Yes.
left.
Okay. So here, that's where the lateral line is. I've gone up to the top. I'm here. Can
Yeah.
you see that?
Yes, sir.
Yeah.
Yes, sir.
I've gone up to the top. I've gone up to the medial margins.
Sir, here I want to interrupt once again. Sir, what is your limit of medial dissection?
Yeah. So you want to keep 2 centimeters from the midline.
Okay.
Yeah, that is your ideal situation, 2 centimeters on either side of the midline. So
Okay, sir.
there is a gap of 4 centimeters between the 2 edges of the implant. But if that's not possible because the patient's chest width is narrow, the absolute minimum you must keep is 1 centimeter.
Okay.
Absolute minimum.
Okay, sir.
Yeah, because what happens is if you go more than 1 centimeter, as the implant stretches the skin envelope very quickly or very not quickly, very often you can get synmastia.
Sir.
And that's a terrible, that's a terrible result. And it's very, very difficult to correct. Yeah. So here again, this is the extent of my pocket. Little bit I need to do on the upper side. Usually you will find that, in a particular pocket, everything okay with the patient? We have not disconnected or anything, no? All right, all okay? Sure, na? Sorry, I'm paranoid about these things, that's why. So I'm not, yeah, just little dissection here. Yeah, cautery, please. So whatever bands you feel with your hands, that's the only thing you dissect out, and always use cautery. You're always tempted to use your finger, but you never know what perforator is there. You never know what vessels are there on the underside of your breast glandular envelope. So always dissect with the cautery. And we are using this really lovely long cautery tip. If Dr. Giri permits me, I'm going to steal it. Yeah, perfect. Chalo. Okay, I need a swab with sterilium, please. Sterilium, yeah, you have this thing?
Yeah.
Yeah, just, and then a dry gauze.
The incision we took from this medial.
Yes. Yeah, so the incision is along a tangent from the medial border of the areola.
The lateral border of the.
Yeah, no, so it's lateral to that now. So
Okay.
the place for the incision is depends on, you maximally stretch the breast and you see what the arc diameter of your implant is. So her inframammary crease was at 6.2 centimeters, but the arc diameter of the implant is 7.7. So if I were to take it in her inframammary crease, the incision would come on the breast, not in the new inframammary crease. So we have lowered it by 1.5 centimeters. Dry gauze, please. Chalo, can we open the implant? Okay, now to put the implant in, there are various methods, but the simplest method is to use a flat retractor. And we've gone through all the phases, personally speaking, through all the phases of using triple antibiotic solution, using gentamicin, using chloromycetin. Implant kholo na. We started with betadine, then we went to one antibiotic, then triple antibiotic. Then yesterday, Dr. Mainak was mentioning linezolid. We have not used that, but again, that's another antibiotic. Then we stopped using betadine because for some time people said, कि नहीं betadine से capsular contracture होता है. And there were a couple of reports from abroad as well. Then there were another 5-6 reports from abroad saying that betadine doesn't make a difference. So finally, in the last 5 years or so, we are back to betadine. I don't think it makes any difference at all. What makes a difference is probably hematoma or bleeding inside. What makes a difference is if you don't use powder-free gloves. What makes a difference is if you introduce a mop inside when you don't need to introduce it, because the fibers from the mop remain inside, and obviously whatever sterile environment is there, you're disturbing. That's the thing. But these things like betadine and all don't make. Please open it. Yeah. Okay. Okay. So we will have the box inside now. Yeah. So what we are using is a 280cc Motiva Corsair. Corsair is the highest profile. Once again, the base diameter of this implant is 10 centimeters. The arc diameter is 7.7 and the projection is 4.7. We had a choice between 260 and 280. उसके अंदर और एक रहेगा, so don't. Yeah.
Round, not anatomical.
Yeah, round implant.
And-
Dr. Misra, I have no faith in anatomical implants. I've used about 10-12 of them for slightly older foreign patients because they insisted on it. But I don't think it makes a difference at all. Because if you see a round implant, none of the implants, none of the manufacturers except one, which is actually Silimed, have fully filled implants. नहीं, saline लो, saline में betadine डालो और उसके अंदर ही डालो. Don't take anything separate. Yeah, so
it's textured.
they are about 85% to 90% filled, which means they are, if you keep an implant on the surface, it looks like a circle or a half circle. But the moment you hold the implant up, it will look almost like an anatomical implant. Yeah. So I don't think it really makes much difference. Then पहले saline डालो, please. Saline डालो उसमें. Put
Sir,
saline, use
smooths.
fresh bottle of saline, and then just add betadine.
Sir,
Yeah.
it's smooth or textured?
This is nano textured.
Okay.
Yeah. So that's a great question.
Yes,
Now
sir.
that we are a little aware of
LCL.
ALCL, and I mean, I did a presentation on this about just 3 weeks ago for another association. There are now about 800 cases of ALCL in the world. Out of those 800 odd cases, 650 cases are with textured implants. And all the deaths that have occurred from ALCL, of course, ALCL एक बार हो गया तो then it's a lottery, have been in textured implants cases. Bas, enough. Just mix it up, please. Mix it up. चलो, मेरे को बड़ा वाला सबसे लंबा आपका रिट्रैक्टर चाहिए.
No antibiotic in that.
इससे लंबा है? इससे लंबा राइट एंगल रिट्रैक्टर है?
No antibiotic in that.
No antibiotic. Yeah. Can you bring it here? Let me see if you can see it in the camera now. Can you see the implant? Yeah. So this is basically saline in which a little bit of betadine. Perfect. ये शायद इसमें बैठेगा नहीं. थोड़ा नीचे ये वाला है.
एक size छोटा.
नहीं छोटा मतलब breadth में छोटा है. रहेगा तो. नहीं है तो give me the last one. ये वाला ये give me this one. Use it.
Ordinary betadine, sir, from the bottles we hold.
Yes, simple betadine. Yes, ordinary betadine. Okay, Giri, I'll not.
Dr. Chandru here, sir, is asking whether it is autoclaved betadine.
Autoclaved betadine, I don't know. Is there any such thing?
No, nothing.
Okay, yeah, I don't know whether you can see now. So our mantra now is, I think we should put a patent on it. Out of packet and into pocket. Out of packet and into pocket as soon as possible. Yeah, and only one person handles the implant.
Yeah.
Easy to lift that. Okay, you can see my incision, and you just use your fingers. Some people use, they cover the entire breast with. Lift it up, please. lift, Giri, can you just, yeah, sorry about that. Yeah. Okay, yeah. Yeah, sorry, किससे? Keller funnel जैसा. Yeah, a Keller funnel you can use. See, our issue is economics. Of course, you can, your Keller funnels are available. Each Keller funnel costs around 4,500 rupees. And you're going to use it for 15 seconds. How much time did I take to put the implant? Yeah, so yeah, and whether it's really as a something that is, helps to for sterility purposes. Yeah, I think the biggest advantage of the Keller funnel is that it pays the bonuses of the CEO of the company that manufactures the funnel. Okay, so that's how the implant is sitting. And the good one thing that you should see, I don't know whether the camera can make out, you can't see the implant in the incision. Yeah,
Sir,
it has
yes.
to go up.
Yeah.
It has to go up. See, the implant is here now. I'm pulling the whole thing up, and the implant is there. But when I pull this down, the implant can't be seen in the incision. So yeah, so you need to make sure that that is the case. So one is done. Now we are going to fix the inframammary crease. Now, why are we fixing the inframammary crease? Because we have gone through the fascia. We have gone through the superficial fascia of the chest wall, and there is a possibility that there will be a downward migration of the implant, which is called what? What is it called?
Bottoming out.
Implant migration bola. When it goes under the fascia, what is it called?
Under the fascia.
What is the term for it? Bottoming out. Correct. So you get bottoming out, right? So we don't want that. So what are we going to do now? 30 PDS, please.
So you said to infiltrate.
Yeah, good idea. Okay. Okay. All right. 13 degree means endoscope, is it? Okay, perfect. That will be perfect. Chalo. Can we just infiltrate the other side and keep so that it's ready for us? So any questions on this? Any comments, any criticisms? Most welcome.
No, sir, it's nice to see that it is such a small incision you were able to put the implant. So
Yeah, so it just requires a little bit of patience. One thing that Dr. Kalra had shown me, I'm sorry I didn't show you in this, which I don't know which makes a difference or not, Dr. Rakesh Kalra. But
yes,
he had this theory that when you dissect the pocket,
sir.
air goes into the pocket. So before you put the implant in, you should suck out that air. And
But
the air creates a resistance to the implant going in. Now, I have not found this to be true when the cut is larger or when the implants are small. But in larger implants, yes, it makes a difference to a certain extent. It is his theory, and I have a lot of respect for him. Probably, maybe there's something in that. Chalo, 30 PDS, please. Okay. So now this part I really hope you can see, because this is something we have started doing recently only, last 2-3 years. Yeah, I need a tooth for sir. Yeah. Yeah. Okay. Catch paw at the bottom. Okay.
Sir,
Catch paw. Chota wala dal.
manufacturer. You are talking about manufacturer.
Yeah. Okay. Can you see this, please?
Yes, sir.
Can you see the fascia?
Sir.
Under eye.
Sir, we were in the discussion of breast implant induced ALCL.
Sorry.
we were discussing about ALCL.
Okay,
So still, most of the aesthetic surgeons, they prefer this textured implant, though it is
yes, right,
so.
right, okay, yes, we were talking about that, correct. So, yeah. So the thing is, before I take these stitches, like I said, most of the cases that are occurred worldwide have been with textured implants.
Sir.
However, for the last 20 years or more, I think, India has been using textured implants, not in the same volumes. Yeah.
Yeah.
And we have never reported a case of ALCL. We have never had a problem with textured implants. However, there are some cases of unexplained seromas, some cases of unexplained capsular contractures, and we don't have the we never send our capsules for pathology. We never follow up and see what the seroma was. Do we send it for cytological examination? So on one hand, everybody here still uses textured implants to a large extent. But in case there's a problem now, if there's a medical legal issue,
Sir.
with what the world literature says, you have no defense. Because nanotextured implants are available in India.
Sure.
If they were not available in India and our patients were insisting on using them and we said, nahi baba, hamare paas nahi hai, only we have only macro textured implants, wo alag tha. But now most companies manufacture nanotextured implants, right?
Sir.
And they're readily available to us. In that case, we have to use them. Nanotextured or smooth, one of the two.
So, sir, you mean to say that amongst the textured implants, in terms of breast implant induced ALCL, nanotextured has an edge over the macro textured?
Very much so, very much so. Smooth and nanotextured are practically the same. There is a study by an Italian plastic surgeon, I forget his name now, of 5,000 patients and about 70 or 80 cases of ALCL among those patients, not 70, sorry, 7 or 8 cases of ALCL among those 5,000 patients. And he has shown that nanotextured and smooth implants as versus the macro and the micro textured implants, there's a complete sea of difference between the two. So you can continue to use textured implants, but in case there's a medical legal problem, you don't now have a defense. You have to, okay. So can I go to the next step?
Sir, please.
Yeah, so I don't know whether you can see it, but this is the fascia that I opened.
Yeah, we can see.
That's the edge of the fascia I've opened. Yes. Yeah. And underneath that is areolar tissue. I don't know, you can see that part. There's areolar tissue. So this is where the implant bottoms out. So I'm going to fix this edge of the fascia to the nearest rib. Just hope and pray that this does not bleed.
So, sir, you are reaching it to the periosteum of the nearest rib.
Periosteum of the rib. Yeah, can you see this?
Yeah.
Kadak stitch. No, it cut through. Yeah, don't pull this. Don't pull this. Don't pull this too much. Khali itna bas retract it.
PDS or monocryl? Suture?
This is PDS 30 PDS. Okay, can you see it? Kadak stitch. So you take one in the center. Fix that fascia. So there is no chance that the implant will slip under this and bottom out. The tip of the scissor. Don't use this. So one on the lateral side and one medial. We'll go medial first. Okay, now that you have a central fixation here, if you can find a rib on the medial side and the lateral side, all and fine, which I can here at the moment. Yeah. Okay. So some people say that once you fix this fascia to the this thing, closure of the fascia above that is not anatomical. But finally they are only layers. Yeah. So they will all adhere together. It doesn't matter. But bottoming out is a real problem. So the theory at the moment is that you are preventing the bottoming out if you take these stitches. Who knows, 5 years down the line, somebody will come with something else. Okay, now I'm between the ribs on the medial side, on the lateral side, but I've already taken those 2 stitches, so I know this is going to adhere down. So I don't go for a rib higher up unnecessarily. I just fix this down to whatever pectoral muscle that I can find here. Doesn't matter. Doesn't matter. Okay, so that's our fixation. And now we are going to close this with 2 layers of PDS. 30. Yeah, side in the corner. You can take this as interrupted or you can take this as continuous locking. The first layer. We tend to do it with continuous locking sutures. The 1 minute. Yeah.
Morning, sir. I'm Dr. Ruchi. I wanted to know what is your experience with anatomical implants, the teardrop implants, advantages or disadvantages of it?
Yeah, so I really don't see any advantages. They have an advantage in older patients who do not want upper pole projection, want a more natural look. But the disadvantages are many. You know, there's a chance for the implants to rotate. You don't get very good upper pole projection like that's like the the disadvantage we already mentioned. They are very expensive. If a pair of round implants cost around 42 to 46,000 rupees, anatomical implants cost around 65 to 70 for a pair, at least at the moment in India.
Okay.
But yes, there are some indications like older patients who want that typical westernized ratio of 45-55 that people talk about. I have not understood what that 45-55 is for a long time. Yeah, can you follow this?
Yes.
Sir, I have a question for you. Mainak here. I have a question.
Yeah.
Milind sir, can you hear me?
Yes.
Sir, that day Rajat Gupta sir was mentioning about smooth versus textured implant. So what's your take on smooth implants?
What's my take on?
Smooth.
Yeah, so smooth is very similar to nano textured. Yeah, that's
So
all right.
given a choice between a smooth one and a nano textured one, which
Yes.
one follow? In terms of cost, in terms of patient outcomes?
Yeah, if I was able to get smooth implants, I would definitely at the moment now, with how the evidence is, I would definitely use smooth implants.
Okay, sir.
You can show the left side ना अभी तो बंद कर रहा है ये left side वाले में we can
Sir,
अभी निकाल लो
Sir?
take it, sir. Yes.
In this patient, how do you calculate the volume of this implant?
Depends on what the patient wants. So if the patient wants, she said she wants to go from what she had was a small B. She wants to go to a moderate C cup. Now, small b to small c is approximately around 150 to 175.
Sir.
And if you're going to go to a moderate, that add another 75 cc or so to it. We have tried to convince her for a 260 because of that reason, but she wanted a 280 up to 300. Now, honestly speaking, we did not have a 300 available. at short notice. So 280 is what we went with, but I think she could have done quite well with a 260 as well. The other way to choose the implant is it has to fit within the patient's breast width. Of course, there are occasions in which you may not be able to do that, but ideally speaking, it should fit within the patient's breast width. And if that is so, then you have to choose an implant. For example, this patient's breast width we talked about, you have to subtract a minimum of 1 centimeter for skin thickness.
Sir.
And that's how we arrived at the, something that has a base diameter of approximately 10 centimeters.
Yes, sir.
Okay, so that's my first layer.
Is the picture clear? I think they are showing the endoscopy just ask. Clear है लग रहा है. Is the picture sir clear now? पूछो उससे फोन करके. लाइट वो वाला.
नहीं
हाँ लाइट अप कर सकता है. नहीं ये लगा है ना लाइट. ये है ना. हाँ.
Good morning, sir.
Good morning.
Sir, one question, sir. What are the different tricks to get better cleavage? Some people, along with this augmentation, also go for fat grafting. Would you advise that, or what are you?
People do what?
So along with this augmentation, they
Yes,
go.
yes, correct. Yeah. So see, if you are going to achieve cleavage with only an implant, then the breasts need to be close to each other. You cannot achieve cleavage because, like I said right in the beginning, the implant has to be sitting on the with the nipple areola centralized. Yeah. If that is so, then depending on the patient's anatomy, you are not going to get cleavage, or you're going to get some kind of cleavage. But important to tell the patient is that cleavage is usually formed by the bra. The bra pushes the two breasts together, and that is how you get cleavage. There are very, very few women who will have a natural cleavage when they're not wearing a bra, unless the breasts are large. Yeah. And of course, if you want to create the cleavage, like I said, implants may be able to give you a better cleavage than they had before. But otherwise, then you have to go to fat grafting, which is what is called hybrid augmentation.
Yes, sir.
Yeah. Now, yesterday, when we were planning this case, there was a question from one of the young ladies here about when to do the fat grafting. So yeah, so if you have experience, you have a decent amount of experience with implants, you can do the fat grafting at the same stage. But we prefer to allow the implant to settle first. And then in about 3 months' time, we plan to do the fat grafting. The reason for that is also been proved by some studies. It is that when the capsule forms, it causes angiogenesis. There is a lot of angiogenesis going around in the subcutaneous tissue and in the the general area of the implant.
Sir.
And this angiogenesis lasts approximately for 3 to 6 months as the capsule settles into place. So that is really the ideal time for you to take advantage of that angiogenesis and put fat there, because of that increased vascularity and angiogenesis that is there, the chances that your fat will survive are much better.
Sir.
I hope there was some kind of logic to that answer. Okay, I need the 15 number blade now once again.
Sir, since regarding this, sir, company means Elargan, Motiva, and Sabin, whatever the study is going on, this most of this ALCL is noticed in the Elargan.
Can't hear him again. If you can understand, just.
Sir, again, please.
Sir, am I audible, sir?
Yes.
What Dr. Mishra wanted to ask is, it is reported that most of the breast implant associated ALCL is seen with the implants manufactured by Elargan. Is it so?
Yeah.
Any
That is true.
clinical
That is
significance?
true. Yeah, Elargan also, there is another company called PIP. that has also been implicated. And there are some from Silimed as well. And most of them, like I said, are textured. Now, if you know, sitting in India, it's all right to say Allergan made it. If you are in the US and they say that Allergan implants are responsible for ALCL, they will make sure that you practice is shut down.
So,
Blade, please. It's a very powerful company, and I think those who use Botox and fillers in India know.
Sir, so is there any incidents of such thing that surgeon is in trouble by this ALCL after using this implant? This medical point of view, I'm telling, sir.
Surgeon is in trouble.
Sir, after this,
Okay, now let me finish this step, then I'll answer your question. So every time we do a breast through an inframammary incision, we freshen the incision. Yeah, without any this thing. However delicate, however great a surgeon you are, however delicate your work is, always freshen the incision, because this is what will give you trouble. So in this case, I'm afraid there are a couple of cautery burns there, but that's not the reason why I'm freshening. Always about 2 millimeters of the edge of the incision is to be freshened. I need a 40 monochrome, please. And please take this time to do this, because very often you will find that this is the difference between an implant incision settling without any problems and getting ischemia at the edges, and then you're having trouble with the implant.
sir, have you ever come across the poor scar in this inframammary incision? Of course, when you
Yes, of course, 100%. All kinds of scars. I've come across hypertrophic scars. I've come across thin scars. I've come across where the implant has sort of come through the incision. All kinds of things. Keloids, everything.
so this is one of your recommendation to reduce the scar.
Yes. Yeah, so this is really to make sure that you have nice fresh edges. You don't have bruised edges when you do this thing. 40 monochrome, please.
So do you recommend post-operative scar management,
Needle holder hai?
gel, massage, and compression?
Yes, yeah. Okay, that's a good question. Right. So what we do is for 3 weeks, we don't ask the patient to do anything.
Sir.
At the end of 3 weeks, the patient starts a massage program, self-massage, of course, and you teach the patient to do it. You tell the patient to do the massage quadrant by quadrant. And the way to do it is that you tell the patient that there are 2 parts of your hand. There is the monocryl hai?
Yes, sir, died.
Okay. Yeah, so there is the fingers and there is the palm.
Yeah.
And if you put your hand across your chest, or the lady puts her hand across the chest, the right hand works for the left breast and the left hand works for the right breast. And if you put your right hand across your left breast, you will see that the fingers cover the outer part and the palm covers the inner part.
Yeah.
So now you divide it into quadrants. The outer part you massage with your fingers, upper outer quadrant, lower outer quadrant, and keeping the hand the same way around the breast, with the palm you massage the inner quadrants. And you do 25 repetitions twice a day. It takes about 7-8 minutes to do this. Now the beautiful part, which is the most interesting part. I don't know whether this helps at all, but it gives the patient something to do.
Keeps her busy.
Keeps the patient busy.
Yeah.
Whether it helps the capsule to settle into place, whether it prevents capsular contracture, I don't know. I really don't know. I'm always a little cynical about things. This is one of the things I'm cynical about.
So nowadays you recommend all your patients to start breast massage. Sir.
So I'm looking from underneath.
या
संतन
क्लीन करके
clean करके दे।
दोबारा
संतन सर का थोड़ा फॉग हो गया है।
I've got used to the loop.
सर को थोड़ा फॉग हो गया है, लुक आप थोड़ा साफ करके दे दीजिए। हाँ।
Yeah, पीछे से can you just take it out from here? Yeah, thank you, much better. At least I can see what I was looking for underneath. Okay, now it's up to you to close this completely and go to the other side. We prefer doing this, but you can finish the second side, close, and then go back and do this monocryl downwards. Subcuticular 40 monocryl. At the end, it's up to you. But the freshening is, at least in my opinion, it is non-negotiable. You must do it.
Is there any advantage of this bar stitch on this about this simple stitches?
Sorry?
Bar stitches.
No, not really. It's just something that we have got used to doing, and there are no stitches to be removed. There is, we are quite certain that the monocryl will stay for at least 4 to 6 weeks. So there is an additional little bit of strength to the suture line. That's about it. But yeah, please, no problem with whatever sutures you want to use and whatever sort of. But as far as possible, 3-layer closure, 2 layers of either PDS or monocryl inside.
Sir.
And 1 layer of whatever you want to use on the skin or under the skin. Yes, please.
Meaning it is good morning, Dr. Chaudhary from Cuttack.
Hello?
Good morning, I am Dr. Chaudhary from Cuttack.
Yeah, thoda niche kar sakte. Yeah.
Did you have any time, any problem?
Good. Thank you so much. Yeah, Professor Chaudhary साहब कैसे हैं आप?
ठीक है, आपको गुड मॉर्निंग कर दिए पहले.
Good morning, sir. Good morning.
Thank you. I think you became one of our faculties in Odisha. So we have been very frequently coming and doing great job for us. All our residents are very much pleased on you, on your live operative, because I am also very much fond of this live operative workshop. It gives a lot of teaching to the students rather than whatever videos they see. This is much better and it is more educative than that. Anyway, my question was, is your backup system, by chance the implant has any problem on the table? So do you keep extra, or it is okay always to have one of one side and for both sides you do two, it's okay?
You are saying that should we have more implants stored?
Yeah, should have backup, have an implant with you. It may not be needed because all time in any case we keep a backup. In this requirement at any time we had such problems. Because I had my experience with tissue expander and it was a big issue that tissue expander on the table, it went wrong and the patient.
So, okay, ideally speaking, Chaudhary Saab, we tend to keep 3 implants in the OT.
Yeah.
We keep based on what are the ideal implant that you have chosen. Let's say for this patient, the ideal implant was 260 cc.
Okay.
So obviously it's all availability also, whether it's Mumbai or whether it is Bhubaneswar or Orissa, it's availability. But if they are available and the inventory is there, if the patient's choice was 260, I would keep a 240 and a 280, both in the operation theater.
Yeah.
One size above, one size below.
Right.
And then depending on the dissection pocket that I've created and what I feel is going to fit properly in the pocket, that is what I would use. Okay, so now in our protocol, at least we bring this out little farther away from where the incision is and we just create a knot there. And at the end of around 2.5 weeks, this knot is just cut because the monocryl has served its purpose. Everything has healed nicely. Yeah, around 16-17 days, we just close this off. Chalo. Can I come that side for that side? Yeah. Okay. Now, a lot of surgeons prefer to operate from the same side. That's entirely up to you what your comfort is. But it depends. You can. Infiltrate किया था ना?
Sir,
चलो,
do you
blade
have any experience with the saline breast implant, sir?
या ऊपर का लाइट हाँ.
कैमरा कहीं गिर गया नहीं कैमरा 80 फोकस पर एंडोस्कोपी
40 चेंज कीजिए, इतना लॉन्ग नहीं चाहिए.
अरे एंडोस्कोपी टाइप को तो फोकस करो
ब्लेड
प्लेट का जिसको 40 प्लीज. हाँ वही.
Sir, you are changing the side or operating from the same side?
नो सर
I'm come to the other side. I prefer that.
Sir,
One more action.
sir, I was asking, do you have any experience with the saline filled implants?
Yes, I have done a few, but I feel that gel implants are more
Better.
definitely superior.
Okay.
I don't think there is any place for saline fill implant, unless you are doing them in cases where there is a asymmetry, there is a congenital
Yeah.
difference in the size of the breast, or one side hypomastia or something like that, where you can get a little more accurate this thing when you fill it with saline. But other than that, there are all possible disadvantages
Are there with
of
SL?
saline implants. The rippling is there, the possibility of deflation.
Yeah.
All those things are really disadvantage rather than advantage. Blade देना जरा एक मिनट. Blade देना. Blade.
ठीक है ठीक है ठीक है
और अभी ये लाइट इल्यूमिनेशन करके रहता है.
नहीं वो लाइट वो अलग से ये एंडोस्कोपी कैमरा है तो दिखा दिखा ठीक है उधर से दिखा
चलो. Hold. Ready?
नहीं आ रहा है कैमरा ये कौन हो रहा है तो दिखा
Catch pole लगेगा.
हाँ कैच पर प्लीज. 2 कैच पर.
इसमें दिखा रहा हूँ नहीं किसके लिए
I'll hold it. आराम से.
फोटो दिखाओ दिखाओ उधर ही था क्यों लेके जा रहे हैं ज्यादा कुछ
नहीं, don't stop bleeding again.
Sir, Milind sir.
Yes.
Hello. Sir, there's some of the young plastic surgeons, they just joined recently. So, can you please review your markings for this procedure? How, like you,
Okay.
on the other
Right.
side?
All right. Yeah. Just let go.
Starting-
So once again, this is an inframammary incision. There is a tangent to be placed from the medialmost border of the areola. So you come down from the medialmost border of the areola on this side, come straight all the way down towards the inframammary crease. Yeah. Your incision has to be entirely lateral to that. Usually we take an incision which is around 4 to 4.5 centimeters, not longer than that. And the placement of the incision in the inframammary fold or below it is dependent on what the arc diameter of the implant that you have chosen is. Now, what is the arc diameter? The arc diameter is when the implant is sitting on the chest wall, on the chest like this. If this is the nipple, then this is the arc. Can you see? Not a straight line down on the chest wall, but that's the arc. So in this particular case, the arc diameter at maximum stretch, we might measure it like this. We pull it up and then take for the distance from the nipple to the inframammary crease. In her case, her inframammary crease was at 6.2, but the implant we have chosen 280 has an arc diameter of 7.7. So we have lowered the inframammary crease by 1.5 centimeters. Now you can either keep it at 7.5, or you can keep it at 8. In an older patient where elasticity is a little, more laxity is there, you keep it at 7.5 because it will stretch. In a younger patient where the elasticity is good, which means that it's not going to stretch a lot, you keep it at 8 centimeters. Yeah, so that's what we have done here. Chalo, can we? Okay, so what you are doing now, we are going down to the fascia. I don't know whether the endoscope has made a difference. What we are looking for the fascia here. Aram se, don't this thing, because the vessels and all unnecessarily bleed then. Yeah, patient is moving. Giri, ये side में एक layer close करके, should we go to the breast reduction?
मैं ये सोच रहा था, अगर रिडक्शन चल रहे हैं तो जो इनॉग्रल पार्ट डायरेक्टर जो आने वाले हैं।
अच्छा, तो ये अभी कितना बजा है?
अभी 10 साढ़े 10 हुआ है।
Okay, so by the time we finish this, it will be 11 o'clock. 10:30 बजा अभी. What is the time?
10:30.
10:30. So we'll finish the dissection by 11 o'clock. We'll put the implant in 5 minutes. Then, if necessary, I'm going to close it. हाँ, आप close करो ना. One of the senior people can close. हाँ,
डायरेक्टर अगर आ जाते हैं 11 साढ़े 11 में, जब फॉर्मेलिटी खत्म कर देते हैं।
हाँ, तो अभी आधा घंटा रुको आप. 11 बजे जाओ. 11 बजे आप ये करो. Or you want to leave just now? You can leave. These girls are assisting perfectly fine. No problem. Yeah. Okay. Can you see this thing now? I have made a hole in the fascia. Can you see it through the endoscope?
Yes, sir.
Yeah. So that's where my fascia is. So I'm going to just increase that, and then I'm going to go under that. Aram se. Fascia जहाँ पे ये होता है ना, see the vessel there. Can you see that vessel? Yeah. You always find vessels just there. So unnecessarily they bleed. Today it's been lucky that we have not needed to use the bipolar at all. Otherwise, sometimes it's not easy. Yeah, you are doing as good a job as you can. Right? Yeah, no, you are doing. No, we have never been able to manage this. Never. Yeah, Dr. Aditya Agarwal and so many other people have asked me to make a video on breast augmentation का कैसा ये करो, endoscope try किया है, सब कुछ try किया है, वो होता नहीं है. It doesn't happen. Yeah.
Patient is bucking.
Yeah, it's moving again. We are all right with the tube and all, no?
Yes, sir.
Yeah. Sorry, I keep saying it, but I'm really paranoid. I'm paranoid. Tell me when I can start.
So in the meantime, I would like to know, sir, you said the size of the implant is measured by the width of the breast, sir.
Yes.
So the base of the implant, suppose 16 is the width of the breast.
Yes.
You see how much should be the base of the implant and how size of the implant? How do you make out that?
No, so there are different factors, right?
Yeah.
If the base width is 16 centimeters, if you subtract 1 centimeter, absolute minimum of 1 centimeter for the skin thickness,
Yes,
you are
sir.
left with 14.
Okay.
So the maximum width of your implant, whatever you choose, needs to be 14.
The base
The
of,
base, maximum, this thing. Yeah, depending on the profile of the implant.
okay.
The more the high profile of the implant, the less is going to be the base diameter.
Yes,
So
sir.
extra high profile implant will have the least base diameter, but it will also have the least it will also have the maximum projection.
Yes, sir.
The other side, a moderate profile or a low profile implant will have a wide base diameter, but it will have minimal projection.
Yes, sir.
Yeah. So that is the maximum this thing. And then it depends on what size the patient wants to go to, from what cup size to what cup size.
So actually, normally the patient wants the biggest size. So go for E. So what I want to know is, how do we say that this is practical, this is not practical? At what level? How do you logically justify?
Okay, yeah, that's another good question. So the average range of implants for a patient who is, let's say, like you said, your has a breast width of say 16 centimeters, which is unusual. 16 centimeters is quite a lot. But let's say this thing is 14 centimeters. So
Sir.
now you have 12 centimeters as the maximum diameter.
Yes, sir.
Now, most implants that we use in normal practice are between say 225 cc to 350 cc,
Sir.
right?
Sir.
So within this, irrespective of the profile and the base diameter of the implant, you are at liberty to choose. The
Sir.
moment you go beyond this, you have to counsel the patient that this is more than 350 grams sitting on your chest wall.
Mm-hmm.
And if there is more than 350 grams sitting on your chest wall, you are going to land up with a ptosis sooner or later, because these are heavy implants.
Sir.
Also, most patients who undergo breast augmentation, the younger patients who undergo breast augmentation because of hypomastia, have a tight envelope.
Sir.
The moment you have a tight envelope and you try to put in a large implant, irrespective of the profile, you're asking for trouble.
Sir.
Yeah, because the tension in the implant and the tension on the tissues is what is one of the factors for capsular contraction.
Okay. Yes, sir.
You are the expert, the patient doesn't know anything. The patient say, "Mere ko 500 cc ka implant dalo."
Sir.
Even if it fits her, you have to counsel her that this is not the way to go because this is a heavy implant. You're going
Yeah.
to have ptosis much sooner than you otherwise would have. And all the problems of having such a tight envelope and a large implant are going to be a cause of problems for you.
Sir.
Yeah.
Thank you, sir.
Yeah. अरे इसने तो आधा dissection कर दिया. Yeah, no, we want the slightly larger one.
IF sir today in the morning, Ashish sir told that it is endorsed in the IF. And it is used this.
Oh, very nice, very nice. That's very kind of him. Yeah. That's very nice of
So
him.
you can also inform.
Yeah. नहीं, only this side now. इधर कुछ करने का नहीं. Yeah, and lift it upwards.
Sir, आपने टेबल थोड़ा इंक्लाइन किया है?
नहीं, करना है? नहीं, one second. What I need now is you have to be at that level. Yeah, that's right. See,
Yes,
that's
sir.
what I meant by you already done the dissection. Now you're in that plane. लाइट चाहिए, अभी लाइट नहीं है.
लाइट इधर से लेके आइए, हेड एंड से, अरे फुट एंड से लेके आइए ना. ये वो लाइन इधर चाहिए, इधर इधर, मतलब वहां से अंदर आएगा. हाँ. सर थोड़ा सक्शन करेंगे सर.
Need a little better light.
वो लाइट केबल दे दो ऐसे, जो पहले ऐसे सिर्फ लाइट सोर्स यूज कर रहे थे. ये देना पड़ेगा. सर कनेक्टर यहाँ लग रहा है, रिफ्रैक्टिव है, इल्यूमिनेटर.
One second, I'll hold it. I'll hold it. Just get it in the center.
अंदर आओ, अंदर. So 1 second, I'll just use the cable. That will be better.
Yeah, just use the cable. Just need to see, get some light.
नहीं, थोड़ा सा और इधर इधर. ठीक है, ओके फाइन.
Okay, you're giving me that only? Okay, ठीक है, sure. नहीं, वो निकाल.
निकाल दो.
Yeah, can you hold that please? एक मिनट. Go on. One second, I missed the plane here. Can you hold this?
Yes.
Yeah, just hold this. No, hold, no, this
Okay,
one. Yeah, just 1 second. Let me just remove this.
कोई बात नहीं, take your time.
Light, no, just there is no light here. फुटपैड कहाँ पे है?
उसको छोड़ दीजिए, उसको सेंटर में लाइए।
फुटपैड इज आई थिंक फुटपैड इज देयर.
के ऊपर लाइए, ये लाइट फुटपैड है वहाँ पे थोड़ा दे दीजिए।
Can somebody press the footpad?
आकांक्षा वहाँ पे है। नहीं वो की तरफ दे दिया। अच्छा दे दिया। ओके सर ऑन योर लेफ्ट
हाँ, all right.
heading there, yeah.
Okay.
Right नहीं आ रहा है। better.
Yeah, one second.
No, sir, not pulling.
Yeah, bring the card.
Now I'm taking.
Yeah, एक minute.
Okay.
Yeah, and here. Bus. Perfect. Bus. Ready.
So थोड़ा सा लाइट थोड़ा अपने तरफ लाइए, नीचे की तरफ, नीचे बस की तरफ।
आराम।
Sorry.
One second.
Yeah.
Are you able to see through the endoscope at all? Are you able to see through the endoscope? चला गया वहां से, ट्रांसमिशन चला गया क्या?
हेलो ଆଉ ଗୋଟେ ମାଇକ୍ରୋଫୋନ ନାହିଁ କେମିତି ତମେ ଗୋଟେ ଧରିକି ଆସିଛ ଆପଣ ବାବୁ ଆଉ ନାହିଁ ମାଇକ୍ରୋଫୋନ ଗୋଟେ କାଳେ ଚଉଠେ
One second, I'll take this.
ଛାଡି ଦିଅ ଏଣ୍ଡୋସ୍କୋପିଟାକୁ ଦେଖ ଶୁଣ ଏଣ୍ଡୋସ୍କୋପିଟା ଯୋଉ କରୁଛି ସେଇଟାକୁ ଦେଖ ଦେଖେଇ ପାରିବ
Yeah, now this thing is
ଭଲ ଲାଗିବ
illuminating inside.
हुआ सामने देख
Morning, sir.
Yes.
Sir, many transgender patients are coming for breast augmentation. So, do you have any difference in position of incision or anything like surgical part?
Yes. Yeah. That was a question I was waiting for. I was wondering when that question would come. Can I just finish a little bit of there's a light here is a little tricky.
Okay,
Yeah,
sir.
एक minute. Give me 1 second.
So, no problem,
I'll
sir.
just finish a little bit of the dissection if you don't mind.
Yes, sir.
Yeah, because the illumination inside is just about enough. So I
Sir.
just want to get past the nipple areola while the light is still good.
Sir.
Bipolar. One second. Yeah. Okay. Yeah, so, yes. So as far as the incision is concerned, transaxillary is one way to go in transgenders. But otherwise, it's really the same measurements. What you have to understand that transgenders are basically males.
Sir,
Yeah. So the nipple areolar complex
it's very small in them.
is not only small, it is also lower and lateral
Okay,
in a male chest,
sir.
which is the first thing that you have to explain to them. Once again, the same funda. Lamba wala ye milega. That you as the surgeon has to centralize the
Nip,
implant on the nipple areola.
sir.
So the only way to change the position of the nipple areolar complex, if you want to do that and make it like a woman's, is to first put a tissue expander.
Ach, sir.
Yeah, put a tissue expander, get it to the position that you want, and then do this thing. But which in India, which transgender or which patient will agree to a two-stage?
No.
I doubt it very much, right? So if they're not going to agree to a two-stage augmentation, then this is what you have to tell them. Now, once you have done that,
Sir.
ये बहुत लंबा है, बीच वाला दो ना, बीच वाला एक था ना. So once you've done that, you basically the measurement is exactly the same.
Okay, sir.
Yeah, you know what is the, even if it's a male chest, you know that need to keep 2 centimeters minimum from the midline on
Sir.
both sides. एक medium size था ना, ये वाला ये इसमें डाल के दो. Giri, you want to leave? You go leave. Huh? Yeah, she will. I will hold anyway, and we'll do that. Okay. Left side is always a pain for a right side surgeon. Yeah, perfect. थोड़ा ज़्यादा इतना ये मत करो. I know it's not easy because the implant, the retractor is. Yeah. Give me that. Is the endoscope adding any value to all this?
Slightly better, so they can see the plane of dissection now. Light.
Light source. Okay, let's change the light source.
बड़ा वाला.
आप थोड़ा प्लेन दिखा दो. अंदर वाला.
Yeah, I don't know whether you can see with the light. Yeah, can you see the plane now? See the moist muscle?
Yes, sir.
Yeah?
Yeah.
Yeah, so the moist muscle means I've cut through the fascia. Otherwise, you would have the layer of white fascia on top of the muscle, which is the subglandular plane.
Sir.
So the problem with the moist muscle is that the moist muscle also bleeds. So
Yes.
that's where you have to be a little careful.
Sir.
And the other thing is the moist muscle is a complement to the anesthetist as well. It means that the patient is really nicely hydrated. I'm not trying to flatter the anesthetist, huh? Just saying. Yeah, this is good. अरे और थोड़ा नीचे आ सकते हो आप. Yeah, now I can see half of the this and here. But you show, that's all right, I'll manage. Or dissection is almost up to the areola is done. Yeah, just no, one second, sorry. Yeah, perfect. Yeah, just hold that. This is, yeah, I don't want to sound chauvinistic, but this young lady is doing a really good job. I think she's a strong this thing. I don't think I would like to arm wrestle with her. She's quite strong. This is not easy to do at all. When Dr. Dixit does a case and I am assisting him, at my age, I am struggling to hold his retractor up for more than 15-20 seconds. So she's doing a great job. Yeah. Can you remote? I'll just see the. Yeah. Okay. Now, if you see now, I've reached the medial limit. Can you see that? Can you see?
Yes, sir.
Yeah, you can see my line, right? So this is my medial limit, but here I've reached only up to here. So I
Sir.
need to go a little higher, and laterally, where am I? Yeah, laterally I've reached.
Yes.
This I have not reached yet. I'm just here yet. So that's the only part I have left to do. So let's put that back. Yeah. Okay. Can you see now my finger?
Yes,
Can
sir.
you see my finger?
Yeah. Yeah.
Yeah. Reach the limit here. I
Yes.
reach the limit here.
Yes, sir.
Reach the limit here. I'm right at the top.
Yes, sir.
Okay. So that's my dissection pocket. Not doesn't take a with good illumination, good retraction, should not take more than 10-15 minutes at the most. Good. And you don't want to make it too wide a pocket as well,
Sir.
because that's counterproductive. I have a little bit of distance to go here. It's very close to the incision. That is where sometimes the implant can get caught.
Sir.
पॉकेट नहीं बड़ा करना ही नहीं है हमको. Don't, एक मिनट, नो आई नीड दिस साइड में. हाँ, बस 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 एब्सोल्युटली परफेक्ट. थोड़ा बाहर निकालो, थोड़ा बाहर निकालो. The other trick is, you use your cautery tip like a dissector, and when you are in the plane where you want to put it, then you press the button.
Sir.
Otherwise, you use it like a dissector. We are surgeons, right? Very
Sir.
nice to be able to do that, and it's quite simple and easy. Chalo.
Sir, any
Now I am all the way to the side.
electrocautery, any Colorado needle or anything else or specific?
I am sorry, I didn't hear that question.
No, I am asking about here, sir, any specific needle tip for the electrocautery you are using?
Any specific needle tip you are saying?
This electrocautery.
No. It's an absolute normal. Can you see it?
Yes, sir. Yes.
Yeah. The only thing I have done, which I would advise you strongly to do, this is the end of a 8-number infant feeding tube. Yeah. So we just put it on that. Because when you have a cautery burn like we had on the other side, it happens usually at this junction.
Exactly.
So you only have a cautery tip here, which is, exposed here. This is plastic. This is plastic. Yeah?
Okay.
And this fits very nicely. If you try to use the original cautery, this thing, where is that blue thing? Blue था ना उसके ऊपर का टिप, नहीं blue उसके cover था ना, cautery के ऊपर cover. Sheath हाँ. See, this is what the cautery comes with.
Sir.
Right?
Okay, sir.
This junction is the problem. This
Oh.
is where you get this thing. And the other thing you will see is when I'm inside, see how easily I'm able to remove it.
Oh, yes.
Yeah, I've had a case where I've been lucky to escape because my assistant suddenly saw the blue tube there as I was closing the incision. Otherwise,
Okay.
I would have left that tube inside. But see this now. Can you see this? I cannot move this. I have to use a lot of force to open this.
Yes,
This
sir.
fits really well. Number 8 infant feeding tube. Chalo, can you open the this thing, please? Implant. Yeah. Sterilium चाहिए.
Retractor is meant only for this surgery.
Yes, yes, it's only for breast. No, you can use it for lat dorsi elevation. You can use it for gracilis if you're doing that. I mean, it's basically just a retractor. Sterilium, please. So this is just one step in our protocol. You don't really have to do this. Just cleaning around with sterilium and then making sure that it's dried. But of course, we have stopped using the cautery at this point. But you have to be careful when you use sterilium and if you're going to use cautery in the next step. So this is just drying off the sterilium. Just
Yes.
one additional step in trying to get it sterile. Chalo. Yeah. Okay. इधर थोड़ा घुमा सकते हैं कैमरा हो सकता है इधर या एक मिनट या so can you see now? I don't know whether you can see yeah 1 minute.
It's visible.
Yeah, this is our previous solution.
Yes.
That's where it's been removed from. Yeah, fresh saline. Just cover the entire implant.
It's normal saline or ringer lactate, sir?
Bas, normal saline. And just a little bit of betadine. Yeah.
5% betadine.
Bas, yeah. This is just, that's all. Chalo, like I said once again, out of packet into pocket. Retractor, please. No, not that one. Yeah, 1 minute. Can you hold this in your hand? Okay, yeah, up. Okay, so this incision actually is a little smaller than the other one as well.
Sure.
Let's see whether we are able to. I just need a. Yeah, up. Yeah, that's you need to correct. That's right. Thank you.
How we want to the breast receptor.
Create sufficient plane after initial facial dissection. Breast receptor. Excuse me, sir.
Yes.
So there's a question online from Dr. Sonal Banipal. She's asking, how about using a breast dissector to create a subfacial plane after initial facial dissection? I couldn't.
Yes. Actually, I have that instrument, but not everybody will have that instrument. That's why I didn't bring it. I have that instrument. Again, it's an expensive one. Yeah, Nikalo.
So I had a question. So
Yes.
after putting the implant in the pocket,
Yes.
do you check for, is there anything, you check the position of the implant, like there's a mark on the undersurface, it should come onto the.
Yes, very good, excellent question. So there is a disc on the underside. Okay, so what I'm doing exactly now is seeing where the disc is in relation to the nipple areola.
Okay, sir.
All right.
Bye.
And I'm smoothing out the edges. Chalo. Is the table tilted? Nine? One just needs to go slightly higher. No, no. Yeah, good. Good, sure. All right. Can you put that small cat's paw? No, sorry, not the cat's paw. This. Yeah, so that I can show them the. Yeah, don't press. There's an implant now in place. Huh?
Yes.
Don't press. Just hold it there. Okay, so I don't know whether now this time we'll be able to show you the step of PDS, please. Fixing the fascia.
Sir.
There is a 30-degree endoscope that is being used here. First leave it like that. Okay, let's see. Can you see the cat's paw, please? Cat's paw. though. Can you see that's the fascia?
Yes, sir. It's
Yeah. Can you see the edge of the fascia?
yes, sir.
Yeah. And we are going to palpate. There's a rib here. So my first stitch, central one, we are going to take through the fascia. That's my stitch on the fascia. And I feel the rib. And I go through the periosteum of the rib. Cut through. Be careful with the implant. Huh? Be careful with the implant. Yeah, I can see it. No, I can't see the needle.
Sir, do you have any specific consent form for this augmentation mammoplasty or the same?
Yeah, we have a specific consent form for everything. Because
Sir.
this blanket consent form that you have is ideally not suitable for aesthetic surgery. So we have a form that we have modified from the American Society of Aesthetic Plastic Surgery. Certain things we have removed from it.
Sir.
Certain things we have kept.
Do you have somehow in this this consent form? Do you have for this patient? Have you used this one, sir? This consent form?
Yes, they have taken it as per the IAPS. This thing. I can't see the. Scissor dena.
वो तमें अच्छे कौन बहुत
Just cut that at this point. There is some bleeding there. ये पकड़ेंगे जरा एक मिनट. Bipolar. So that particular consent form, a blanket consent form just says that breast augmentation on this such a person, and it has been explained in a language you understand all that. But an ideal consent form should also explain all the common complications.
Including AICL, sir.
Sorry?
Including, sir, ALCL also, you have to mention this carcinogenic effect.
Yes, including ALCL. My colleague for a long time in Sion Hospital, Dr. Mukund Jagannathan.
Sure.
I have a lot of arguments about this. He's one of my closest friends. He also wants us to take consent for death on table on all cases.
Okay,
So I always tell him that, if we do this, then we will be plastic physicians. Won't be plastic surgeons. We will never operate.
Sir.
But that is the extent to which, the paranoia and the worry has gone now.
Exactly.
पता नहीं क्या होगा.
Sir.
Little bit of where I took the stitch through the periosteum, no, a little bleeding on the rib. I'm just trying to control that, but I don't want any hematoma in the bed. Light नहीं आ रहा है अंदर
Light.
बिल्कुल.
ये वाला थोड़ा focus कीजिए, right? नीचे नीचे नीचे. हाँ. Right.
Yeah. This struggle will only be with this operation. Most other, everything is on the surface. So hopefully we should not have the PDF, please. Okay, that's my fascia. Can you see the fascia here?
Yes.
We'll try
Okay.
once again without causing bleeding to at least take one stitch through the periosteum of the rib. Chalo, Jai Bholenath. At least this did not bleed. Okay, so we are just going to get that tagged down. Means that now the loose areolar tissue between the fascia and the chest wall has been tamped down, and there is no place for the implant to go and bottom out by migrating downwards.
Exactly.
That's the theory, yeah, Raja. That's the theory. Actually, another 2-3 years they will say, "Arey, why are you doing this? That's not necessary." ऐसा ही होता है. Go down. But at the moment, this is what they are telling us. Since we follow that as well. Yeah, abhi laterally. Can we just move laterally? Yeah. Itna खींचो मत, just retract. ये क्या है? This is the previous one. Scissor. You cut that. The one that we said is, yeah, cut. Okay. This fascia here.
Light.
Light, please. Is there a rib here? Yes, there is a rib, edge of a rib here. So we'll just go through that periosteum and we'll fix the lateral side. Any other questions while we are closing?
Sir, I have a question.
Yes.
So I have a question. Sir, sometimes during the subfascial dissection, we are missing the fascia, some part actually on distal. So what is the upper part and some times in our journey? So what is your techniques advice or suggestion to us? So while intact without using the endoscope or something?
No, we don't use the endoscope. This is just to show you guys.
Sir.
We don't use the endoscope. It's all under vision, no?
Sir. Sir, another thing, sir, I have gone 1 year fellowship under Dr. Manoj Khanna. Sir always takes circumareal incision so that his advice is he can visualize all the parts, sir. What is your view, sir, on that?
You can visualize all the parts. No, actually, I would have to disagree with Manoj on that.
Sir.
The perioral incision is, yes, taken by people who are a little more skillful for sure. But the exposure is not as good as with a submammary incision. This is a direct, beautiful undervision dissection.
Sir.
There you are, and the other argument or the other problem I have with periareolar is that you have to dissect through glandular tissue.
Okay.
You say you are in the subcutaneous plane, but you are dissecting through glandular tissue. The moment you are dissecting through glandular tissue or breast fat tissue,
Sir.
I am not happy about the sterility.
Okay. But sir, I have seen no infection Khana sir ke paas, sir. I'm
Yeah,
not,
so he's lucky.
sir, another
No,
thing.
I'm not trying to joke or anything here. That's the way he has been trained. So does Dr. Ramchandran from Chennai. Yeah,
Sir.
he also does periareolar route. It's one way of doing it. And if he's getting good results with it, nothing like it.
Again, sir, another thing, right now I'm working with Vibhuti Naik, sir. He always
Yes.
take dual plane, always takes. So, what is your
Yeah, okay, एक minute ना समझ के just don't want to go through the implants.
some parts of muscular and some parts of facial? Dual plane, sir. Sir, what is your dual plane?
That's another way of doing it. You always have your muscle covering the upper part of the implant, so you have a good, nice soft tissue padding.
Yes.
But my how shall I put it? Vibhuti is my argument against the dual plane is that most of these women that come to, at least in my practice, they
Sir.
are slim and athletic women.
Yes, yes,
And
sir.
when I'm doing dual plane, I have to cut the muscle.
Yes, sir.
Post-operatively, that is quite painful, and their muscle really doesn't go back to absolutely normal ever. So if it's not necessary, I will not do it.
Sir, have you any time gone through the auxiliary approach?
Yes, I have, because once upon a time I was young and dynamic and foolish, and I have repented. Because with the transaxillary approach, at least in my hands, I always found that the implant was landing up too high.
Sir.
Yeah, the dissection was very easy up to the nipple areola. Then for the next 5 to 6 centimeters, it is hard. And beyond that, to get to the inframammary crease, it is nearly impossible. So there is always a tendency कि अरे हाँ बहुत हो गया, अभी काफी हो गया, चलो इधर डाल देते हैं. So there is always this thing, and the world authorities on people who describe the transaxillary approach also have said this, that this is a problem that they have faced themselves. When the scar is in the inframammary crease, I have actually I don't know. I mean, maybe I'm a dinosaur. I have not understood this obsession with hiding scars. You require good access. I think that overrides anything else. There are a lot of people I meet in Mumbai. No, just this side. Who take one single incision for liposuction and do liposuction of the entire abdomen through that single incision. No, let go of this. And they're struggling. They're struggling, but they're fighting, and then at the end they'll proudly tell the patient, "Arey, मैंने सब कुछ एक incision में किया." I have not understood that. I'm sorry, but I have not understood that. I want access. I want to do a thorough job. I will try my best to hide your incisions, but my priority is good access.
Sir.
बाद में patients, if there's a problem, patients don't give you rewards. They give you abuses.
But again, there is a transumbilical endoscopy.
Yeah, there is there's a question here about tuba, transumbilical breast augmentation. That's ridiculous. It's absolutely ridiculous. Of course, that can't be used for gel implants. It's only for saline implants where you roll them into a tube and you put them like a cigarette into the pocket. But I think that's too much. That's taking things to a level that is simply not necessary. Yeah. Chalo.
How many patients came with this something with a scar? ये दिख रहा है.
So yes, so there's a good question here. How many patients finally come and tell you and complain about this scar? This is a 4 centimeter scar. You have freshened the incision, it heals well. And if I give you a talk on breast augmentation in the evening, I don't know. I will show you the scars at the end of 6 months when they're well settled. Of course, we already talked about hypertrophic scars and those things happen. But the normal scars that we get, they are invisible as long as they are in the inframammary crease. Okay. Now, one thing I want to point out in both in this patient also. Can you see her now? You
Yes,
will
sir.
say that the scar has ridden up on the chest wall, on the breast.
Yes,
It
sir.
is not at the inframammary crease. But you know what the reason for this is? It's that suture that we took on the fascia,
Okay, okay.
right?
Yes,
So
sir.
we have fixed that down. That's why this looks like it's pulled up. But when the breast settles, see this is what happens. Now, can you see it?
This is not visual. Yes.
Yes. So that's what happens. So by measurement, you have done the right thing, and that when everything settles down, it will come back to normal. But you initially only take the incision in a wrong place, then that's a problem.
Sir. Sir, have you any experience on Brava expansion?
Sorry?
Brava expansion, sir.
Yes, I've done one case. I've done one case when it was very, popular and Brava. Unfortunately, I did not get a full this thing. The patient was not compliant. She was
Okay.
so frustrated with the need to use. No. I've already broken the knot. She was so frustrated with the need to use it. The marks it leaves on the breast,
Sir.
the suction cups, all that sort of thing. But I think Dr. Dr. James Roy Kanjur has done 3 or 4 cases. So I had to abandon mine. The poor lady had bought the Brava apparatus from the dealer in Mumbai. In fact, I still have her Brava apparatus with me. But unfortunately, we couldn't finish it. Yes.
With fat grafting, how much augmentation can you do?
Yeah, so there is a question here, again, a very good question. How much can you do at a time with fat grafting? So if you are using as a hybrid augmentation, which basically means either the cleavage or the upper pole, then you can put about 80 to 100 cc in both places maximum, and try to get what you want there. But if you are doing it solely as a method of breast augmentation, then I think probably around 250 cc is the absolute maximum that you can do in one stage. You would ideally prefer to do maybe 200 cc and then after about 6 months do more. But I think we have done 230 at one time, and at the end of a year or so, we have had quite decent results. 230 is the maximum we've done in one shot. Other thing you have to understand, which is quite paradoxical, is that many of these ladies who don't want implants and want to do fat grafting, they're themselves very slim. So where does the fat come from?
Yes. That is a problem.
Yeah. And the ones who are older and who are likely to have fat have ptosis.
Sure.
And fat grafting is not going to answer your this thing of ptosis. So it's a really small subset that you can do only fat grafting as a method of breast augmentation. But hybrid is the exciting part, where earlier we were so scared कि इधर ये capsule के अंदर जाएगा, implant को puncture करेंगे. That is now, I mean, because now that most people have good experience with fat grafting, they know how to put fat in the subcute, how to use cannulas, the planes properly. That is quite exciting. And more we are getting patients who are convinced, or we try to convince about hybrid fat augmentation.
If the patient comes with a tuberous breast.
Yes. Yes, so tuberous breast is a completely different entity. There are multiple elements to the tuberous breast, and there are multiple grades. So most important thing in a tuberous breast, two most important things in the tuberous breast are to provide, to lower the inframammary crease, to provide volume in usually the medial and lateral lower quadrants, to lower quadrants, and obviously based on that increase the base diameter of the breast, width of the breast, and lastly, of course, get rid of that tight ring around the areola through which the nipple areola is herniating.
Yes.
But if of all the grades of tuberous breasts, you will find, I was just telling these young ladies yesterday, absolutely normal patient, what is called grade 1 tuberous breast, where the only deformity is that the distance from the nipple to the inframammary crease is less than 6 centimeters or sometimes even 5. You will find that नहीं ये मेरे को अभी मोनोक्रिल चाहिए
इसमें लगाओ
या हाँ ब्लेड देना प्लीज.
वो कैमरा main light.
So once again, same thing on this side. We are going to freshen the edges.
Main light का कैमरा bring it closer.
इसको
Bring it closer, दिखाओ सबको. अरे स्क्रीन में देखो ना. अभी स्क्रीन को फोकस करो. स्क्रीन को फोकस करो. उस स्क्रीन को फोकस करो.
ब्लेड दूसरा मिल सकता है.
फ्रेश ब्लेड 15 नंबर.
ठीक से दिखाओ. ठीक से दिखाओ. तो ठीक से दिखाओ.
Excuse me, sir.
Yes.
Sir, what about the complication if the patient has seroma or what? How do you manage that, sir?
Yeah. So first thing, if you feel that the seroma is an ultrasound,
Sir,
yeah, once you find out on this thing that there is if you have a good radiologist, you can try to carefully aspirate the seroma under ultrasound guided control.
okay.
Yeah, it's a little risky, chances of puncturing the implant and all, but that's why I meant a good radiologist
Sir,
who will show you where the implant is. Will show you where the seroma cavity is and what is the best area from where to aspirate the seroma.
sir.
Now let's answer this seroma thing. Okay. If that happens, are able to aspirate, then you always just give a little bit of compression and hope for the best.
Sir.
And obviously, you're going to send the seroma for culture.
Sir,
Yeah, because you can sometimes get subclinical infection and you will never know. But of course, sometimes the patient shows symptoms, sometimes they don't. So
sir,
if the seroma shows any kind of positivity in culture,
sir.
then your best option is to remove the implant. Yeah?
Okay,
You remove the implant, and if you feel confident enough, maybe give a wash and
Sir.
put the implant back, the same one or a new one.
In the
But
same,
if you- Sorry?
in the same setting when we are removing and clean
Yeah,
and,
that's what I'm saying. That's what I'm saying. If you feel confident enough.
sir.
But more often than not, the safe thing to do would be to just remove the implant and let everything settle down. Put the patient on a good course of antibiotics
Sir,
and go back after 3 months.
sir.
Now, whether you want to do it only on one side or two sides, obviously depends on what your findings are. But you can always leave the other implant alone and just have or wear pads inside her bra for those 3 months.
Okay,
If it's if your seroma is suspicious, is accompanied with pain, when you if you feel that there is any chance of ALCL, then you have to send it for cytology.
sir.
There are a few labs in the country now. I think I'm not sure. There might be one in Bhubaneswar, but probably all the metropolitan cities now have labs from where samples can go to test for ALCL. For sure, in Mumbai, Delhi, Bangalore, Chennai, Calcutta, I don't know, but there are labs which this in Mumbai there is Hinduja Hospital lab has that facility.
Sir.
you generally tend to get the report after 2 weeks. So the patient is under a little bit of stress and tension for those 2 weeks. There's not much you can do about it. On the other hand, if after the aspiration within a week's time the seroma collects once again you diagnose it with another second ultrasound, then you
Sir,
have a decision to take.
sir,
Whether you want to aspirate it once again and hope for the best, keeping your fingers crossed, or you want to go in and do something surgically.
sir.
What I mean is a seroma where there's been no culture in the no growth in the culture.
Yes,
The moment you have any growth in the culture, you have no option. You have to open.
sir.
Yeah. So that's it. Yes, the question here about Poland syndrome. Now there are actually it's actually a talk by itself, but the issue in Poland is it depends on whether the muscle is there or not, and how well the muscle is developed. If the muscle is present or to some extent it is hypoplastic, but it is there, then of course you do a subpectoral implant. Now what size the implant should be, that's another completely different, almost half a lecture. How do you decide what size of implant to take based on what the opposite side is? Because all those issues come. These patients generally come to you unmarried. They are young. And they are likely to get married. They are likely to, the opposite breast is going to increase in size, which is normal. So what do you do about that? How do you explain to the patient that that breast will become larger, while at the moment I am just trying to make the two breasts symmetrical in the present time? So all those questions are there, but otherwise there are 2 or 3 ways of determining what the volume is. Some simple ways, some difficult, some sophisticated ways. So there are softwares now available which will tell you, which your radiologist will have, which will tell you what the volume of the opposite breast is quite accurately, up to about 20 cc or so. But if he doesn't have that software, I am forgetting the name of the software, sorry. Once upon a time I used to know it. If it's not possible, the best thing is to create a mold, like a mold made of clay, and you put it over the opposite breast and create a complete clay sort of this thing, and you fill it with water. That's the volume of your this thing. The earliest way to do it was to use rice bags, bag of rice. But वो bag of rice अभी ever since PDS system started, the bag of rice is of no meaning. There is one way that is used by these people in, what's his name? I'm sorry, I've become so bad with names. Bill Adams. Bill Adams Jr. is a plastic surgeon in the USA. वो बीटाडीन इसमें डालेंगे, इसमें डाल दो और मेरे को खाली कप दे दो. Yeah. So this is what they use. Is the camera around? Yeah.
इधर दिखाओ. Hey, इसको दिखाओ. Cameraman.
Yeah. So
इसको दिखाओ.
everybody has this.
इसको दिखाओ.
Okay, on the other, it's turned around.
इसको दिखाओ. सर का हाथ को दिखाओ.
Okay, it's taking from the monitor. Can you see this? Hello.
Yes, sir. It's
Yeah. So this is what was used for a 280 cc implant, right? You can fill this with water and find out how much water this contains.
okay.
And you will have similar ones for smaller or larger implants, and you can cut them. You
Yes.
need not have this circumference. You can make it smaller.
Sir,
Make it smaller. You have a larger one as well, and then you
Okay.
fit that
okay.
and see
Okay.
whether it fits
Sir,
over this thing right up to the base, and that gives you an approximate estimation. So that fellow has got he's got six of these,
Sir.
from 160 to 200 to 240 to 280 to 320 of each of these.
okay.
This is a very ready-made way of making out that, if this covers this fully right up to the base, that's
Yes.
the volume of your breast.
Sir,
चलो अपने को अभी we need sterilium, we need betadine. ointment or T-back, whatever you use as ointment, आपका जो भी protocol है, mupirocin. And we need, do you use Fixomal here or Micropore? No, not Tegadam. No, I will use Micropore. Yeah. Normal, we'll do a normal dressing just to fix the breast in the area that we have put it in. 1 minute on this side.
Milan, can I speak? Can I ask you a question? Disturbing. Is it mandatory that one surgeon should do both sides or two surgeons can share?
Yeah, you can, sir, of course. It all depends, sir, how much you're paying your assistant.
No, because plastic surgeons, we have always a team, no? Many a times you do surgery, reconstructive surgery. Huh? So
Definitely.
you can save time and you can save.
Yes, absolutely. But
So
doing simultaneously, there are, you require 2 pairs of illuminated retractors, 2 cauteries. That's not easy.
you are right.
And you are likely to come in each other's way as well. And I mean, I don't want to boast about this. We do this all the time, but we finish breast augmentations about I think 45 minutes to an hour maximum. Bilateral. Today also, I'm not sure how much time we took. Chalo, sterilium, please.
So I just told Vikal is to be played like in cricket. Okay, one has to bat, other has to be a runner.
आप clean कर दो जरा. Don't remove this until we close.
Milind, can I ask one question?
Yes, please.
Do you hitch the dermis to the muscle on the chest wall to create a good inflammatory fold?
Do hitch to the muscle? No, we hitch to the periosteum of the rib.
Okay. To the periosteum, okay, it's good.
Okay.
Sir, I have another question, sir.
No, we'll just use straight away this only. There's no need for anything on top. Gauze pieces, give the dressing there, and then we'll just support the breast. I'll show you how to support the breast from the sides to prevent lateralization.
Sir, can I ask one more question, sir?
Please, as many as you want, as long as I'm able to answer them.
Sir, during this,
Ointment.
you have completed one side first. Next,
Yes.
you have next side. So, can we dissect both the side and then complete simultaneously?
Oh yes, absolutely. My partner, Dr. Dikshit, likes to do that.
Sir.
He'll finish one side, take the first layer of stitches, go to the other side, and then we close it simultaneously and save time. No problem. You can even, if you are confident about the sterility of your mops and all that, you can just put a mop inside. After doing the dissection, go do the dissection on the opposite side. Lots of surgeons across the world do that as well. No problem.
Sir, yes, sir.
This is just the way we do it. I'm sorry, this is just one, like they say, there are many ways of skinning a cat.
Sir, we are seeing this one. The right one looks a little bit more projected than the left one.
Sorry, I didn't hear you. What?
Right one is more projected than the left one, sir. In these conditions, in the here.
Okay, so it's 2 things are possible. One, because we've used the same size of the implant. One is that there may be a little tilt in terms of the camera. And the second is that, one side breast may have been a little larger than the other. But that's okay. It is rare to find a woman with equal, absolutely symmetrical breasts. And she didn't have too much asymmetry between the 2 sides for us to be putting 2 separate size implants. The proof of the pudding is I need two more layers of gauze. 2 more layers of gauze.
Suppose after surgery, a patient. Hello, yes. Sir. Can you, after surgery, if patient didn't agree with the size of the breast, then what surgeon should do?
Surgeon should run away. No, that happens. Quite often it happens that the patient is not happy with the But the thing is, that's why you should ask the patient to choose. Never make that your decision alone. All right. Anytime the patient says, "आपको जैसा अच्छा लगता है वैसा आप करो," don't do it. You have to reach that decision to about the size together, so that the patient is as much a partner in crime as you are. Yeah, one more layer, please. Gauze piece. हाँ, पोलैंड में अगर मसल डेवलप नहीं है तो you can't do much. You can, if you are very fastidious about it, you can transfer the latissimus dorsi, bring it to the front, and fix it. Now there are two ways of fixing the latissimus dorsi. One is in a single this thing.
One here, third one.
लगा? हाँ, okay. Chalo, everything okay? No problem with instrumentation. Everything is fine. No problem, right? Okay. Mops, gauze, everything is okay. All right. Yes, please. Yeah, absolutely. Doesn't matter. What do you use usually? Micropore.
Yes, sir. So sometimes actually we use tegaderm as well.
Put tegaderm, but इतना बड़ा tegaderm क्यों waste करने का? ये नीचे होगा एक बार प्रोजेक्शन दिखाना अगर
कैमरा टेबल पे होगा ना, एंड ऑन व्यू दिखाना।
कैमरा नीचे आएगा तो नीचे करो। Scissors, please. This Durapur is supposed to be easy cut, no?
Yes.
Sir, what are the post-op do's and do nots for the patient?
Yes, yeah.
थोड़ा छोटा काटिए।
Yeah, one second. Let me just finish the dressing. I'll answer that. Okay. Broad 4 inch वाला कुछ है? 4 inch का broad?
डायनाप्लास्ट?
No, Dynaplast. Even micropore 4 inch वाले चलेगा.
हाँ, बड़ा वाला माइक्रोफोन।
हाँ, projection आ रहा है. Sir, I'd like to dent it through the projection. Okay. On table projection. है micropore है? Everything okay ना? All pieces of plastic, everything come. हाँ, सब मिला है ना? Yeah. अच्छा, यही है. Okay, ठीक है.
टेगाडर्म एक बार दिखाइए।
You hold it.
Scissors, ये नहीं हाँ, तो ये पे
Cut. Yeah. Can you hold on to this?
Yes.
Yeah, just hold this. दोनों साइड से नहीं, दोनों साइड इधर भी. ये दिखाओ ये दिखाओ ये इम्पोर्टेंट है दिखाओ. सर लाइट प्लीज घुमाए मत सर.
हाँ, बस ठीक है।
एक ही जगह पर
ठीक है, हो गया।
एडजस्ट करके दिखा रहा हूँ कितना इल्यूमिनेशन. ठीक है, ओके. Yeah, okay, one sec. So what I'll show you that last step that we do. Usually we use 4 inch micropore or we use pixomal. This is the last this thing to make sure that the breast is not lateralized. And this we don't remove even after the dressing. Each time we do the dressing, we will put it back, right? So you take this thing, you press your breast medially and no, not Dynaplast hurts the patient and they curse you more for that than anything else. Yeah.
We are not able to.
This is how we medialize it. We make sure that this is pushed and for 3 weeks, this does not come out.
We are
Every time
not-
the patient comes for dressing, we will peel it off, clean everything and put it back.
We are not able to see. Yes.
Can you
Yes, sir.
see it?
Yes, sir.
Here we have Durapore. I don't know how this thing Durapore is, but it seems to be quite nice.
Yes, sir. Okay.
So this is, I think, a 2-inch one. So what we are trying to do is we are trying to make it into a 4-inch one. Okay. So you push the breast medially with the same this thing. And that's how it is. Okay, that's how the breasts are. Okay. Yeah. So now about post-operative way, until the patient is fully awake, whether
Sir.
you do the surgery in a dual plane with the muscle being cut, whether it's subfacial, whether it's subglandular, never put the sports bra on when the patient is not fully conscious. Where the patient does not feel pain, and you might stretch something and cause bleeding. Yeah, patient is not feeling the pain. The patient will instinctively feel pain and stop when the patient is fully conscious. So always put the sports bra with the patient fully conscious. Never put it in the operation table. Get a nurse and a doctor to put the sports bra. We usually use either. I mean, I don't know whether it's available in Bhubaneswar or elsewhere. The best sports bra I have found is Mark and Spencer. Yeah, Marks and Spencer. But if you don't get that, then there is Jockey, there is Adidas, and what is the third one? No, Lipomed is basically called liposuction. I've forgotten the third. One of the sportswear companies. No, Adidas, Puma, correct, Puma. So those three these things are there. And what the best, the important part about a sports bra following breast augmentation is two things. One, it should have a very broad band at the bottom, which should support the lower part of the breast. And it should be as tight as possible towards the side. Yeah, so broad band at the bottom underneath, and should have tightness on the side, which once again medializes the breast. And it should be worn with a zip or a hook in the front. Never make a patient wear a sports bra where this thing is behind, because that itself also stretches. Yeah, and the patient is not able to. Even if a woman, somebody else is doing it for her, there's the instinct of stretching the chest to put the thing behind. So always wear a sports bra with the zip or the hook in front. And it's supposed to be worn for 4 to 6 weeks. At 3 weeks, like I said, we tell the patient to start a massage, do a self massage, quadrant by quadrant using one hand. So the way it works is, now that I think I'm in focus here now, this is how it's sitting on their chest wall. Your fingers are on the outer half. Your palm is in the lower half, in the inner half, medial and lateral. So just keep it like that, not like this, cupped around the breast. And with the upper part of the fingers, you massage with circular motions, upper outer quadrant. Turn the hand, lower outer quadrant. Keep the finger straight again, once again on the breast. Now with the palm, you are massaging the inner quadrant. Same, turn this thing up, massaging the outer quadrant, and it sits naturally. The opposite hand, you can't use this can't be done. It has to be the opposite hand. So do that twice a day, 25 repetitions in each quadrant. It takes 7 to 8 minutes, and tell the patient to make it a routine part of our life for the next 3 weeks. So after 3 weeks after surgery, 3 weeks beyond that. So you're taking it to 6 weeks. By 6 weeks, we expect that the capsule would have nicely settled and formed. Now, whether this helps or not, I don't know. I said this before as well. But you are a great doctor. You are a fantastic plastic surgeon because you have told the patient something to do. The patient feels very good about it, and massages always help. Yeah. So that's how I feel about it. I don't know whether they help or not.
We'll have a break for 15 to 20 minutes because director is coming.
Sure.
So we'll get complete.
Thank you, sir.
उसके अंदर मैं सोच रहा हूँ कल जो pre-recorded किए थे,
हाँ.
that can be shown to the
Yeah. Is the marking still there on that patient after the bath and all that?
pre-recorded है sir.
नहीं, मार्किंग अगर करने का रहेगा तो नहीं, क्योंकि अगर मार्किंग किया रहेगा ना,
ये वाला काम खत्म
नहीं संजय, मार्किंग अगर किया रहेगा तो दूसरा ओटी है हमारे पास कि इधर ही है ना, तो पेशेंट कैन गेट इंड्यूस्ड अगर मार्किंग है तो वी विल सेव टाइम. अगर मार्किंग नहीं है तो बट उतना भी सेव हो जाएगा ना टाइम। हम लोग उधर जाते हैं तभी तक ये ब्रेस्ट रिडक्शन का पेशेंट इंड्यूस हो सकता है अगर मार्किंग स्टिल है।
पहले देखो प्री रिकॉर्डेड वाला जो है
पर वो जो रिकॉर्ड किया है वो दिखाओ उनको, नो प्रॉब्लम, unless they want me to explain. So, ladies and gentlemen in the audience, it seems that we are just going.
Sir.
Because everything is on the surface, and it won't be such a struggle for you, you guys to see. Yeah, thank you so much.
Thank you, sir.
हेलो 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 बहुत अच्छे बंद बंद कर दो चलिए हैं कौन
अरे सारे अनाउंस गोटे देबे कि आरो पेशेंट रो वीडियोटा चलिबो बोली सर अनाउंस तो देबे
हाँ ओके ओके
আমরা ডাউন রিপোর্ট করব হ্যাঁ তো পুরোটা তাও পেশেন্ট কি দেখতে হবে
अच्छा
चेक कर दो मैं चल रहा है कि
हेलो 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 हेलो
ऑनलाइन काम नहीं कर रहे बोल रहे
अभी सब ये इसके लिए सब ये करा ना अभी अभी रेडी अभी बताए क्या बताना
ऑनलाइन लिंक काम नहीं कर रहे बोल रहे
कौन बोल रहा है
तो लिंक बोलो कैसे बोला है मेरे जूनियर बोल रहे हैं
उनको बोलो सर मेरे से बात करनी लिंक मैं आपको दे देता हूँ
लिंक मुझे बोलो
हाँ सुभाष सर देख लो सुभाष सर नंबर अच्छी बाहर पर
9821
नहीं नहीं आपका नंबर दिया सर मेरे पास
you tell you will have the inauguration in 10 to 15 minutes. In the meantime, we are showing the pre-recorded of the second phase of the marking. Just बोल दो उसमें इसमें बोल दो
चला गया सर रेडी रेडी सर आपको बोलना है ना रेडी 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 है कैमरा रेडी है पटे हां हो गयो तो सर कहले
केही नाहांती हले रे सब उठी पड़े से तो मत कहला केही ना सब पड़े
चाह पिए देखिए बड़े
मत इन 10 मिनट आगु कहला केही ना सब उठी पड़े रानी
हॉल हॉल में कोई नहीं है सर
हॉल में कोई
नहीं ये तो खबर है उधर से चाय पीने के लिए गया है सर चल ये लागी कि था उसे बढ़िया कैमरा ऑफ थी बस पड़ता
कनेक्ट हैला कनेक्टिंग
हॉल में अगर कोई नहीं है कौन देखेगा फिर
कोई नहीं है हॉल पे मैं तो कैमरामैन से पूछ रहा था कोई हॉल में कोई नहीं है
के चलेंगे अंदर जाके चाय पी गए
चाहता है पर मैडम को पहुंच रहा था मग सेदिन भी नेट देथिले जो पक्ष जे कि नेट देथिले मस्त उडुथिले अरे अरे
लाइन देखेंगे
हेलो तो पचलू
हेलो हेलो am I audible
yes sir audible
okay now we are going to display the pre-recorded video of marking of reduction mammoplasty
yes sir well, I'll just check it whether it is running or not sir because everyone has taken a break for tea sir for 15 minutes I think so
and meanwhile there will be an inaugural program over there
yes sir
Okay.
Sir, I'll just check whether the video is coming correctly or not, sir. After that, we'll start, sir.
Who?
Sir, I'm Dr. Reena, sir.
You can just call all of them inside.
Okay, after 5 minutes, we are going to start that display.
Yes, sir. Sir,
Pre-recorded that marking.
okay, sir. Sir,
Okay.
can you check it a little earlier, sir? Like, I wanted to check it now and then we'll run it, sir.
Once the people over there come into the hall, then let me know and we are going to telecast it.
Okay, sir. So,
हाँ 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 नहीं ठीक है टीवी ऑन थी वो
फिर हम वो
जी जी
जब
जी
बोलेंगे
जी
फिर
जी। हाँ उसके बाद में ये आप ये इसको भी ऑन करना पड़ेगा मेरे को जी सेटा ऑन थी वो सब
क्या ऑफ कर देता है
हाँ
सही था हाँ सारे पता चल
अभी बोलना है
Slide टा blank कर.
चलेगा ना? Okay, so the first thing mark is the midline from the clavicle down, straight all the way down. Right? The next is the breast meridian. So the breast meridian basically provides the breast into the lateral halves.
Esteemed dignitaries, a very good morning, everyone. I welcome you all to the live operative workshop on body contouring and aesthetic reconstructive breast surgery. We are in the inauguration session part, and now I'd like to invite our dignitaries. I would like to request our Honorable Director, Professor Dr. Ashutosh Biswas, a very dynamic personality and a backbone of AIIMS Bhubaneswar, to come to the dais. I'd like to invite our guest of honor, Dr. Milinda Swag, sir, ex-associate professor, Sarin Hospital, Mumbai, and senior plastic and cosmetic surgeon, PD Hinduja Hospital, LH Hiranandani Hospital, Leelavati Hospital, Breach Candy Hospital, Nanavati, and SL Rahija Hospital in Mumbai. To come to the dais. I'd like to request our organizing chairman, Dr. Sanjay Kumar Giri, to come to the dais. Thank you, sir. I'd like to invite our secretary, our professor, Dr. Ashish Patnaik, sir, to come to the dais. Thank you, sir. I'd like to request our Dr. Ranjit Kumar Sahu, sir, to come to the dais. Thank you, sir. I'd like to welcome our guests now. Yes, sir. I'd like to welcome our Honorable Director, Professor Dr. Ashutosh Biswas, sir, with a small token of bouquet. Thank you, sir. I'd like to honor our guest of honor, Dr. Milinda Swag, sir, with a bouquet. I'd like to honor our organizing chairman, Dr. Sanjay Kumar Giri, sir, with a bouquet. I'd like to honor our secretary of Professor Dr. Ashish Patnaik, sir, with a small bouquet. I'd like to honor our Dr. Ranjit Kumar Sahu, sir, with a small bouquet. Now we'll have our inauguration ceremony with the lighting of the lamp. I'd like to request our dignitaries to proceed forward towards the lamp and inaugurate the session with the auspicious ceremony of lighting the lamp. Now I'd like to invite our organizing chairman, Dr. Sanjay Kumar Giri sir, to come to the dais to have.
Respected Director Sir, Astas Viswas Sir, and Milind Sir, and Secretary Apraso Assis, and Organizing Secretary Ranjit Sir, and esteemed seniors and my teachers, all the esteemed Apraso members. It is my privilege to welcome all of you for this our live workshop on body contouring and aesthetic reconstructive breast surgery. And we are very happy to say that Sir has helped us to start this live workshop, and he told you go on, there is no problem. So we have started this workshop just 10-15 days back started, and we got the cases and started these three major cases which we are usually doing this aesthetics, mostly the augmentation of breast and reduction mammoplasty. And so I was just asking in a way what are these things, and I just was explaining. Sir was so that these things should be done, and abdominoplasty. So I was very keen to know what is abdominoplasty. So I was just telling a little bit of what is abdominoplasty. So in this way, I think we should propagate this aesthetic workshop, live workshop, and it is very. I am happy to also say that in the morning, Indian Association of Aesthetic Plastic Surgeons, they have endorsed this for education purpose, and they have told that this will be in the banner of IRs. It will be propagated as education of this to propagate this live workshop for education of aesthetic surgery. By this way, I welcome you. Thank you.
Thank you so much, sir. Now I would like to request our Honorable Executive Director, AIIMS Bhubaneswar, Professor Dr. Ashutosh Biswas sir, to say us a few words.
Good afternoon. Professor Milind Wag, expert in this field, and our team from the Bhubaneswar AIIMS Department of Burn and Plastic Surgery, Dr. Giri, Dr. Saul, Dr. Patnaik, for organizing this kind of live workshop, especially very important domain, reconstructive surgery, breast aesthetic or mammoplasty, and then abdominoplasty. Yes, these are very important domain. I think you need very skill and very sophisticated steps in the surgical management. So we'd like to, I'm very, very much thankful and grateful. Dr. Milind has given a very special time for giving the hands-on training to our expert, and then all the surgeons here for learning and giving his time and expertise to deliver the younger generations. So thank you, sir, for coming here. Really grateful, the AIIMS Bhubaneswar. And the participants who are here, I think you are getting opportunity, and our team, the Department of Burn and Plastic, taking special care for you to give full exposure to learn and to go back with the skill that you are expected from the AIMS Bhubaneswar and the department. So I think all the surgeons, they know what the knowledge gap is, the skill knowledge that you are going to achieve from this. And the expert is quite international. I think expert Dr. Milind is very much known. So he is here to, I think, very supportive to give you the skill of your the highly demanding the area, the reconstruction, the aesthetic, whatever, maybe therapeutic, the cost reconstruction of the breast, and then abdominoplasty, lifestyle, so many things due to you understand. So everybody wants fitness. All the parts of the body should be fit and good looking. So that's the one aesthetic part. So thank you everyone. Thank you the team and the participant coming here and learning about the great skill of the domain. Thank you very much. Thanks all.
Thank you so much, sir, for encouraging us so much. Now I would like to request our guest of honor, Dr. William Yogs, as Yogs said, to say us a few words about the workshop.
Yeah. So at the outset, thank you very much for inviting me, Dr. Giri. This is my second or third visit to Orissa in the last 3 or 4 years. And for those who don't know, I did my schooling here in Bhubaneswar in Stuart School. 8th and 9th and 10th standard, I passed from Stuart School, Bhubaneswar between 1976 and 1978. So I have a more than 40 years association with Odisha. I also did take Odia, although there was a choice to take Hindi. I took Odia in this thing, but I've forgotten. I'm sorry. I do understand a few words, but I've forgotten. It's a lovely language, wonderful literature as well. So I'm back here. So once again, thank you very much. I hope I'm able to make some difference as far as your perspective in aesthetic plastic surgery goes. Dr. Giri has chosen 3 very nice cases. I think they represent what those particular surgeries should be like. We've already seen the breast augmentation. If there has been any lacuna in showing you what needed to be done, it's entirely my responsibility. I'm very sorry, but I hope I was able to satisfy some of the questions. Anything else you need to, if you want to ask me, provided I'm able to answer, I will definitely answer. We can always meet during lunchtime and afterwards, and you can always correspond with me on email. And I'm most happy to share my knowledge and my experience with you. The other 2 cases are going to be breast reduction and lipoabdominoplasty. Again, they are very suitable for the surgery. And while in breast augmentation, it's difficult to show within the dissection cavity. It's not the fault of the cameraman. And they also tried to use a 30-degree endoscope. We have struggled in Mumbai to do that, to just film inside. We never succeeded. At least here, I think you could see a little bit. So that was a good choice to use that endoscope. The others are on the surface, so I hope you will be able to see that. And I welcome questions. Anything you want to ask me, I'm most happy to answer. And I hope that those patients will do well. Yeah, thank you once again. Thank you very much for calling me.
Now, thank you so much, sir, for your enlightening words. Now we'll have our felicitation ceremony, and I would like to request our Dr. Ranjit Kumar Sahu, sir, to felicitate our Honorable Director, AIMS Bhubaneswar, Professor Dr. Ashutosh Biswas, sir. Now, I would like to request our organizing chairman, Dr. Sanjay Kumar Giri, sir, to felicitate our guest of honor. Sorry, sir. Now I'd like to request our Honorable Director, AIMS Bhubaneswar, Professor Dr. Ashutosh Biswas, sir, to felicitate our guest of honor, Dr. Milind Swag, sir. We have come to the end of the inaugural session, and I'd like to request Dr. Ranjit Kumar Sahu, sir, to come to the dais. Sorry for the change. I'd like to request our Operative Secretary, Dr. Ashish Kumar Patnaik, sir, to come to the dais and say us a few words.
Respected Ashutosh sir, Milind sir, and my dear friend Giri and Ranjit sir. Actually, it is a nice moment for the Association of Plastic Reconstructive and Aesthetic Surgeons of Odisha, because the able leadership of Giri, he has made this possible of this live operative workshop on body contouring. And today, our association has reached 100 number of association members. So now there are 4 teaching institutions in Odisha, and Barampur has started, and new with 2 students. So it will be a nice learning for the some started 3 years back actually. Anyway, the SOM has also started, and Barampur has this time 2 students have joined. So 4 institutions have started, and I think Giri is my childhood friend. Actually, I have seen him. Actually, if I am telling, I have seen him since last maybe 25 years or more. So he is a able leader. I have seen on the date of the super cyclone. I have with Giri's house on that day. Actually, I have gone to his house, and so I have seen his leadership. So I hope AIMS as well as the people of this part of the India will be benefited by his leadership, as well as the students of this state, as well as the members of the APSO will learn a lot by this workshop, as well as the symposium in the evening. And thanks to Milind sir, and thanks to AIMS. Thank you very much.
Thank you so much, sir. Now we come to the end of the inauguration session, and yeah, I'd like to request Dr. Ranjit Kumar Sahu, sir. To come to the dais to do the honor of vote of thanks.
Thank you everyone being here a part of the live workshop. Very much thanks to our director sir giving the permission to organize this event, and Milind sir is the to be here despite of busy schedule, accepting our request for this thing, organizing this event. Actually, learning from experts and learning from experience is actually this is the end stage of learning. So we hope with the blessing of everybody being present here, we'll carry out these things in step by step. And very much thanks to my department and the SRs, my staff, all faculties, especially our secretary Rajni and my whole core teams. Being last 1 week, they have given the great effort to this. Now, and special thanks to Giri, who is being our doing every pain and taking all pain for this. Thank you, everyone. Thank you.
So उस पे भी Hello. Good afternoon, everyone. The next case in the operative workshop is a case of bilateral breast macromastia. A 39-year-old female patient who is married and completed her family, whose primary concerns were enlarged ptotic breast, shoulder pain, and discomfort. And on examination, she had large breasts with grade 3 ptosis, 12 centimeter below the IMF. Her height is 5 feet 2 inches and weight is 86 kg. And the plan is bilateral reduction mammoplasty. We'll have a demonstration of the marking session first, which is pre-recorded. And after that, we'll go to the operative workshop.
I had this yesterday. We have taken the pre-recorded markings. Then that we have tried this one first time. Let's see. We do not know. We have taken the pre-recorded video markings. I have so told that if we will take the pre-recorded, then it will save time. So let us see what is happening with this marking.
Can we play the recording?
Ask the chairperson.
Yes, sir. The chairpersons for this session, Dr. Jayant Kumar Dash and Dr. Biswajit Mishra. Please chair the session, sir. Please. Can we play the recording?
Play the.
So the first thing we mark is the line from the clavicle down.
Just check with the scale. We have a reasonable sort of equality on the two sides.
is 10. This is 9.8. No problem, right? And the next thing to do is something that gets wrong. Yeah? So it's very she wants to be she got this thing. Now this is the upper part. This is the upper. See on the other side. Mark the 8 centimeters. Just keep this. With the inflammatory phase.
এটা সরি দিব না সরি হলে বন্ধ করে দিই
Mark the inflammatory phase.
তুমি একটু দেখো দিও না আমি দেখছিলাম তোর ভিজুয়ালটা হচ্ছে করলে মানে সাইন সেন্সরটা বন্ধ করে দাও বুঝলি
The same on the other side. Very often. That see. More or less coincides with that. Now, a normal reduced areola is 4 centimeters. Approximately at this level. Approximately at this level. Yeah. Yeah. So that's all this measure from the next thing is medial and laterally to mark the medial and lateral. Let's first make sure that now the position mark medial below. The same thing on the other side. You can see before you just mark the inflammatory crease as well, all the way to the sides, right? So now we have these two lines. We need a cookie cutter, and sorry, we need a dome mark. But with yeah, 17.8 centimeters. Just lift it up. Mark a nice lazy dome. Towards the end, and go back and join this. To the other side, go back and join this. Now, why this? Why this thing here? This is called the angle of sorrow. This is where most suture lines break down. So you come in a little bit. Once again, this marking can change on the tip. When you decide, you know how much you need to do. Now you have now centimeters. Now, what does this do? From this 5 centimeters, you mark the inframemory place. This 5 centimeters you export. This is what is called your medial post. This you export. This has to go. Now, if you so it's very easy. No other marking required except for the key cutter. Yeah. Now, most heavy press have reduced sensation. That doesn't mean that you can push a key cutter into that. So we might do it once the patient is given anesthesia with the breast stretched out. But otherwise, we would just mark a 4 centimeter diameter of this thing. So once again, same thing. 8 centimeters from this thing is the upper border of your areola. 2 centimeters below that is your dimple. Your over the breast. This pitch or one. Beside a small J on the right breast and a C on the left breast or any, or you can just have a small short T. Yeah. 1.6. If it is over down. Yeah, so you get same see now see This comes down, joints. This comes down and join. Same, will they keep the scale? Yeah, I have 5 centimeters on this. 5 centimeters here. Mark the
So live streaming.
one side to the other. Now we're doing something about an auxiliary tail as well. There's an auxiliary tail there, no? So this comes down here. This comes down here. This
Hello. Hello, check. Sir, am I audible? Hello? Hello? उनका earpiece
Hello, can you hear me? I think they can hear, no? Or is it just here?
I think you can do this pre-recorded. If you are doing this,
Can you hear me in the
Check.
auditorium?
Sir, am I audible on the other side?
Yes, you are audible.
Hello?
They can't hear us. ये थोड़ा reduce करेंगे. A little tight. Reduce this a little bit. This is not bad. Scale is 5 is correct. More or less correct. No problem. On the higher side. We'll take somewhere here. Yeah, 3.5 to 4 centimeters. And we will bring this in. That's fine. This should be fine. The first thing we see when the patient is supine, whatever we have done, and we pinch this. Is this coming on the middle of the mound or not? Yeah, it should not be high. It should be on the top of the mound. In case this comes higher, then we have to bring it down. Make sure that this is on top of the mound because the patient is now fully relaxed and I'm pulling as much as I can. And still it is on top of the mound. Yeah, so that's where it should be.
Hello.
Rest of it is just this thing. Chalo, let's no, can you hold the breast up? We'll use this as a tourniquet. I hope this is big enough. Yes. Alice, yeah. Okay. Yes. Okay. Needle, please. Needle 22 number needle. No, 26 is too much. 22 milega, 21, 22.
Just 22. That voice must be audible there. That voice is not audible.
22 gauge.
22.
Just check this again. Pinch. Should close. Okay. 21 रहेगा ना? नहीं 21 नहीं है. 21 green color का needle नहीं है.
Hello. Hello.
Lift the breast.
Good afternoon, sir. Sir, can you explain the markings again, please?
Oh dear. Okay.
Hello.
Hello. Yeah.
Yes.
Right. Okay. So you saw the. Can you hear me?
Yes, sir. Please explain the markings again.
So you saw the preoperative marking with the patient in standing position, right?
Yes, sir. Yeah.
Right. So we have marked the dome pattern. So what I'm doing here is when the patient fully is supine and fully relaxed, I pull the breast down. Yeah. And
Yes,
I
sir.
see whether this is sitting on top of the dome or not.
Okay, sir.
Can you see it is sitting on top of the dome?
Okay, sir. Nice.
I don't know whether you are able to see from here.
Yes, sir. It is visible, sir.
Yeah, it's on top of the dome, right?
Okay.
It's not
Yes, sir.
above or it's not below. It's on top of the dome. If it was above, then I would move the markings a little lower by a centimeter or so.
Yes, sir.
And this pinch is approximately about 4 to 4.5 centimeter diameter, this circle, right?
Yes,
I've
yes, sir.
taken I did the marking yesterday, but I've taken precaution of just bringing this marking in a little bit by a centimeter
Yes, sir.
on both sides. Yeah. And I've also taken the bottom of the U, it was about 3 centimeters. I've taken it 1 centimeter above. It's just an additional precaution. If you are able to close more than this, then we will just excise a little more and make sure that it is nice and tight. But we don't want it to be too tight. That's why I start off with something a little more conservative, and then you can go back to what you need to do.
Sir,
This has been marked with a cookie cutter, you know, the normal cookie cutter, and this has been marked at 4 centimeters, 4 centimeter diameter. Now, this 4 centimeter diameter, when the pedicle rotates, it's going to get incorporated into this dome pattern, which is going to close like a keyhole. And that's our pedicle. Okay. Now, when we talk in the evening, hopefully I will try to explain to you, there is always this worry. What is the distance of the nipple areola from the clavicle? People say 28, 30, 32, array, bahut zyada ho gaya, and all that sort of thing. It makes no difference. It makes no difference at all because it is not related to the blood supply is not coming from the clavicle. The blood supply is coming from here. So what matters is where the base of the pedicle is. Because as the breast descends down, as it gets pulled down, it's almost like a delay phenomenon. It's bringing its blood supply down with it. So we are not cutting all around, right? We are not cutting this area at all. This entire thing is getting blood supply and finally it's coming from here. So it is the length to breadth ratio of this pedicle that matters. It does not matter whether this is 32, 34, 40, 45, 60. It doesn't matter at all. It's this what is matters. So this is something that Western textbook have continuously told us that, you know, aisa mat karo, iske upar hai to inferior pedicle karo, iske niche hai to you can go to superior. It does not matter. It's only when this is more than a 2:1 ratio, which is like this thing of a axial pattern flap, that you have to start worrying about. The second thing is that we are going to remove all the tissue from this part, the lower part. Entire lower half below the equator, as we call it, we are going to remove. This is going to be removed along with the skin. Whereas this is what is called the medial ghost and the lateral ghost. These are going to be removed under subcutaneously. And we are going to make this skin as thin as possible, just one single layer of fat, so that it's allowed to contract. Now, when we open the breast, you will see that there is a difference between the fat globules of the breast tissue and the fat globules of the chest wall. We come to the bottom here at the lower part of the chest, you will see the breast fascia. So there is no need to go beyond the breast fascia, because then you are going onto the chest wall and you create a crevice here. You create a khadda that we don't want. All right. And the last thing is that if there is any lateral excess in this area, in the area of the lateral pedicle, now this is the medial pedicle. When it rotates like that, that is not going to be the medial pedicle, and this is going to be the lateral pedicle on this side. So we are going to keep about 2 to 2.5 centimeters thickness of the lateral pedicle, and everything else below this we are going to bevel out towards the chest wall. So all the lateral excess is also taken care of. I would imagine that we'll probably remove, I don't know whether they have a weighing measure here. We'll probably remove about 750 to 800 grams from this breast. Okay, so now you can use a mammostat, but this is the old traditional jugaad method. Little higher.
Hello, sir.
Yes.
One question. So suppose this hot scar technique and the inverted T pattern. So what is the there is each point you cannot do hot scar, you have to do inverted T. So how do you decide it?
Okay, see, so the inverted T pattern is basically skin resection. It has nothing to do with the parenchyma.
Right.
Okay, it is basically skin resection. Here also we have a Weiss pattern which is sitting at the top, and whatever is below the Weiss pattern is being removed. You have to understand that there is a parenchymal resection and there is a skin resection.
Right.
They are two separate things. So you can have permutations and combinations of both. The inverted T is basically a scar. Depending on which pedicle you choose, that's a different matter altogether.
Yeah, there are two aspects. One is the scar, short scar.
When we are doing a superomedial pedicle,
right.
When we are doing a superomedial pedicle, we stop the vertical suture line at a maximum of 10 centimeters. Preferably 9, but a maximum of 10 centimeters. At 10 centimeters, whatever dog ear you get, you would like to convert it into a short T, or you would like to convert it into a J on the right side and a L on the left side. So we'll see how the skin thing is, because the inverted T and all that is basically dependent upon the laxity. So whenever there's a laxity, there is a laxity in two axes. There is a laxity in vertical axis and there is a laxity in horizontal axis. Whenever there is a laxity in horizontal axis, you will have a vertical scar, because that's how you close it. And whenever there is a vertical laxity, you have a horizontal scar. So depending on how much the vertical laxity is here, we will know how much that horizontal scar is going to be. As far as possible, rather than doing a full-fledged inverted T, it's always better to convert it into a short T or a J, especially when associated with a superomedial pedicle. Okay, so let's start, since we are, I think, running a little behind time. So the first thing that I do is, for sheer fear of losing my marking, I scratch the areola and all other incision markings. Yeah, because this is the one thing that in aesthetic surgery you are most worried about, is losing the marking.
So you keep 2 centimeter of portion, which used to be deepthalized.
Not really 2 centimeters. It is basically just going beyond the the marking.
Normally, right.
इन्होंने सर्कल मार्क करा है, ये हाफ सर्कल है, 3/8 है, कितना है, क्योंकि उसको बाद में ज्वाइन करते हैं ना।
क्या कितना वो हाफ सर्कल कितने हाफ सर्कल
ज्वाइन करके हो जाएगा।
So there are 5 centimeters. So just scratch that, so that you know that is where our 5 centimeter lies. This is more important on the lateral pillar. because that lateral pillar is what is going to give shape to the breast at the end.
Sir, the Western textbooks say that up to 800 gram in one superpedial is well practiced. But according to your experience, have you done the resection more than 800 gram in using the superpedial pedicle?
क्या बोला कुछ समझा नहीं.
Sir, what I mean is that for large breast, where you have to resect around 1 gram of breast on this side, can you use that superpedial pedicle?
इसको भी दे दो. This side. So okay, so now in the what we are going to do is depithelialization. So in the area of the pedicle, we are going to infiltrate intradermally. At the same time, we need to also infiltrate the incision margins, and in the ghost areas, medial and lateral and inferior part, we will be infiltrating subdermally, so that we have a single layer of fat, which we make the skin as thin as possible. Yeah. Okay, so very quickly depithelize. थोड़ा stretch करना पड़ेगा. When Elizabeth Hall Findlay first described the superior pedicle, she was very categorically in saying you have to save veins, make sure that you don't injure any of the veins, be very careful about the depithelialization, all that. But later on, she herself has gone on to say that it's not really so important as long as you leave a decent amount of dermis. So this is the boring part.
Sir?
Yes.
Hello?
Yes.
What are the preoperative investigations do you advise in these patients, specifically unmarried?
Preoperative what?
Unmarried patients. What are the investigations to be done?
Preoperative, yes. The most important investigation in any patient who is more than 35 years old is a mammogram.
Sir.
At least a sonomammogram. If the patient is younger than that, then you may not need to do a sonomammogram, but you must always ask for a history of breast cancer in the family, or any any swellings that have been palpable, any fibroadenomas that have been removed, any kind of fibroadenosis that the patient has history of during perimenopausal, perimenstrual. But beyond the age of 35, almost certainly the most important investigation is a mammogram or a sonomammogram.
Sure. Any hormonal investigations do you advise for this one? Hormonal investigations. Hormonal.
Hormonal
investigations.
Hormonal investigation? No, I don't. We have never done any hormonal investigations in. Not even in virginal hypertrophy. I don't think it really matters.
Sir. Dr. Chaudhary, can I ask you a question?
Yes, please.
Yeah, actually, what we inflict is not with the hypodermic needles. We take the spinal needle, no? 25.
Yes, we can. Yes.
Then that it became easy and take a bigger volume of the syringe also.
Yeah, we use a 2 cc syringe. We use a 2 cc syringe. It's much easier to inject, but they don't have a lower lock 3 cc syringe here.
And if you put a spinal needle, no, 25, they become a longer one.
Yes.
And very easy to infiltrate.
Yeah. So it's what you are used to. If you are used to controlling a spinal needle as well as an anesthetist, then by all means go ahead and use a spinal needle.
Thank you.
Some more. थोड़ा और देना. वो साइड का इंसिजन किया ना? राउत साहब आपने वो साइड का इंसिजन किया ना? इधर भी हो गया, ये भी हो गया, नहीं यहाँ तक हो गया.
It's a 1% Xylocaine with ADR.
No, this is a solution of 150 cc of normal saline, 1 ampule of adrenaline, 20 cc of lignocaine adrenaline, 30 cc of lignocaine adrenaline, 2%, and 20 cc of 0.25% sensorcaine.
Sensorcaine.
So it gives post-operative analgesia as well to a significant extent, not completely. It's not as if you can eliminate pain, but breast reduction is usually not painful. If you have pain in a breast reduction, it means you have a problem. You have a seroma, you have a hematoma, something like that. थोड़ा अपने को और लगेगा because this you have to infiltrate. We keep that infiltrated. So
It's more of a pain relief operation than pain.
Sorry?
Sir, you are infiltrating throughout the breast or in specific areas?
What?
Yeah, your infiltration is along the incision line or in the lateral or
Yes. This is going to be our incision line, so we're infiltrating along that. Some people also like to infiltrate under the breast, but I find that it doesn't really help a lot. It makes cautery work a little. ये हो गया ना? Yeah. Okay, we can remove this. सांप को वापस give them again. So here now we will do subdermal. All this area we'll do just subdermal. Little thin layer of fat, roughing it and inject all of that.
Sir, another.
Injection.
Hello, sir.
Yes, please.
Another thing regarding the pedicle. Suppose we have to, it's a huge breast, we have to remove more than 1000 gram or say 1.5 kilo breast tissue from the each side. So what
Yes.
would be your pedicle of choice?
My pedicle of choice always will be supromedial.
Always.
Always.
Okay.
The maximum we've removed from one breast with a supromedial pedicle is 3.2 kilos
From each breast.
from each breast.
Okay. So it was a free nipple areola graft or it was?
Yes, that is the question I was waiting for. That is the question that you have to make a choice, and if you feel pre-operatively that this pedicle is going to go more than 2:1 ratio, or you are going to have a doubt about whether the nipple will survive, because that's the most important thing, right?
Right.
You must take the patient's consent for a free nipple areola graft before surgery, whether you like it or not, whether you do it or not. And the decision for the nipple areola graft must be taken on table. You cannot take that decision 2 hours later, 4 hours later, 6 hours later. It's too late.
Right, sir.
Yeah. So that decision whether to do it, and obviously, you have to err on the side of safety. The reason for the consent, obviously, that the patient is never going to be able to lactate again, and the sensation is lost forever. Even touch sensation, only 50% regain once you do a nipple areola graft, but the erogenous sensation is gone forever.
Right, sir.
I have not done an inferior pedicle in our last, I think probably 300, 350 breast reductions. I'm not needed to, and we've had breasts which are hanging down to the level of the umbilicus also. So that is why I was saying in the beginning that this distance from clavicle does not matter, because it's like a delay phenomenon.
Delay phenomenon.
The pedicle is coming down with the breast. I mean, the vascular pedicle is coming down with the breast. So your only worry is actually the nipple areola. So that thing you have to take that decision on table.
Have you ever faced the difficulty in rotating the medial pedicle if we are removing small amount of tissue? The other question is, if you are removing small amount of tissue, have you ever faced rotating the medial pedicle to the new nipple areola position?
No, never. Okay, there is a corollary to that question. Two things that you have to remember. If the pedicle is short, as you call it, there is usually never a problem, because it's basically just approximately about 45 to 60 degree rotation. If the pedicle is long, then you must actually over rotate the pedicle. You must go beyond 90 degrees and go to about 120 degrees. Okay.
So in fact, one of the advantages of suprapedicle pedicle over superior pedicle is that it rotates very nicely.
That gives an elegant curve to the lower pole of the
It can't be
breast
removed.
after reduction.
Okay, chalo. Let's get they're talking among themselves. Okay, can we lift it up again?
Question पचाले
Alice, please.
question पचाले जो lower border रो inframemory fold रो view separate. So what is the distance and how पचाले which one पचाले how to decide? Question पचाले.
15 number blade, 15 number blade, please.
Sir, how do you decide the distance between the inframammary fold to the lower border of the knee that that the J or T or whatever junction area that from the inframammary fold to the lower border of the resected tissue? How do you decide it?
Sorry, what?
Sir, how do you decide the distance between the inframammary fold and the lower part of that resected tissue? You said it's 5 centimeter. It is 5 centimeter in all cases, or
No, not 5. It's between 3 to 4.
3 to 4. So it
3 to 4.
it is
the reason for that.
To all cases.
Yes. The reason for that is twofold. One is that when you do a breast reduction, the inframammary fold rises, and it always rises by at least 3 to 4 centimeters. The second is you want to limit this U because you want to limit the length of your vertical suture line.
Right, sir.
Yeah. So, like I said, you keep it at 9 or 10 centimeters. In spite of that, you will see that it is still a little lower than where my 10 centimeter comes. But keeping it even above that, what will happen is that you have too much excess skin. This is part of the excision, right? Okay, so now there are two ways of removing this skin. I'll just show you in this thing. You just divide it into squares and remove the squares, or what you do is you cut it into strips. Faster and much easier to do with a 15 number blade or a scissors. You cut it into multiple long strips. Some people do it also like a Swiss roll. But it's like I said earlier, there is multiple ways of skinning a cat. Tooth for please. Adson tooth. और एक 15 नंबर का दूसरा ब्लेड तैयार रखिए.
Give a mosquito, no?
No. This is basically avulsion. Comes really fast. So you must put as much pull as you can on it. And it's no need for anything. Just tighten, bust tight, pakdo. Everything else will follow. Your job is to see whether I have left any skin behind anywhere. See, for example, here. Yeah. So you just have to show me, remind me that there is some skin left. This is what I mean by you can do it really rapidly. There is no need to worry too much about veins. Yeah. Yeah, infiltration is in the right plane, no? It's almost like an avulsion. It's almost being avulsed. I'm not even have to cut it. It requires a little practice, but yeah,
area. Actually, I am also scared. I don't infiltrate here.
Acha,
So
no,
it
no,
takes a bit more time and little easy also.
yeah, correct. So those 10 minutes infiltrating makes a lot of difference. And when we do the excision, you'll see in the lower half that infiltration. Actually, I do it with the ghost. I excise with a blade, but I won't do it just now because that's not the way people should be taught. We'll do it with a cautery. meaning not the tissue. I separate the skin from the underlying this thing with just a blade. I just move a 21 number blade under the skin. But there's a risk of cutting the skin also. We are used to it. That's the only difference. That's not something somebody new should do.
Sir, regarding the free nipple areola graft, sir, how to ensure the good take of that graft? So what are the tips and tricks?
Yeah. So when you take a full thickness graft elsewhere, you have to make sure that there is no fat or anything left, right? And you actually try to trim the dermis also a little bit.
Right, sir.
Here you don't do that. The nipple areola, I mean, that tissue is something different. It's something special. So you will find that it behaves almost like a composite graft, if you know what I mean. Like a composite graft which contains skin and cartilage.
Right.
So once you put it there inside, without thinning it, just removing, exactly the nipple and areola and leaving and the dermis from on the underside without thinning anything. For the first 72 hours, you will find that you're terrified because it becomes congested. It looks almost black, dark, but that's not a problem. Yeah. In fact, if you thin it too much, then there is an issue. You will find that over 5 or 6 days, the color comes back, congestion reduces.
So it typically behaves like a composite graft.
It behaves like a composite graft, yes. Nothing left behind, no?
Sir, can you use skin graft handle means blood to remove this DXY skin here?
Sorry?
Can you use skin grafting blood to DXY the skin?
I did skin grafting blade to do this.
To remove this one.
I have not used it. You can try and maybe show us how to do it. I have not used it. It may be possible, I guess. Only thing is with a skin grafting blade, I'm not sure over a curvilinear surface like this how much easier it will be. And you are likely to leave dermal or epidermal islands. Or you may go too deep, one way or the other.
Okay, sir.
Pottery लिया है ना?
Monopolar ready. Both bipolar insert.
Any skin island anywhere? Okay, so we have depithelized. I don't know how much time it took me, but that's usually the average.
Very fast, sir.
Okay, chalo. Now we are going to develop the pedicle. So this is one part where you don't want to, just let the breast sit on the chest wall. Yeah, you don't want too much this thing from your assistant. Blade, please. And I'll just show you a technique how you prevent undermining the pedicle. So first thing you do is you cut the dermis. Yeah, don't worry. It's small. It's not from the aorta. Don't worry about it. नया blade है? नहीं. Is this a new blade? No. Not cutting that is why.
You can take the one.
No, it doesn't matter. It's okay.
Using for display.
Yeah, I think.
You can take the other one.
No, cool. It's almost done.
So, sir, you don't use monopolar dithermy for it. You first
Yes,
use.
I will. This is just to cut the dermis, but see, I don't like cutting dermis. Like
With monopolar.
Tata and all do. cutting the skin also with cautery
Good.
because it causes problems. So once we are going through this, so two things now in developing the pedicle. First thing is that make sure you don't undermine it, and when you raise it first, you raise it as a full thickness pedicle. You can make it thinner, and you can make it less bulky later on. The second thing is, like I said, let's let it sit on the chest wall. Not too much movement. Yeah, just a little support. Just a little support.
So your incision should be vertical, not slanted or
Yeah, it's at 90 degrees.
90 degree.
Yeah, and how you go at 90 degrees without undermining, I'll show you. I'll ask Dr. Raut Saab to just help me out. Once you have gone reasonably deep inside, assistant and surgeon, a surgeon and assistant put their fingers. Yeah. At the level where the dissection is going. No pulling. Just keep your fingers next to each other and then just cut through. As you go deeper and deeper,
It's
your fingers also go deeper and deeper.
Perpendicularly.
Perpendicular. So there is no undermining. Correct. The fingers are retractors and you are absolutely sure that you are not undermining. If at all you are doing anything, you are leaving excess tissue along the edge of the pedicle. That doesn't matter because you don't get rewards for, removing everything en masse in one piece. There are no rewards for that. Okay. The second thing is that you go deeper and deeper, you are going to find glandular tissue and you're going to find some milk cysts sometimes. Okay. Now, Dr. Raut will attest that we have almost reached the fascia. The most important thing to retain sensation in breast reduction is never to go to the fascia when you raise the pedicle. Never, ever. Always leave a couple of layers of fat on the fascia. The moment you reach the fascia, you have destroyed the patient's sensation. Yeah, there is no hope after that. So I can feel now the rib cage, but I can still not see the fascia at all. There is still fat there. So that's where you stop. No gauze pieces at all. No gauze pieces at all. Okay.
So you have to leave some fat on the fascia.
Yes, you have to leave fat on the fascia. That is the way you are absolutely guaranteeing that you will preserve sensation.
Right.
That's it. My dissection here is done. I go to the top. I don't know how long that took, but again, it's very quick. Excellent pottery this is. So now I've gone to the top. Same thing once again. Raut Saab will going to put his finger there. I'm going to be at the top. He's going to be at the bottom, and we do exactly the same thing. Here now, as I go a little close, I'm going to find some vessels. Hopefully, आपने कुछ gland देखा क्या? There's hardly any gland in this lady. It's almost all fat.
जब लड़की ज्यादा समझदार
फिंगर के नीचे कुछ है. Yeah, okay. Okay, same thing once again. Going down.
वो अच्छी समझदार हो गई है हर चीजें.
Yeah, little bit of this thing is there. And as we are retracting, we are actually separating it out, the fat and helping our dissection as well. Whatever cauterization you need to do, you can do. Once again, you can feel now you are on the rib cage. Anything further that you need to do for rotation, you do once you cut the third side. Yes, this part. Done. Okay. So now I need counter traction. Yeah, that's right. Yeah. And I keep my finger here. I know I have a full thickness pedicle. So if this becomes thinner when I dissect it, it really does not matter. Excision of this specimen and creating the pedicle should not take more than half an hour to 45 minutes. It is the suturing that is the biggest problem. If somebody can find a way of suturing this aesthetically in 30 minutes time, before I retire, I will give him half my savings.
Robotic.
Yeah, but अरे बाबा robotic तो मेरा पूरा savings निकल जाएगा ना. Yeah, so little careful as we are developing the pedicle. इधर थोड़ा ग्लैंड है, इसके लिए थोड़ा going a little slow because gland है मतलब उसमें vessel रहेगा. Tissue is remaining here and a little tissue is remaining here. This part. Done. Okay, that's my pedicle rotated. Anything more I need to do, I will do once everything else is excised. Yeah, can you see the pedicle? It's already moving into the defect, into the keyhole. Yes or no?
Yes. Yes.
Hello.
Yes, sir.
Yeah, all right. Chalo, do catch pause, please. 15 number blade. So now we'll develop the ghost. Ulta side. Yeah, blade then please. Blade. Now this part you have to thin out subcutaneously on the lateral and the medial sides. On the lateral side below the level of the lateral pedicle, and on the medial side entirely below the pedicle itself. Okay, so now how my assistants are going to help is that we are going to, she got pretty thick skin. We are going to lift this straight up in the air, up. One more, please. Sorry, yaar. One more. Yeah, bus straight up in the air. Audrey, I don't know whether you can see from the camera angle. Maybe you'll be able to see on the lateral side.
So what is the thickness of this flap?
One layer of fat.
One layer of fat. So it's a random flap.
Yes, no, it's not really a flap. It's actually just skin. So make sure that you never expose the dermis. Again, same this thing. You can make it thicker if you want and then make it thinner afterwards. Nobody is giving us prizes for removing this in one shot. See how much difference the infiltration makes. It's waited for 10-15 minutes while we.
So it's absolutely bloodless.
And how my assistants are helping here is because they're holding it vertically. I'm just going parallel to how they hold it. So if I expose dermis, please blame them, not me. Yeah, this is absolutely perfect. Raut Saab, thank you so much. It makes it so much easier. No, because if your assistant knows what is happening now, it becomes so much easier. So yeah, can you see here now? I've almost reached there. Can you see my finger?
Yes.
Yeah, so that's my ghost on the medial side, almost completely excised. Excised meaning I have separated the skin. I have not excised it yet. I have separated the skin. Yeah, and that's how thin my flap is. Right?
Right.
Do the same coming over towards this side.
Yes,
Almost one layer, one fat layer.
Sorry?
Almost subdermal.
Almost subdermal. Just a little bit of fat underneath. Okay. Blade, please. Yeah, now we bring it here. Oh, sorry, I have not cut the dermis. Yes, please, here. Yeah, we'll put here, one here. And this one, we just get a little further. Yeah. Same vertically upwards. We are going to just separate this out as well. Light, please. Light. Yeah, the dermis pakdiye, just hold the dermis. Yeah. It's not sharp. Yeah, that one is not as sharp as. Okay. The difficulty we are having here is because of the infiltration, but I don't mind because it makes sure that the bleeding is. Yeah, okay. The other thing is this skin, never handle with your fingers. Okay, this is what causes problems. So always if you're going to hold the skin, you hold it with a, or like Raut sir is hold it up with this thing. Because that is where all the problems with the skin occur.
Natural tendency to.
Yes, it's hold it with the hand. So you need to be a little delicate. Imagine that it's your newly married husband or wife. Not after 5 years, but newly married.
Utmost care.
Yes. 5 साल के बाद वो either husband or wife कुछ होता नहीं है, but at least 5 साल तक, I hope. Okay, there we are. Right? Can you see the fascia? That's the fascia. Right? So we are going to stop short there because now we are going to be on the chest wall. So if you see here, once again, I've reached the bottom. I need not go deeper than this because I'm going to the chest wall. This is not breast tissue. Yeah, this is chest wall tissue. So there's no need to go there. And this is not going to be related to a breast reduction at all. So why go there unnecessarily and create dead space further? No need for it. I'm going to just penetrate the fascia and show you something if I'm allowed to. Okay. I don't know whether you can see from the camera. You see the fat globules here? See these fat globules? They're all big fat globules and they are yellowish. These fat globules are all smaller below the fascia. So that's one way of knowing that you have reached the fascia. Blade, please. Okay, now usually we finish this as well, but for people who are just starting out, we will do something which is a little more, to be cautious. So we start off by doing the, Alice, Alice, please. We start off removing the tissue from the dome. Now here we are not going to go full down, right down, because we need what's called a platform on which the rotated pedicle is going to rest. So we are going to take about a centimeter or so of tissue. Yeah, yeah, just put it here. Yeah. Okay. Now this is going to be a lateral pedicle. Again, you have to be very careful about how you separate the skin from the lateral pedicle. It should never happen. So never touch this area or try to pull this away. Yeah. So first thing, we are going to cut this now. Blade.
Sir, regarding the dome, it is a half circle dome with the diameter.
Diameter of 4.2 centimeters. But when you draw the dome as a, like a free dome marking, it should be about 16 or 17 centimeters in length. 16, 17 centimeters length, or a circumference is approximately has a diameter of about 4 centimeters.
4 centimeters. Sir.
Remember, it's going to stretch.
So it should be approximately 16 centimeters dome.
Yeah, 16 to 18 centimeters is what you need to draw it. You can use it drawing a, there is a dome marker as well. You can do it freehand if you need. Okay. So now what we are going to do is that's the pedicle. We are going to stay away from the pedicle.
Something called the blocking triangle.
Yeah, that's we'll talk about that. That's a little different. Forceps, plain forceps.
It's not this, sir.
And regarding the distance from the upper fold of the breast to the dome, it is also constant, 10 centimeter.
Sorry, what?
Regarding the distance between the upper fold of the breast to the upper part of the dome.
No, that is between 8 to 10 centimeters, depending on how much tissue you want to leave behind.
Right, sir.
Minimum should be 8, maximum can be 10 centimeters.
10 centimeter.
Yeah, so now we are going to remove about a centimeter, go down below. This you're saying, no? These two triangles. Yeah, but I'll show you what happens there.
Dissection at the dome part is also perpendicular, not beveled, or it is almost perpendicular to the chest wall.
Which one?
Dissection at the dome.
Dissection at the dome is, yes, but it's only 1 centimeter. So now I've gone 1 centimeter below here. So all I do is I remove 1 centimeter up to coming to the pakdo. Yeah. No. Yeah. Yeah. Bas, that's it. Okay. Now the most critical step, which you have to be very, very careful about. You can be fast in everything else, but always take care with this. Support the lateral pedicle. Never separate the skin from the lateral pedicle. Blade. And we have our 5 centimeters marked here. So first thing I'm going to do is make sure that I have a flat, absolute vertical, no separation of skin from this thing, lateral pedicle. And I will treat it with the utmost of respect when I cut it. Forceps there upon lateral pedicle, there it is. Vessel, aram se, don't. Yeah, that vessel is just that. Yeah. No, we'll bevel it beyond the 2 centimeters. We'll bevel it towards the, yeah. So
लाइट थोड़ा ठीक चाहिए ना, ये वाला कैमरा वाला लाइट.
yeah, give me a mop. Okay, so that's my lateral pedicle now. Can you see it? That's the thickness of my lateral pedicle, 5 centimeters, and that much thick. Yeah, no separation between skin and lateral pedicle. Is absolutely stuck to it. And now beyond this, as long as I protect this 2 centimeters thickness, I go and bevel outwards. So now let's finish that. We know that the lateral pedicle. Let's finish this.
So lateral pedicle is 2 centimeter thickness.
2 centimeter thickness, yes.
So initially it is perpendicular, then after 2 centimeter you will.
I'm going to bevel outwards towards the periphery of the breast and remove all the tissue under that 2 centimeters. So that is what removes the lateral fullness that is there in most breasts. Yeah, and all the time I am going to make sure that my assistant also understands that he or she is not going to pull at that lateral pedicle and separate the skin. All the problems with the vertical suture line occurs because you have separated skin from the underlying fat.
So there will be necrosis of that area.
Sorry?
There will be necrosis of that area.
Yes, there is a problem with the skin, this thing then, okay? So we have come down here. Now the same thing on the medial side, two skin hooks, two catch first, please. Yeah, so this you have to protect with your life now, all right? Up to here, okay? Even if I go there, please caution me. Huh? Don't squeezing, just hold that there, bas, that's it. The other hand, please hold this. No, one second. Hold this. Aram se, be careful in that junction. And here, okay? Yeah, I'll hold it.
So how far you go laterally?
Laterally, we go all the way to the margin of the breast.
Margin of the breast.
Same thing that we did on the medial side, leaving a thin layer of fat here. Oh, what a counter traction thing here also. Yeah.
One.
That's my limit. If at all I come, I very careful there.
It is up to the lateral border of the breast with 2 centimeter thickness of the lateral flap.
Mop then. Can I just have that mop? Yes. Yeah. Nikal down. I'll hold. Yeah. Yeah, cut the fascia there.
So laterally also you will go up the fascia table, down, deep down.
Okay, so we have reached the end here. Can you see this? My finger is there. Yeah, that's the end. Okay, and now all this tissue is going to be removed. So we'll start from the top. Okay, protecting once again the lateral pedicle. We'll start from the top. Now this is my platform. All right, I've maintained the platform here. So एक Alice लगाएंगे इधर. We'll just remove this triangle. Alice. Yeah, bus. Just a little bit of a triangle to give a little better shape. There's nothing else.
It is triangular tissue on the pedicle side.
No, this is on the platform.
Platform.
That is a poking part of the platform. Okay. Yeah. So now we have, you can very quickly lose orientation. Yeah. So you have the pedicle in your hand. Lateral pedicle, lateral pillar you have in your hand. Yeah, this is out completely. Now give me that. Yeah. So this is my lateral pillar. Okay. I have gone up to there 2 centimeters. Now I start cutting under it. Okay, that's my lateral pillar. Can you see that? Yeah, that's my lateral pillar, and I've gone. I still have to go a little further to the periphery of the breast. It's important that from time to time you just pause and reorient yourself as to where you are, because you can get lost in the breast. And I don't mean that in any other way. Okay, now if you look here, I'm at the edge of the breast. That's my pillar. Okay, now everything that I have here now is going to go except this, this, and this. Yeah. So now somebody holds the pedicle gently for me. I get rid of all this tissue here. Alice, please.
Oh my God,
Pedicle you have in your hand. Pedicle इधर है ना? Yeah. ये छोड़ दीजिए. You can actually separate out. Okay. नहीं वो रहने दीजिए. Yeah. Now we are very close to. If it's not coming in our way, we'll leave it. No reason. मैं बोला we'll leave it and मैं चाहिए.
Unless it sounds quite a bit.
Yeah, so lateral pillar is there. Yeah, आराम से. Going down as low down as you want. This traction देगा तो it practically separates out. We are at the bottom. Same here. Go down. We are at the bottom. Yeah. So this upper part is now taken care of. Everything else is going to remain. So now we start. Either we'll just hold it with. ऐसा पकड़ लेंगे. Yeah. So now we are removing the medial ghost. Okay. Once again, it's not so important from the point of view of sensation now, because remember the pedicle has gone up. But it's important from the viewpoint of seroma, to leave fat and not expose the fascia. Again, this breast tissue, a few grams of breast tissue is not going to make a tremendous amount of difference to the size of the breast if you leave this behind, but it will make a hell of a lot of difference to seroma formation. So always leave fat on the fascia. Never expose the fascia if you are. Yeah, this is the inferior pedicle. What you see here is the inferior pedicle. So for those in the audience who wanted to do inferior pedicle breast reduction, I'm sorry, we can't do it anymore.
So it follows the same principle as abdominoplasty. We have to leave a layer of the fat on the fascia.
Yes, very much so. Same reason also, but not so much lymphatic drainage, but seroma. In abdominoplasty, or I could have been mistaken, this could be the inferior pedicle, because they are all in that area. Yeah. In fact, I can see artery and vein here, so probably this is the one.
So do you think inferior pedicle technique is now obsolete? Once upon a time, it was the most popular technique.
I don't know who asked that question, but you said it, I didn't. I really don't see any need for an inferior pedicle because the shape of the breast is absolutely fantastic with a superior pedicle.
Superior pedicle.
Because the moment you do an inferior pedicle and you do that inverted T, you are flattening the breast once again. Sorry, देखा और मेरा pottery लग गया उधर. थोड़ा side में.
Main complication of the bottoming out of the pedicle.
Yes.
That was the main complication of inferior pedicle.
Mop, please. Yeah, that's it. Yes. Bus. Okay, now this is the one. This is done. Now we come to this side. We remove this part. अच्छा मेरे को वॉश के लिए थोड़ा 20 cc का सिरिंज रहेगा आपके पास? हाँ. या वॉश लेने के लिए जरा या टूमी, हाँ टूमी रहेगा तो इवन बेटर है. ग्रीन वाला. एक मिनट. Just leave it there. Let's remove the yeah. So this are not inferior pedicle or anything like that. This is basically just because the breast is ptotic. It is there are perforators coming through the breast tissue. एक मिनट हाँ इधर से जाएंगे. No, there is a vessel there. Okay, so let's hide this for the moment. Can I just see that specimen, please? Yeah, so this is now our excision specimen. If you look at it, the camera is there. See how little is removed from the platform area.
Right,
you see
sir.
that?
Yes, sir.
Very little is removed from the platform area because you need from the keyhole area. This is all the stuff that is there that was below the lateral pedicle. See how much tissue there is here, which you have beveled outwards, right? This is the medial ghost. This is the lateral ghost. That's the inferior part that has come out with the skin. Okay. This is probably around 550 grams or so. Yeah, we just see what the hemostasis is like and whether if this breast is still too large and we want to narrow the pedicle.
Sir, can you please show the dome area and the pedicle area?
Yeah.
Just to...
Yeah. One second. Okay. Yeah. Right.
So this is.
So see, this is the dome.
Dome area. So dome area is full thickness fat.
Just about a centimeter, and the rest is a platform.
Right.
This is our lateral pedicle. Can you see the lateral pedicle?
Right, sir.
Oh, किधर से आई? That's the lateral pedicle. This is all empty. All empty.
Right, sir.
Okay. ये थोड़ा सा निकाल लेंगे हम लोग. We'll just remove a little bit of this. Forceps देना please. Alice, your forceps. Just make it a little prettier. What is that green fiber of Okay, first class. Yeah. Now you rotate. See and see what she wants, a moderately size breast. This is already a C cup. So little bit now carefully. Wash देने के लिए तैयार रखो. We will reduce this. No, this, yeah. Can you? थोड़ा ज़्यादा नहीं, because otherwise undermine होएगा. Just to take it out. नीचे ये है ना, मॉप है ना नीचे. Okay. Now you have a choice whether you want to. This is a full thickness pedicle. So if you can gently hold this, we can remove this except for the base. Yeah. So once again, about 3 centimeters thickness here, but never go towards the base. Keep the base as thick as possible. Chalo. Yeah, this is looking nice. We have a yeah. Chalo, let's give a quick wash and we are done. Little bit here. Oh, that's this bit. Remove.
ग्रीन वाला बॉल जो ट्रेल है, ठीक है, फिर यही दे.
Suction, please. We'll need suction now. So you see this loose fat. This is what then causes problems, right? This is what causes fat necrosis. This causes inflammation. You see redness along the suture line.
So it is normal saline wash, one normal saline.
Just a normal saline, absolute normal saline wash. Yeah, वो निकाल दो. Just put the.
Saline दे दो.
नहीं चलेगा.
Some more saline.
It all come into the. Wash it out from there. One last one, sister, last bit. Okay, आ गया सब. हाँ. It doesn't look like there's any more loose fat anywhere. So let's start forming the breast. Yeah, sister, 30 PDS, please. It is quite thick. Right now, when you reform the keyhole, one important thing is your first stitch should never be at the level of the keyhole. Yeah, take it a little lower. Yeah. So this is now my lateral part. I don't take it here. I take it slightly below. Because what happens if you take it here is that the vertical suture line then starts pulling it and making it into a teardrop. So when you close your keyhole, whatever is done for the keyhole should be within the keyhole. But this stitch should come slightly below. One thing we forgot to do is to mark the cardinal points in the on the pedicle. But ठीक है, doesn't matter. Yeah, छोड़ दीजिए. Yeah, नहीं वो rotate हो जाएगा. Don't worry about it. छोड़ दीजिए. No problem. We will push it in. Yeah. Okay. So now.
What is that cardinal point?
Yes,
On the
cardinal
bit.
point is to accurately oppose 3 o'clock, 9 o'clock, 12 o'clock, 6
Right, sir.
o'clock
Right.
on the areola. Yeah, but we know here that now this is 12 o'clock, right? But here that the part that was 12 o'clock has become 3. So if I scratch and I know where I am, I can always find out if I have already scratched it. 9, sorry, 9. For the right breast, it's 9. Okay. Sister, next I'm going to need 20 Vicryl. Short, ekdam short, next to the knot. Next to the knot. So some of the threads are coming from somewhere. Don't know. It's a mess. So in between now we will take 2 or 3 to complete what's we call the spoke wheel. And then on top of that, 30 or 40 monocryl subcuticular. Short. Keep it short. Just next to the knot. Okay, now this is what I mean. Yeah, so correct. So this is what I mean. If you take it at the top here, no, then when you do the vertical suture line, this starts pulling down. So you make sure that this entire thing is only restricted to the nipple areola. So we'll take one here. We'll take one there. We'll take one here. Okay. As soon as I take the 20 Vicryl stitches, you will see the breast mount forming. This lady, we asked specifically whether she wants to go as small as possible or she wants to go moderate. And she said she wants to go based on how the rest of her body is. So we have kept it a little larger than normal, but that's my breast mount. Yeah, that's my breast. Okay. So here, when cutting needle pe, round body pe nahi hai, sister. Round body pe do na. Sorry, I should have mentioned it. Sorry, wasted. Sorry. We are also going to need a 14 number Romovac. Romovac 14.
Negative section 14.
Can you see the shape of the breast now?
Yes, sir. So you will make a final stitch, or you will put stapler as stay stitcher so that you can compare with the other side of the breast.
No, I don't compare, but I think maybe in the interest of time, so that Raut Sahib and I can suture together, we might just take the piece sutures and go to the opposite side. But some important steps I'll show you here. Okay, now we are exactly at 5 centimeters. This one is a little lower, but I found this pillar a little bigger, so I've done it at that level. The 5 centimeters is here. Yeah, but when you equalize it, it looks like probably this would be better. Sister, thoda jelly lagao na Vicryl ko.
This 5 centimeter is also constant, or it changes, varies from?
So correct. So 5 centimeters, if you leave 5 centimeters, you will get the smallest size of the breast. If you take 6 centimeter pillar, you will get a larger breast. If you take 7 centimeter pillar, you will get even larger breast. You know, more tissue you are remaining behind. No?
Because in inverted T scar, it has been described it should be 7 to 9 centimeter. The
Yes.
vertical limb.
Yes. So here also we are going to hope that we keep the vertical limb at 9 centimeters. And beyond that, we convert it into a,
Some used to put a the pedicle to the chest wall.
no, we don't do that. One second. So Vicryl को जेली लगाया? Not ये नहीं होता है. Yes, but I don't like to do it because it doesn't, it tethers the breast. I don't like to fix it to the chest wall. The breast rotates better and the scar goes underneath better if you leave the breast free. Cut to the tip, no? Tip is not cutting. Sorry? What is waist?
Sir, there is a
taking
question.
pillars, no? Pillars are being taken, no?
Hello, sir.
Yes.
Yes, sir. While suturing this, we have to take a bite from the de-epithelialized portion.
Yes.
Yes. So, does it affect the venous drainage of the nipple areola?
No, not at all, not at all. But if you see now where it is rotated, it's only in the lower half.
Yes.
Yeah? It is only in the lower half. Whereas venous drainage and all is from the top, no? You can cut it on all other sides.
Right, sir.
Also the suture orientation.
Yes.
We are taking longitudinally.
Yeah.
Along the vessels, not across the vessels.
Yeah. In fact, sometimes we don't even do this, you know, we just bring it together. But I wanted to show you this because of the very question that Mainak asked. Mainak, yeah, Mainak is. Yeah. Are you basing it only on the dermis? Because see, there is no dead space here. No, that's what. So you don't, no. So that we are not taking any strangulating sutures. We are just opposing.
Just to eliminate this.
Yes. We are just opposing. System मेरे को अभी 30 monocryl चाहिए. Now this next stitch is what forms your inframammary fold, not this one. The next stitch I'm going to take. So we are going to take 2 box stitches, or rather figure of 8 stitches, and that's going to form a new inframammary fold. Yeah, and that's going to be at the bottom of the pillars. Yeah, so we don't do that anymore. It's not necessary also. Okay, so here now, this is the first one, which is slightly below, and I'll take one slightly above. So you go from in to out. This is in the dermis, mind you. Come out above. No fascia. Just this. Yeah. Go back in again.
So the mount won't be hitched to the chest wall by
Nothing, by nothing. And then come back. That is the level of my new inframammary crease.
But there is no underlying TCP. How would the thing mount get the support?
Why do you need support? The breast, does the breast have the
tendency to bottom out?
what has a tendency to bottom out?
Because of the weight of the parenchyma that is left.
We have reduced it, no?
Okay.
The whole idea of this thing is, was the breast earlier supported on the fascia? No, it was not. It's a free lying organ. Yeah, no, I'll just take one more. 1 second.
So will you put a drain now or?
Yes, always, always. Especially in a workshop, definitely. Yeah, no, because we,
Those are the tricks. That is correct. Is doing outside your hometown.
yeah.
Conservative measures are always dangerous.
Yeah.
The drain will come out to the axilla.
No, at the bottom here.
There will be an additional.
Mainak, when you do your case, you remove the drain from where you want. When I am doing this, I will remove it from where I want.
And what about very still?
Outside can do that later on, no problem. Okay, yeah. So 2 there we'll do that. If you want, okay. Now let me just show scale, please. Can I see the scale and marking pen?
Right.
Extra fat there, but we'll remove that later. Yeah. No, just stretch this one. Just stretch that. No, I need to see the edge. Yes, so we are going to go, no, not 7, 9 centimeters. Yeah, so we are going to keep 9 centimeters.
Inframammary fold will be at 9 centimeter.
Yes. Okay. So your vertical suture line is 9 centimeters.
10 centimeter.
Anything beyond that, now you decide whether you want a short T or how it's sitting. Okay. So this is where we are going to close up to. Beyond this, whether it will become like this or whether you want it like this. That's what you decide, because as long as you have this, the breast is up. The moment you do this, you're tethering it down, right? So
Right.
as far as possible, we'll do a J.
So at 9 centimeter, you'll put a stitch through fascia also, underlying fascia?
No. We don't hitch to fascia at all. No hitching to fascia at all. Yeah. System erco monocryl 30 monocryl. Just take those 2 stitches so that we get this in place. And then I think we can move on to the other side if necessary. इधर का थोड़ा स्किन जो एक्स्ट्रा फैट है, just trim that only. No, short. Go to the knot, please. बीच में 2 gaps. when the skin is nice and thin, you actually see it contract almost on table. Lady's got fairly thick skin. Sister, yeah, so I think it will sit well as a J. Yeah, थोड़ा higher जाना पड़ेगा. Just comes down here. Or will it sit better as? I think J is better. J is definitely. Just correcting now for W. Yeah, we can do that. एक वो PDS देना जरा sister. ये thin करते हैं. Yeah, let's. 41 नहीं यही करेंगे. We just hold this thing up. ये वाला tissue.
Sir, if it is more on the lateral side, then you decide to make it a J.
Yes, that's right.
Oh.
ये तो chest wall पे है ना. It's not on the this. I think it's not. This is not in the. ये भी नीचे है. It's not in the skin. Yeah, it's close like that.
So this is basically chest wall.
This is chest
So we
wall
are not
fat.
going to remove
Yeah,
that.
we are not going to remove that. Yeah, in this envelope is where. See how thin this is. Yeah, this is how इधर थोड़ा है देखो. You can see some little bit of fat. I can feel there.
Yeah.
So that we have to remove. Yeah, scissor देना sister.
So what about liposuction combined with it to make it a better shape on the lateral side?
Yes, you can do that. You can do that. No problem. We can do that. Yeah, exactly. That's what Hall Finlay described it as with liposuction. Yeah, this is going to contract. Yeah, ठीक है. That much is sufficient. Your side अच्छा है. This is also good. So we can close that later. Yeah, either just for my this thing अपन ने ये करेंगे.
And what about sir fat grafting for better cleavage?
In breast reduction?
Yes, yes.
I have not heard of that. Honestly, I can't give you an answer on that.
But in augmentation you do.
Augmentation we do because it's not always possible to give a cleavage just by the implant. But I don't know. We've never thought of breast doing a cleavage breast reduction.
For this, you always prefer PDS.
Yeah, because this holds everything nicely together. It doesn't allow the areola to stretch. Then the rest is always done with 40, 30, or 40 monocule, subcuticular. Anyway, ये कर सकते हैं बाद में. We can do that later. Can we go there? Okay. वजन किया उसका? वजन कर सकें क्या? What is the time?
2:20.
Okay, it's not bad. So we finished in about an hour, hour 40 minutes. What time did we start?
1:04 we started giving a local.
Oh, is it? Okay, that was pretty fast then. Good. नहीं सिस्टर वो अपना ये था टूनिके का ये किधर गया? नहीं स्क्रैच नहीं किया. स्क्रैच नहीं किया. पहले स्क्रैच करते हैं. स्क्रैच.
Sir, for the benefit of the audience, can you please say the concentration of the
नहीं यार किस नंबर का नहीं
infiltration, sir?
Light, somebody adjust the light.
लाइट थोड़ा ठीक करिए.
That's sterile. Angle is sterile.
sterile.
Just scratch the cardinal points which we forgot last time.
The patient walking.
Yeah, a little bit movement. तो mops थोड़ा गीला करके देना, don't give dry mops. Still moving, sorry. Please tell me when. Not bad, no, the shape is quite decent, I think.
Explain very lucidly.
Unfortunately, nowhere. There are no publications where the average rule of thumb is 175 to 200 is a cup. And if you're talking about how to go from one cup to the other, yeah, so there are tables for that. There is a table. Yeah, can I? Okay. Sorry, I actually started already.
Excuse me, sir.
Lunchtime
Excuse me,
also
sir.
Yeah, I will do that. Yeah, at least the lower half में जो अंदर लिया ना, definitely do that. ज़्यादा कुछ उधर laxity लगता नहीं है. It's a good tension free closure, so it's better.
Excuse me, sir.
Yes.
There's a question from YouTube. Multiple slits help faster deepitalization. Is it so? And what are the disadvantages if it is done in a single piece?
Multiple
slits for deepitalization. He has asked multiple slits you are doing. Is it because that makes it more faster?
Yeah, it's faster. That's all. You can do it as you want. You can remove the whole thing as a single piece and declare it as a trophy. Doesn't matter.
Okay, sir.
It is just what suits you.
Sir.
If you feel that you want to show this to the patient and say, "Arey dekho, maine ek piece mein nikala, mere ko shabashi do," that also can be done.
So another question from YouTube is drain always a must?
Is what?
Is drain always a must?
Drain always a must. Okay. Not really. No. Depends on, see, if you find the breast is very glandular and it's not oozed a lot, then you may not leave a drain. But if the breast is fatty, you hardly found any granular tissue, then it's a wise idea to leave a drain for 24 hours. ये तो है. उधर भी अपने already थोड़ा scratch बाहर की तरफ किया है, but we can use that as the. That should be okay. ठीक है, चलो इसको ये देना. Yeah, scratch करने के लिए.
Uji, blender मतलब it will be uji. Blender मतलब तो भसना जाता. Yeah, that is what sir says. If it is more glandular, then better to put a drain.
It depends on what you find during surgery. If you find that it's oozy, you had problems, and at the end of this thing, thoda idhar udhar se ooze maar raha hai, leave a drain. It doesn't matter, no. एक मिनट अंदर या ओके अपना स्क्रैच इधर एक
I think from this side. No.
okay Mr. Can I use this? Okay, Alice then up please. Sure. Can you lift the breast up? Just lift. Yeah, you have to hold up and lift. Yeah, correct. Hold the whole breast up. One sec. What I'll do is I'll hold it. Chodo, up, chodo. Yes. Does it go around? आया? First class. Infiltration. Sir को भी दे देना.
So benefit of the audience, can you please repeat the concentration of the composition of the liquid you are infiltrating?
Yeah, so 150 cc of normal saline, 30 cc of 2% lignocaine adrenaline, that's 170 cc, 180 cc, 20 cc of 0.25% sensor cane, that makes it a 200 cc solution, and 1 ampule of adrenaline. This is the most boring part as well. You have to do it. Yeah.
Definitely helping. Rapidly
And this you can do as long as you are intradermal, no? You can do bindas, koi problem nahi. It doesn't cause any issues with venous problems or anything like that. But you have to be intradermal. Hmm? But what?
when we are doing reconstruction using DF flux.
DF flux, huh?
It says we can do the same thing.
Yeah. Chalo, I think done, no? Just have to do yeah, infiltration, yeah, incisions करने का है ना खाली. And the lateral and medial goes.
There was a question about the blocking triangle.
Yes, what about the,
Enlighten me.
no, what question?
What are the blocking triangles actually? This whole case, are you taking the help of blocking triangles or?
No, see, I don't really understand what blocking triangles means, to be honest. But they are the ones where you are bringing the dome pattern in to make sure that there is no tension on the suture line at the level of the keyhole.
There is a arithmetic or geometrical figure that is being shown that
Yeah,
line
yeah.
joining above the go for the superior, go for the supremedial, like that.
I think that is,
That is not this.
I mean, I don't know whether somebody has given his name to it, but that might have been the reason. It's not really. A long time, this maneuver that me and Dr. Raut Saab just did, we were thinking of calling it the Wag maneuver, fingers and all that. Then we realized that it's nonsense. And we are Indians, kya karega? Yeah, we have to do the ghost. Yeah, नहीं इधर नहीं अपने को नीचे करने का या ये निकाल लो ना, take it out. Yeah, we do this. चलो sister दे दो, and this is now subdermal injection. Ghost. अच्छा, come. Yeah. है, is there still some, है ना? Medial side you will always have the pedicle, so that doesn't cause any problems. It's the lateral side which is important because that is what gives the shape to the lateral half.
Sorry.
No problem. अभी होली आने वाला ही है. खत्म हो गया है ना? लगेगा थोड़ा सा. Otherwise, we'll have to make a solution of 1 in 200,000 saline adrenaline without any lignocaine on it. Already डाल दिया. Solution. Yeah. So lipo, if it's a large lipo, we are going to exceed more than 5 liters. Then we add only 1 ampule of adrenaline to 1 liter of ringalactate, and we add 25 cc of 2% xylocard, not xylocaine, xylocard. If we are doing less than 4 liters or less than 5 liters, and we intend to infiltrate in separate sessions, means like we'll infiltrate, aspirate, then infiltrate again, then we will use 2 ampules of adrenaline in 1 liter of normal of ringalactate. That's the only difference. Xylocard, maximum xylocard for a 80 kg patient, you can use up to 100 cc of xylocard. That's 2 vials, 2 full vials, diluted into, of course, 4 different liters. So yeah, soda bicarb we will use if we are doing under local anesthesia. Yeah, because that reduces the pain of the injection. No, hyaluronidase, I've suffered by putting hyaluronidase. I had a patient who went into acute renal failure, and there are 2 case reports in literature that says that hyaluronidase can cause ATN. So we used to use that. After that one case, and fortunately the patient had to undergo dialysis. I stopped hyaluronidase. I'll never use hyaluronidase again in my life, even if my life depends on it, because it's scary. I had done only about 2 liters of liposuction on the thighs, and I went off to see some other patient, and I came back in the evening. The patient had passed exactly 10 cc of urine. So I didn't know what to do. So we gave her that classic challenge. Ye dala, BP acha dekh ke. First, If it's less than 2 liters, we don't catheterize. If it's more than 2 liters and the surgery is more than 2 hours, then we catheterize. Chalo. I think we are more or less done. O side ka ho gaya tha na sab. Yeah. So let's put the
Again, breast control.
इसमें जनरली एक टेल आता है. देयर इज अ टेल दैट कम्स विद दिस. वो टेल नहीं है ना, इसके लिए वो थोड़ा शॉर्ट पड़ रहा है. अदरवाइज द yeah, usually it comes with a tail. Chalo, all right. Hopefully we'll try to finish this faster. Lipoabdominoplasty को सुबह से सर ने रखा है ना? Is she starting from morning? Oh dear. कुछ IV चालू करो ना. Started, no? I should have kept them maybe from 10 o'clock or something.
The right side specimen is 1000 grams.
1000?
Yeah.
अरे इतना कैसे चुप गया मेरा? Good, that's excellent. Sister has not put some of her own stuff in it, no? You can cut this with a scissor as well. You get these nice flat scissors. It's very easy to cut with scissors, but we are used to cutting it with blades.
Of cutting with knife is but knife is better, sir.
Yeah.
In comparing to scissors.
Chalo, sister. Can I have a tooth forceps, please?
I remember himself to be just describing himself to be a burnt child. Why? During parturition, there was an offer for mommy makeover or something like that. I still remember that thing.
Yeah.
It was in Aplas, I think.
It's a traumatic experience you always remember. And complications. Never forget them. Once you, for example, in a blepharoplasty, you see a retroorbital hematoma, you'll never, ever forget it. Ever. God forbid any of you guys should ever have a. Yeah, but
So insurance indemnity kya wo wala hi sir? Promoted by. That is the secondary thing.
what's that?
He is saying financial compensation. Indemnity you have taken from that thing that is endorsed by.
No, I have not taken that yet. My indemnity is from Association of Medical Consultants, the Mumbai this thing.
Okay.
But yeah, I'll probably need to take some additional indemnity. I might do it from cover. As long as APSI is behind it, you need not worry. The problem is whether these people also have good lawyers. You know, it's not just a question of insurance. these companies should also have good lawyers. AMC, which is, I don't know whether there is AMC in other states, but it's basically MDMS, all the consultants in Mumbai. They have very good lawyers for medical legal cases.
We don't have here.
Yeah.
Maybe on the Delhi side. The eastern side.
किधर से किया है ना?
Does the IR endorse any kind of specialized indemnity?
No, but IAPS has been involved with the APSI. Medha Bhave only was part of this thing, and Medha Bhave was secretary of IAPS at that time. So she has worked quite a bit on this. And Selva Sitaraman and Rajat Gupta. Rajat Gupta was again now he's secretary of IAPS. That time he was joint secretary. So ये कॉस्मेटिक सर्जरी के लिए बना के ये लोग ही दिया, IAPS ही दिया, but APSI is the parent organization, no? More members, more clout.
No, the problem is that the distinction between reconstructive and aesthetic surgery, as per the coverage, whether that will be under the same umbrella or not.
Yeah, it will be. It will be. It will be under the same umbrella. Only thing is, if you're doing reconstructive only, then you don't need that much coverage. Not that it's predictable. Just a blade थोड़ा सा जाने लगा है. Can you just give me a new one? Yeah. I think there is silence from that side. खाना खाने को चालू किया लगता है. Or they are bored. एक side देख गया हो गया. अभी the same thing is a duplication.
एक साइड देख के तो दूसरा साइड बोरिंग लगेगा ही.
हाँ. BP बढ़ा है थोड़ा. Is the BP and it is the tourniquet.
Sorry. Preferred method.
Yeah, but I have it. If you want to buy, I'll give you 50% discount. I bought it for some 8,000 rupees. I'll give it to you for 4,000. I've never ever used it. If you had told me, I would have brought it here.
So what about police? Usage of police?
Sir, is it also for you?
No, see,
Hello?
the best tourniquet is the assistant's hand. It's the best tourniquet. But even there, if the skin is lax, like it is here, there's some part of it you cannot escape. There is going to be laxity. You have to just get on with it. Somebody's suggestion, I had bought that Mamostat. I've never used it, never. It was it's on the surface. I don't think we waited as long after the infiltration for this. That is why it's a little oozy here. And second side, always you are more impatient. खत्म करने का रहता है.
Second thing is
replying to the queries from the audience at that time, because already repetition.
Yeah. थोड़ा tight करें, little tight. Yeah.
You are not.
Yeah, we'll remove this. Tell us how much is venous, how much is.
This side तो blade में भी कर सकते हैं सर, जो बोल रहे थे आप.
क्या?
This side artery, this side blade. Anyway, you are going to put a drain. So blade.
Blades. You are saying this thing? No. It's way if you are teaching, let's teach it the proper way.
Okay.
That you can do after,
Because I have seen Manoj Khanna sir also doing that blade.
Yeah.
उनको तो डर लगता है.
मनोज खन्ना को ब्रेस्ट रिडक्शन में ही सिखाया. Although he will not admit it.
That was his presentation.
Yeah, so वो एक वीडियो बनाया था मैं.
Video.
There was a video with this. चलो, Sister Blade, please once again. So what is this being broadcast on YouTube? Or is streamed on YouTube? Is it? Okay. हाथ संभालो. Take care of your चलो, Audrey. Finally, एक जगह पे it's too large. Maybe just at the moment थोड़ा अंदर जाते हैं. भी थोड़ा थक गया लगता है. Okay. पानी में चलता नहीं है.
ये
WhatsApp पे chat करो। देखिए कहीं ना कहीं उसी काम सॉरी सत्र
ये थोड़ा ज्यादा डीप लग रहा है। More fat. Depth. Also, we are more tired, so looking. Yeah, you know, you see underneath. एक बार ये हो जाएगा तो we'll see on the other side. Yeah, कितने पे है कॉन्ट्री? करो ना 35 करो जरा। Can you just take this? कर रहे हैं क्या? He's doing. हाँ.
35 वो भी करो। हाँ, done.
अभी चलना बंद हो गया।
नहीं हो रहा अभी। Maybe the contact is breaking.
No, Artery should work, no? ठीक है। Sorry. Yeah, almost there. Yeah. Okay. Get this out. Can you hold the like that? Yeah, that's right. Okay. I've seen people do this dissection with blade completely. completely unmindful of hemostasis, and then go and do hemostasis later on. It is also okay, provided you have that confidence. But it's not something that you can show in a workshop. It's not. Yeah, exactly. So then the people get a little discouraged, or they think कि ये किसको बुलाया. Okay. Yeah, so for the pudding is the rotation. चलो blade please. तो मेरे को दूसरा glove मिलेगा, थोड़ा गर्म हो रहा है. There is a hole in this. ऐसा कुछ है नहीं. I mean, we use 15 number in everything in plastic surgery. So this is also, and you can always try. Well, you don't know. Yeah. So that ghost dissection I used to do with the number 2021. You just sweep across. It separates the skin from the. Because in that case, we'll be cutting the tissue, the belly of the. Not with the tip of the foot. Yeah. तुम लोग को the ladies want to go. बाद में मिलेगा नहीं है खाना already गिरी बोल दिया है. अभी डायरेक्टली डिनर का भी गिरी गारंटी नहीं दे रहा है. चलो सिस्टर कैच पॉज प्लीज. No, keep it at the top. Medially तो कोई इधर नहीं. Okay. No, just a normal sports bra. Yeah, one size larger than what you have made the breast, because bulky dressing रहता है ना. Yeah, can you just keep the pedicle aside? We might as well finish off this dissection. Everybody is busy eating ना. निकाल लेते. Yeah, thank you. Perfect. Just nice counter traction. क्या हो गया? ब्रेकफास्ट बॉस मेरे को याद भी नहीं है. ब्रेकफास्ट में ऑमलेट दिया उसने. ऑमलेट और 3 स्लाइस ब्रेड दिया. नहीं और मेरे को कुछ. बॉस मेरा नॉर्मल ब्रेकफास्ट इज कप ऑफ कॉफी एंड 2 बिस्किट्स. दैट्स माय नॉर्मल ब्रेकफास्ट. ये तो एकदम फीस्ट हो गया. Lunch I have 2 chapatis, that's it. 1 chapati. I don't have anything. Sure, blade there. No, right? No, I've given a price 10 years ago. क्या फर्क पड़ता है? Rice is, I think, fattening. With all apologies to everyone who eats lots of rice here. At least for me, it's fattening. Chalo, sister, thank you. Yeah, so yeah, throw the side middle, just bring it a little distinct so we can, no, this is already separated, no? So bring it to this edge. Yeah, and put that here. Yeah, first class. I'll hold this one. The trick is when you're holding it up, no, don't go like this. You go towards the dermis. You are perpendicular, absolutely perpendicular. And again, I keep saying this, I'm sorry, I keep saying this, nobody is giving you awards for doing it right the first time. Yeah. So बाद में आज जो भी excess fat है बाद में करो ना exercise. But never approach the dermis first. इसको पकड़ सकती है ना? Yeah. Yeah, that's our fascia. Don't transgress that. And anyway, we have reached the bottom almost. Oh, yeah, here at the bottom. We'll come to the lateral side, but first we will do this thing. Okay, that's our pillar here to here. So we will do this thing first. Yeah, one. Assistant, हाँ, दो alleys देंगे please. Cannot be separated. Yeah, you should not separate it because that is what causes trouble on the suture line. एक minute, huh? एक forceps देंगे assistant. Good forceps. Okay. Yeah, 1 centimeter. 2 centimeter. No, either 1 centimeter. 2 centimeter is the lateral pillar. Yeah, so now we just take it off from here. Flat. It's quite easy, it just comes off. Only when there is gland in this that there is some issue. Otherwise, yeah, a little bit of fat from here we need to remove. Scissor देंगे sister? Just 1 second. Bas. Yeah, now the critical part, either just there's some bleeder here. You just clot. Clot, है ना? चलो, blade लाओ and just support this. Huh? Just support this. However many breast reductions you do, not this part, take that extra time to do. It makes a lot of difference. Don't remove your hand from there. No, like this, support this. This is my 2 centimeter pillar. Okay. So once I've done that, then I can do what the hell I want here. Yeah. Oh, we have to bevel down, but that we'll do later. Now we know that we have a 2 centimeter pillar here. Then we will come down from here and go back down there. Blade, please. This here to protect, huh? Yeah, catch first, please. Keep a watch on that lateral pillar, huh? इधर है ना? That's my pillar. What route saw was in his hand. Is my pillar. So I saved that and gone across. I know that whatever is in at the top, just put that catch point again. Yeah, yeah. Sure.
What marking pens would you recommend for marking?
Yeah, so the best marking pens I found come from a company called Pentel. Yeah, Japanese. But what you can do is there is a marking pen in my box. See that black and it's available on Amazon. So far, I found it the best available in India. I used to have Pentel and I had got in a conference in Korea, but I finished all those. I had bought 50. वो खत्म हो गया. I could never find any. Now maybe next time I go, I'll look for them again. But there are some really nice ones. Available from एक एंड में बड़ा एक एंड में नहीं मेरे पास है देखो तो किधर है मेरा बॉक्स या those are excellent ones. In fact, they are so good that sometimes when I use them in facelift and all, patient complains कि 10 दिन के बाद भी गया नहीं है. That the mark has not gone. Yeah, bring them down here. Yeah, now you see this? No. I see this here. See that? Yeah, so that shouldn't happen. Yeah, that shouldn't happen. But this is between you and me, all right? Only us, not for the audience. What? Yes, this. Yeah, I don't know which company it is, but it is fabulous. Surgical skin marker. International. It's available in Amazon. Yeah, it's available on Amazon. ये जाता ही नहीं है. It doesn't go only. You can write it down on the name. Yeah, toward attraction. Yeah. Sister, can you give me a mop? Yeah, just protect the pedicle. Pillar.
Sir. Hello. Not audible. Subhanallah.
Still there is. Okay, पहुंच गया. Okay, now we'll start cutting. Sorry, I don't know your name.
Gopika.
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 Yeah, Gopika, support the lateral pillar. Baki ka sab. Yeah, something happens to the lateral pillar, you have to be blamed. Okay.
Better I should.
So now we will. ये खाली finger निकाल दीजिए. She's holding that. No. Now we will start beveling outwards. Yeah, please.
What do you think leads to bottoming out in inferior pedicle?
It's because it's an anti-gravity pedicle. It's the whole thing is supported and is base below, no? So it's always going to fall downwards. Not only that, the movement with an inferior pedicle, it is almost impossible to have a vertical scar, right? You're going to have a inverted T. So that's also flattening out the breast. The moment the breast flattens out and you have a wider base of the breast, it's asking for gravity to, work on it. Means it's begging for gravity. कि चलो मेरे को नीचे खींचो और bottom out कराओ. No, that's the answer to that is a resounding no. If you are, if you have excess money, please donate to the this thing of your religion, but do not buy mammostats. Yeah, pedicle आपके पास है? Yeah.
The company manufacturing business.
Yeah, the other thing is my mammostat, anybody is welcome to. 50% I already said.
Next question. What is the duration of your surgery and do you send them the same day? When do you call them back for rest? Or do you
Nice.
and when do you directly remove the seat? Or do you direct?
Yeah, so no, the patient invariably stays overnight, whether or not drain is put or not. The reason for that is that I like to give 3 doses of injectable antibiotics. So that's morning of surgery, afternoon of surgery, and evening of surgery, and next morning. So the patient definitely stays because it's a major procedure. More often than not, the drain gets removed after 24 hours. Means it is very rare for the drain to be kept beyond 24 hours. And then once the drain is out and 3 doses of antibiotics are given, there is no need for the patient to be in hospital. First dressing is on the 4th or the 5th day. The second dressing is on the 8th or the 9th day. Third dressing is on the 12th or 13th day. And the patient comes for the 4th visit, that is the 16th and the 17th day. Everything is kept open. And by that time, everything has healed. There are no sutures to be removed. Next question. Yeah, routes of Jara, correct. Just asking. You should show this pedicle. Na? Actually, हम लोग बंद ये कर देते हैं, but we never show the pedicle. Let's show this as the pedicle. क्या? नहीं जाने देंगे. बहुत छोटा लग रहा है. नहीं छोटा लग रहा है. वो कोई believe नहीं करेगा. It's better not to show.
Maybe the first one we was.
Yeah, first one was the pedicle. Actually, that was the inferior pedicle. The other side is powerfully. Either sorry. Yeah, what is on the next question?
Yes, how often do you encounter lateral fullness after your reduction for mildly inward pointing nipples?
Lateral fullness, yes, you can get lateral fullness. There are 2 ways to address it. Either once you have closed everything, you still have the energy, you can do a liposuction at the same time, or you can wait for a secondary this thing. But yes, you can always. But one thing important is once you remove the lateral ghost and you bevel the lateral pillar towards the no, udhar hi hai. That could be the you bevel the lateral pillar outwards towards the border of the breast. No, idhar hai, dekhiye, yeah, see that there, yeah. Okay, so here's our inferior pedicle. Can you see it? Hello?
Yes,
Yes, sir. Yes, sir.
Yeah, that's the inferior pedicle. So once again, like I said in that other breast, we can no longer do a surgery based on the inferior pedicle. It's gone. You've been a little less respectful of hemostasis in this breast. Pure sign of hypoglycemia.
Sir, regarding the marker, so what's the brand name that is available in Amazon?
Sorry, what?
Regarding the skin marker,
Yes.
so what is the brand name that is available in Amazon?
Yeah, they will show you. They'll show you on the. थोड़ा ज्यादा है ना इधर परफोरेटर्स नहीं इधर तो इन्फिल्ट्रेट किया ही नहीं नॉट वी डोंट इन्फिल्ट्रेट अंडर द ब्रेस्ट परफोरेटर्स थोड़ा इसको जरा वापस पकड़ेंगे आई थिंक जस्ट
মানে স্কিন মার্কার করলে কি সেগুলো
बहुत है there are lots of perforators in this side पूरा काला हो गया you can change the tip for you Yes, if it's available, yes, definitely, because it's safer. But a lot of places don't have. In fact, some of the hospitals that I visit in Mumbai also do not have ropivacaine. But if it's available, yes, definitely, as compared to, if not ropivacaine, then at least levobupivacaine. The levo version of the bupivacaine is safer than anything else. So yes, definitely. That's a good question. We'll reduce this. We'll reduce this first. We'll reduce, yeah. ये अपना पिलर है दैट्स गुड ये थोड़ा सा इधर से काट के निकालेंगे या एक मिनट हम जस्ट होल्ड द पिलर इन प्लेस दिस इज माय पिलर यस या कैन यू जस्ट टेक दैट typically it's a triangle no they just curve it there is the platform yes हाँ कहाँ से भीड़ मार रहे हैं इसमें थोड़ा सा दिस पिक Yes. Of the superior pedicle, yeah. So you can leave it as full thickness, depend if you want to have a largest breast. But if you want to reduce it, then at the in the distal half of the pedicle, you keep it at about 3 centimeters, and the proximal half you keep full thickness. So your thinning has to be all in the proximal half only. Yeah, you could probably thin it some more, but I would strongly suggest that unless you have a reason to, don't do it, because finally it's the pedicle and the supply to the nipple areola which is the most important thing. थोड़ा है अभी तक वो कितना हुआ वजन देख सकते हैं, so we'll know how much to.
स्पेसिमेन ये दूसरा स्पेसिमेन मेजर करो.
Someone has asked, can breast reduction or augmentation be done under total local anesthesia?
Breast augmentation, yes. Not total local anesthesia, but local anesthesia with sedation, definitely, with intercostal blocks. I've actually seen it being done in Australia. I've not done in one myself, but I've seen it being done. But reduction, I don't know. It's a little more extensive surgery. I would assume that the amount of local anesthesia required might be a little bit of a problem. एक मिनट, थोड़ा सा do the same from this side. Yeah, so that's a good question once again. So remember that when we are doing the marking, the medial pillar is a full 5 centimeters, correct? The medial side we are taking a full 5 centimeters. So that's straight away the base of the pedicle in the lower part. In the upper part, you are going into the keyhole from around 6 o'clock position to approximately 2 o'clock position. And like I said, the keyhole when you mark it is approximately 16-17 centimeters long. So we would assume that at least 1/3 of the keyhole, that marking that we have done is part of the pedicle. So you take another 5 centimeters. So 5 plus 5, it is at least 10 centimeters at the base. अब नीचे ये है ना, टॉवेल है ना. Finally, let's remove a little bit of this. Can you hold on to that? We'll just remove. We remove on that side also, no? 1 kilo हो गया? Jackass. This side was little larger. So we'll remove 50 grams more and we'll celebrate that. Good. Okay, so that's our pedicle. Now let's do a wash. एक मिनट, इधर थोड़ा जाड़ा है. Just remove that one second. Yeah, scissor देना.
Of the medial part.
छूटा ही है लगता है. It's free only. Yeah, थोड़ा है इधर. एक मिनट. Any bleeding anywhere after all that? Cautery, please. Any bleeding? No, no. What is the blood pressure? Perfect. So it's not bleeding with blood pressure of that much, then it will not bleed. Suction, please. Stop, stop. वो एसेप्टो नहीं है आपके पास? अच्छा, नहीं, आई थॉट डॉक्टर राउत सेड एक्चुअली रिसेंटली लाया। अच्छा, किधर तो रखा हुआ रहेगा सेफली थोड़ा, नॉट ज्यादा ही। अच्छा अच्छा, ओके। This is an important step. The loose fat globules is very important to wash them off. Bas, enough. Just on the surface, because otherwise it starts the bleeding again from the suction. इधर किया है ना, we have done this side also, no? Washed all this. Sure. Mr. PDF, please. नहीं किया बाद में बिफोर यू एक्सट्यूबेट देन जरा एक बार कर डालो, बिकॉज उसका ब्लैडर फिल होएगा तो बीपी भी बढ़ेगा। Yes, this side we had, this side we did. Sorry? No. That one, no? No, my conducive. Chairman, Yeah, short. Please cut it short. The knots, no, they stay for a long time, PDS. Just cut it next to the knot, please. चलो तो वाइकरल प्लीज एंड थोड़ा मॉप देना Yes. Bringing the medial and lateral pillar together, this thing is already rotated. Yeah, this is 2-0 Vicryl. काटेंगे बाद में time 3:30. Just one second. Yeah.
Tissue glue.
I don't think anybody is post lunch there. Or yeah.
Why are you not asking questions?
Like going to the GIT.
Even a live objective workshop, so asking verifying what to do. Ask any topic question, till you can do for you. But I'm come on. How many? Why the it will not need answer.
Layers, two layers. Now the next one will be straight away be subcuticular.
Okay, thank you, congratulations.
In this, the pillar, the next layer will straight away be subcuticular monocrystal.
ଆମର OT light ର system ନାହିଁ ନା
So I need the 30 monocrystal now.
এই জায়গাতে পয়েন্ট করছে এই জায়গাতে কথা সেই জায়গাতে লাইট সেটিং হচ্ছে সেইটা
ନା ରାଇନୋପ୍ଲାଷ୍ଟିରେ ଭଲ ହଉଛି ଗୋଟେ ଫିକ୍ସଡ ଜାଗା ଛୋଟ ଜାଗା ନା 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 ଆମର ଯାଇଥିଲୁ ହାଇଦ୍ରାବାଦରେ ରାଇନୋପ୍ଲାଷ୍ଟି ବଢିଆ ପୁରା ସେଇ OT light ରେ ଗୋଟେ ଜାଗା
Dr. Jelly Gaya sister, it's not.
ଛୋଟ ଏରିଆରେ ଏତିକି ଭଲ
Yeah, no, we'll just take the monocrystal first. To fix the inframammary crease with those two stitches.
ବ୍ରହ୍ମପୁର କଣ ଅଛି ସେ ଯୋଉ ହାଇଦ୍ରାବାଦରେ ପଡେ
No, I drain तैयार रखना 14.
The two separate, no?
No, one this thing, yeah, I think it should come across. No, ये नहीं होना चाहिए.
Christian racing what करेंगे
After reduction, IMF gets pulled up.
Yes, by almost 5-6 centimeters.
And this scar is going to below to the IMF or within the IMF?
No, it will be above the IMF, but under the breast, because the breast comes and sort of rotates downwards. So initially, for the first 3 months or so, you will still see it when the patient stands. When the breast comes down and rotates, it will go under the breast. Yeah, इसका वो PDS देना, just unnecessarily irritate कर रहा है. हो जाएगा वो. चल, अभी मार्किंग पेन दे तो रहने दे, PDS रहने दे. Dry gauze. This is where we are going to convert it into a J.
Sir, it is 9 centimeter.
9 centimeters, yes.
You always do that, sir.
So, monocrystal once again. नो वो जो है वो दे दो सिस्टर अभी फिलहाल. Chalo. Yeah, I think you can start the PDS that side. I'll do the PDS here. गैप नहीं रहा ना है इधर.
All these box type of stitches.
No, these are not box. The only box stitches are, or the this thing are to create the IMF. That was at 5 centimeters on the vertical pillar.
What type of stitch was that?
This is just a buried stitch, just a normal simple buried stitch. Chalo, PDS please. Size wise is looking okay, both. Or one is looking larger than the other.
No, that's question.
That's right.
Each side, 1 kg each side.
Don't go.
One side is bigger.
Yes.
So हाँ उसमें बाद में थोड़ा remove किया ना. 1100 will be from the left side.
Yeah, maybe something like that.
Sir, which suture material you're using now?
On the areola, the one I'm using now is the blue one. You can probably see is 30 PDS.
Yes, sir.
The one we are going to use, we used on the vertical suture line are 30 monocryl.
Yes,
The
sir.
ones we use for the pillars, medial and lateral, are 20 vicryl.
Vicryl.
One of the questions that many patients do ask, especially those who undergo this surgery, is there any chance of this macromastia to recur post surgery? So how?
Yeah, so the only way it can recur is if you get pregnant. Yeah, and there is because of lactational reasons. Yeah, there are very few of these hormonal conditions that cause macromastia. Very few. That's almost syndromic. But normally, no. Only is if the patient gets pregnant once again. Even with weight gain and all that, it's not really a issue with
Sir, unmarried girl doing with macromastia or doing reduction. What is the advice regarding her doubts about lactation, future lactation?
Yeah, so that's a usual question. But the thing is, see, none of the modern methods of breast reduction divide the connection between the nipple, the ducts, and the glandular tissue. It's unless you have done a free, going to likely to do a free nipple graft, right? And it's always peripheral tissue that is removed. So the central core of tissue which contains the pedicle is always going to be retained, whatever pedicle it is, superior or inferior or whatever. So whatever breast tissue she has,
Should be able to.
yeah, she will have, but there will be a proportionate reduction. But there's no question of her not lactating. There are some questions about because of reduction in sensation and reductions to the sympathetic and the parasympathetic, this thing of the nipple. Yeah, not erogenicity, ejection of the milk. Yes, there are some questions about that, no doubt about that.
It varies according to the pedicle, no?
Yes, so they say that the inferior pedicle actually gives good sensation, retains good sensation. Inferior pedicle, sensation. But in for terms of lactation, the superior pedicle is superior. Hmm.
So would you counsel her to come back after or
No, it depends on how troubled they are by it. It is depends on, you know, how much psychologically they are affected by it, how much troubled they are by it. If they are not particularly, then, you know, we always counsel them saying that, you know, you should come back after at least one child. Most of the vaginal hypertrophy young ladies, they are completely frustrated because they are teased, they cannot fit into normal clothes, they cannot find normal bras. There is a lot of problem with chafing from the bra strap, there is neck pain, there is back pain. All those issues are there. The youngest patient I have done breast reduction was 15-year-old American girl. She was, and the way she changed, my God, it was, they say na ki aesthetic surgery mein kuch aisa ye nahi hai. It was unbelievably gratifying. The confidence, the absolutely different personality altogether.
Sir, what we mentioned just now that what are different symptoms of these patients. So with this, should this this reduction procedure be called body contouring or aesthetic surgery? Because many of the symptoms have been cleared by this reduction procedure.
Yes, it's actually reconstructive. I have a feeling that, you know, I would categorize it, if I was in power, I would categorize it as purely reconstructive. And of course, we are doing it, giving good contour and shape. That's the aesthetic part, but it's really reconstructive. But who will convince the insurance companies? So it's your job to convince the insurance companies. So very often, what we will do when patients come to us with really large breasts and they complain of a few things, right from your first documentation, you must document it as that. Back pain, neck pain, chafing from bra strap, intertrigo, that is the fungal infection under the breast. Don't lie, but put it like that. And then if the insurance company gives it, nothing like it. If it doesn't, then abhi kya kar sakta hai? That the patient has to know.
and she is concerned about her huge breast, saying that I need to get maximum of it. So how much would be the maximum amount that can be?
Yeah, so see, depending on how wide the breasts are, but on an average, megamastia breasts are stretched out and wide, right? So you can't go below unless you do a free nipple graft. But we are not doing a free nipple graft. You can't go below a large C. There's no chance. Yeah, large C is the absolute minimum you can reduce breast to without resorting to a free nipple graft. Okay, so this now we will do this thing on.
The fasting related. Fasting for nipple?
No, we'll just take subcuticular around this thing. Yeah, we'll go around that. Now this needs to be looked at. And
Sir, are you going to put the drill now?
इस मेरे को एक मोनोक्रिल देंगे जरा ऊपर थोड़ा सा उसको थोड़ा ये करेंगे मोनोक्रिल है
So quite clear.
just to make this a little better for closure.
Dr. Milind,
Yes,
can you hear me? Dr.
yes, I
Chu,
can.
in one case I remember, one side was done by me, other one was Vibhuti.
This is Dr.
So
Chaudhary.
somehow we missed to put the drain properly.
Sorry?
So unfortunately, we have missed to put the drain properly and
Okay.
in properly. End of the day, we had a problem.
All right.
So I think drain should be given with our experience should be given in all cases, and so we seen that it is properly functioning.
Yes, yes. I agree with you. Drain is because you can always remove it after 24 hours. It's not a big deal. It doesn't pain the patient. The scar is not really a issue. Why not be a little more careful? No question. This is just to tidy up the suture line. Yeah, you don't really need this, but just it'll make suture line a little more tidy when we take the 4-0 monocryl. Yeah. Now, sister, I'll need marking pen, dry this thing. Dry gauze, marking pen. Yeah, so this is we are going to use as a L here. नहीं एक काम करो मेरे को आर्टरी देना गिव मी एन आर्टरी या आर्टरी दे दे Still remember, you will say that okay, this is extending the suture line longer. It's still above the IMF, still above the IMF. And Pakado sister, yeah, can you let go when the breast drops? This is where it goes. Yeah, can you see it now with the breast dropping?
Yes, sir.
Yeah. So what happens is that the whole thing rotates. It's not just that I'm dipping it inside. It's the whole thing that's rotating like this. And that is what you have to explain to the patient when the patient comes for follow-up at 3 weeks. You know, that reassurance has to be there. They'll say, "Arey, ye kya kar diya aapne? Plastic surgeon ho ya mochi ho?" But that is what you have to tell them, and they have to anticipate this. So you must tell them that it's not going to look good for some time, but infiltration. तो वो ये 10 cc सीरीज में दिया था ना वो खत्म हो गया सिस्टर ओके काम करेंगे ये 100 cc नॉर्मल सेलाइन का छोटा बॉटल रहता है आपके पास हाँ हाँ 100 cc नॉर्मल सेलाइन लो और उसमें हाफ cc एड्रेनालिन डालो जस्ट गिव मी दैट अभी तक मोनोक्रिल दे देना सिस्टर I'll take 2 more stitches but they'll anyway be in a curve उल्टा लिया मैं या ड्रेन डालने को याद रखना पड़ेगा. This imbrication, as we call it here, this takes care of itself with time because it's along the curve. हाँ, auxiliary tail करने का है. डाला इसके अंदर. हाँ नहीं, मेरा लंच का नहीं, बट वो लास्ट केस का क्या करने का है. लास्ट केस जो है एब्डोमिनोप्लास्टी वाला, उसको दूसरा ओटी में चालू करने का है क्या. फिर जब मार्किंग करने का रहेगा तो somebody will have to close this. Somebody can close this. You can leave for the yeah. Will you do the dog ear and all that? And to do this also. हाँ, वो भी आपको करना है. ठीक. घंटे का काम अभी लग जाएगा 1 घंटा. चलेगा. Okay. Okay. Sure ना. Thank you so much. Sorry to leave.
Thank you, sir, for your nice and explained surgery.
काट के जाऊँ क्या? At least you can leave without any stress. Yeah, drain है, जगह है डालने के लिए, but डाल देते हैं because we'll forget otherwise. Just place that underneath. The mop. Just open the mop and place it underneath. थोड़ा stretch करो. Be able to close this ना. Yeah. थोड़ा इधर अगर फैट को ट्रिम करने का रहेगा तो ट्रिम कर सकता है. 30 मोनोक्रिल एंड देन स्ट्रेट फ्रॉम ऊपर से नीचे 40 मोनोक्रिल सबक्यूटिकुलर. Alright. Yeah. And here also somebody will need to put 40 monoclinic subcuticular. So I have left some lot of work for you. I'm sorry. Okay, sure. Thanks so much. Thanks everyone.
Thank you, sir.
Thank you. लाइपो एब्डोमिनोप्लास्टी का उसको सुला के जरा मार्क कर लेते हैं, उनको इंड्यूस करने दो. लाइपोसक्शन कोई करेगा? 3 मिलीमीटर कैन्युला रहेगा आपके पास ना. या तो नहीं, इन द सेंस इन्फिल्ट्रेशन बोल रहा हूँ. लाइपो करेंगे बट लाइपो इन्फिल्ट्रेशन के लिए विल जस्ट मार्क द एरियाज, जस्ट इन्फिल्ट्रेट देम. बाय द टाइम मैं खाना खा के आता हूँ, देन वी कैन, आई थिंक बाय द टाइम इंडक्शन भी नहीं होगा रहेगा, so we'll finish that off quickly. Which this thing? Thank you. Infiltration. So one, you have ringer lactate. Yeah. So 1 liter of ringer lactate. Put. She's not hypertensive, no? That patient, the third patient, is she hypertensive? Yeah. 2. No. I'm asking you, is the lipoabdominoplasty patient hypertensive? Yeah. So 2 ampules of adrenaline. So 1 in 500 cc and 25 cc of xylocard. Not xylocaine, xylocard. Huh? Yeah. और ऐसा 2 लीटर बना दो. Make 2 liters. So 2 liters of ringer lactate, 4 ampules of adrenaline, and 50 cc पूरा vial of xylocard in half an hour. Sorry. Thank you. Thank you, sir.
Hello. Now we will go for the third session, third case, which is a 43-year-old female patient, married, completed her family, underwent LSCS twice, and her primary concern was her lax abdomen. And on examination, she had a bulky abdomen with significant skin and abdominal laxity. Her height is 5 feet, weight is 54.6 kg. Abdominal wall at her Ziffy sternum is 74 centimeter, and at umbilicus it is 94 centimeter. And at pelvis it is 86 centimeter, and we are planning for the abdominoplasty. We'll continue with the session, and please arrive shortly in 10 minutes. Thanks. Everyone please proceed for PhD has arrived. Thank you.
Hello. Marking done for lipoabdominoplasty. Dr. Milind is there? I asked him.
Hello.
Hello.
Okay, sir. Audible.
It is audible.
Actually, marking of the abdominoplasty has been done.
Okay.
Patient is induced.
Okay.
Sir has taken the lunch. Now he will come and he will explain all the markings again.
Okay then. Okay. We are waiting.
Sir, video is not coming. Video is not coming.
It is not coming.
No.
It is not so.
It's not shown, I think. Phone ka language to remind. I know you are inside OT.
ଦରକାର ପଡିବ ଫୋନ କରି ନହେଲେ ଚଳିବ ଆଉ ତମେ ଆସିଲେ ସେ ଉପରେ ଡ୍ରେସ୍ ଅଛି ଦବ ଅଡିଓ ଦେଇଛି ଅଡିଓ ଟେଷ୍ଟ କରିଦିଅ କହି ଦଉନ ସେ ଭିଡିଓ ସଣ୍ଡା ଆଣିନି
ଗୋଟେ ଦିନ ଜବ ନା Please over button. Yes, over.
आप जब बताएंगे उस टाइम देंगे बस
The OT technicians, can you please focus the camera towards the OT table, please?
Hello.
Hello.
Yeah, Dr. Jayant this side. So it has not started.
Not started. Okay.
Yes, sir.
ଦିଟା କମେଣ୍ଟ ତ ସାଉଣ୍ଡ ଟା କୋଉଠି ଅଛି ଅଡିଓ କମେଇବା ପାଇଁ ସମୟ ଦେଖିଲେ ଅଡିଓ କମେଇବା ଦରକାର ପଡେ ରାଇଟ୍ similar to that don't try to
OT. हाँ खाली बंद है कल बंद हाँ dates So we shall begin with the third session shortly, the case of lipoabdominoplasty. I would request Dr. Akshay Kumar Rawat and Dr. Ruchi Gupta to chair this session. Thank you very much, ma'am. Thank you very much, sir.
DNB स्टूडेंट है क्या अभी? नहीं है। एमसीए सीट भी काफी हो गया ना, इसलिए डीएनबी नोबडी इज प्रिफरिंग। अगर ओरिजिनल ले लिया होता तो बहुत पैसे निकले। हाँ, और तो आएंगे। नॉर्थ में वहाँ फैकल्टी कौन है?
ये पॉकेट में डाल दीजिए। हाँ, लगा दिया पीछे। हाँ, थैंक यू। ओके ओके, थैंक यू। अरे प्लीज, थैंक यू वेरी मच, थैंक यू। मस्त हो गया, बहुत अच्छा हो गया। चलो, सो we've got the solution prepared. We'll do the lipo first.
Yeah, Dr. Milind, could you please explain about the markings?
Yeah, okay. So we mark the patient in the standing position, and all the circles that you see on the abdomen are basically the areas where there is excess fat which you are going to do liposuction in.
Okay.
So right above the umbilicus, there is this crescentic area or half a circle area where we don't do liposuction at all. So at this point, at the level of the umbilicus is going to come down to this area, which is at the level of the pubis. And this is the area that often gives trouble. So we don't thin down this area. So what you also notice is that maximum thickness, however fat a patient is, You will find that in along the inguinal areas where there adherence, there is a zone of adherence, the amount of fat there is much less than the amount of fat which is over the pubic mound. And nobody does liposuction of the pubic mound unless it's absolutely necessary. So this particular thickness of fat should correspond to this thickness of fat. Otherwise, there's a big dip there.
Yeah.
And that's the area that also gives trouble from the vascularity point of view. The other areas are basically just codes. So, you know, there is, when she stands there, there is already a dip in this area. There is a sort of a dip in this area as well. So we are not going to do much liposuction there. The two flanks, again, you can see, I don't know whether you can see the flanks here, but to the flanks, once again, we are going to do a little bit of lipo for basically the love handles. This marking, what we have done is that she has a cesarean section scar, if you can see that.
Yes.
Taken it just below the cesarean section scar, and the level of that incision is 7 centimeters from where the vaginal, vertical this thing starts. You can take it between 5 and 6 centimeters, but that's up to you. And what we generally do is that we take straight lines, absolute straight lines, no curvatures, no convexity, no concavity, for 5 centimeters on either side of the midline. Then based on what clothing the patients wear, we will curve the line upwards or we will continue straight. The other criteria is if the patient's overhanging fat apron is limited to between the two ASIs. If it is limited to between the two ASIs, then we will continue practically straight along the sides as well. So which is why then we have marked this as a very gentle curve, and this is lower than the ASIs. So whatever she wears, whatever kind of panty she wears, this is always going to be hidden on both sides. With the patient standing, this particular fat apron, overhanging fat apron in the infraumbilical area did not go much beyond about, say, around 12-13 centimeters from the midline. But we always know that when we bring this down, the upper segment is going to be longer. This particular segment is always going to be longer. So we just extrapolate that a little more to try to compensate for the length of the lower segment, so that we don't have to do too much stealing. So what we have done finally here is that this started off at around 12 centimeters. Now we made it around 15. So there are 3 segments, 5, 5, 5 in the lower half. Similarly here, 5, 5, 5. And these ones, as you start taking them from the upper aspect of the umbilicus at 12 o'clock position and slowly curve them down to join this, these are approximately 6, 6 and around 7. So what we will need to do is we'll need to steal in these medial segments. To prevent a dog ear in the lateral most part, you always suture this, in the first 3 centimeters or so, you always suture it edge to edge, meaning you do not do any stealing.
Yeah.
And all the stealing is done beyond these 3 centimeters. Otherwise, if you start stealing from the edge only, then you invariably land up with a dog ear at the edge. Or if you have a dog ear, then you have to need to extend the incision even more laterally. First take care of the dog ear here, about 3 centimeters or so, and then start your stealing. So that's what this marking is for. Okay, and we are going to start with infiltration first, and then obviously liposuction. So let's do that.
Regarding liposuction, I have a question. The area marked round to do the liposuction, where the vessels perforators are coming out, is it ideal to do that liposuction in that area?
Which one? Where?
Upper part, the round markings.
Here.
Yes, here.
Yeah. Okay. So in 2023, there is no contraindication to doing liposuction here.
Yeah.
In 1980, there was. In 1990, there was. In 2000, it was okay. But in 2023, there is absolutely no contraindication, provided you know what you're doing. So when you do liposuction, the tunneling has to be such that there is no lateral, shearing. There's no lateral shearing. So you are dependent on that kind of liposuction to make sure that the perforators that actually not really periumbilical or anything, the ones that are around the rib cage, this is a rib cage, this is a rib cage.
Yes.
So you expect some perforators here along the rib cage. Those you try not to damage by liposuction. We are definitely not going to damage them during the tummy tuck because our dissection is going to be practically within the central median part only. We're not going to do any further this thing there. Yeah. So as long as you do that, you can completely do aggressive liposuction in the entire area. It doesn't matter. Unless the patient is a smoker, unless the patient's hemoglobin is low and the proteins are low. which is where the healing is the problem. It is not the perforators. This is just a single skin envelope. It's not going to cause any problems. This is a a flap that everybody would want to have. Yeah.
Yeah.
एक काम करेंगे जस्ट एक वाटी में पहले एक थोड़ा सा बस हमको इधर इन्फिल्ट्रेट करने के लिए थोड़ा लगेगा तो पहले ये जरा डिटैच करो वाटी में एक 50 cc या किडनी ट्रे में पहले एक लेके रख दो या एंड दिस वी विल यूज फॉर इन्फिल्ट्रेटिंग हाँ उसमें कुछ नीडल वीडल डाल के रख देना सो दैट वी डोंट यूज इट फॉर एनीथिंग एल्स हाँ उसमें गॉस पीस कुछ मत डुबाना एक बार ये खोले अभी लाइपोसक्शन तो बाहर है एक बार खोलेंगे तो नो गॉस पीसेस एब्सोल्युटली नो गॉस पीसेस
Another question is at supraumbilical area.
Yes.
Do you prefer to put a lifeboat at junctional suture areas?
You prefer to put a what?
Lifeboat, that triangular flaps.
Triangular flap? No. That is जमाना गया. 50 number blade. ये इसका हवा निकाल दो.
Excuse me, sir.
Mosquito.
So the patient has undergone 2 LSCS. Is there any incisional hernia or divarication?
There is a divarication supraumbilical. It's a narrow divarication. We've already noticed it. Yes, so we will be doing a repair of the divarication for sure. बराबर उधर ही एक वेसल निकला ना इसको थोड़ा सा सामने ले थोड़ा लूज give me a mosquito.
Where exactly you put your that liposuction?
One more mosquito. Yeah, थोड़ा ऊपर चाहिए. Table height up, please. This is.
It's not holding. Just give another one.
No, it's holding. I'm just clamping it and releasing it. Just my luck that the very goddamn thing. There is a vessel right there. Leak मार रहा है क्या? नहीं ना? Is there any way of doing simultaneously on the other side as well? Do you have a second one? No. Okay, it will take 5 minutes more. Doesn't matter. Okay, now think about liposuction of the torso. Ideally speaking, the patient must have a pillow under her torso. Yeah. So that the curvature of the abdomen is convex. There's something under this thing. Because when you do lipoinfiltration or liposuction, you must go from a low area to a high area, which means that you must go upwards. Your liposuction cannula must be directed upwards and not downwards. So one way of achieving that is to put a pillow under the patient's narrow pillow under the patient's back. हाँ चलेगा ना है तो दूसरा 1 लीटर लिया है ना we'll save some time.
What is the composition of your that lotion you are
we have put, in 1 liter of ringalactate we have put 2 ampules of adrenaline.
Okay.
Correct? And 25 cc of 2% xylocard. CARD card.
Yeah, not xylocaine.
Not xylocaine, xylocard.
It's hard
protective and the toxicity is
less.
Little less. This artery forceps has no business here, but as I took the incision, I
right over the vessels, I think.
Directly on the vessel. So just my luck has held since morning. Now it is slowly changing.
Yeah.
Yes, all liposuction. And at the end of liposuction, if it's only liposuction, we use triple diluted 0.5% levobupropion. So we will take one vial of bupivacaine. अरे बोलो ना मेरे को. Of 0.5 levobupropion we'll take, and then we will add 40 cc of ringalactate or normal saline to it. In fact, one of my senior anesthetists, Dr. Ambardekar, is now almost 70 plus. He tells me that rather than adding normal saline or ringalactate to local anesthetic, you must add distilled water because it makes it a hypotonic solution and it spreads better.
Some people use hyaluronidase also.
Yes, yeah. So I have a story about hyaluronidase, which I told these people. But yes, you can use. About 7 or 8, not 7, about 9 or 10 years ago, I had a patient who had done practically about 1.5 liters of liposuction on in the tummy. And post-operatively, the patient went into acute tubular necrosis. Then, of course, we didn't know why. So she was given the Lasix challenge, 20 milligrams of Lasix, then 40 milligrams of Lasix, then 80 milligrams of Lasix, until 1 gram of Lasix. At the end of 4 to 6 hours, the urine output was about 10 to 20 cc.
Okay.
So I consulted a physician. A physician asked me to consult a nephrologist. And there's a very good nephrologist in Mumbai called Dr. Vishwanath Billa, one of the top nephrologists. The first question he asked me is, what was in your infiltration solution? And when I told him I had put in hyaluronidase, he said, "Tu to gayo." That's in Gujarati means "tu gaya." So then I personally took the patient in my car. In those days, I didn't have too many resources, to another hospital nearby, admitted under Dr. Billa. He also gave some Lasix and something else. Finally, they had decided to do dialysis on the patient. When they were planning to do dialysis at 8 o'clock, at 6 o'clock, the patient started passing urine. So simultaneously, my bladder, which had also been under severe stress, also released itself.
Okay.
So I have never again used hyaluronidase in my life.
What is the cause? That nephrologist.
Yes, so there apparently are 2 or 3 reports that hyaluronidase causes acute renal shutdown. It's like Voveran. How often do we use Voveran? Yeah. Voveran we use like water. But do you know that Voveran, just one shot, suddenly even a patient who's tolerated Voveran before can just cause renal damage.
Yeah.
So अभी क्या कर सकते हैं?
Sunil sir is asking what any special type of dressing to be put
Where? अच्छा उधर. हाँ तो L और J है ना, उसके ऊपर गॉस पीस डाल के just press it down with some compression. दोनों साइड का L और J, और बाकी नॉर्मल जो है वैसा नॉर्मल ड्रेसिंग just cover all around the area. That's all. में भी हाँ just इससे करने का है, just some compression there, just some compression. So just wish me luck.
So one side is over 1 liter. No?
Yes. Yeah. Doesn't have a brother on this.
Your incision is just above anterosuperior iliac spine, or
Where? This incision?
yeah.
No, this ASIS is here.
Okay.
हवा निकाला था ना, थोड़ा हाइट बढ़ा सकते हैं क्या उसका? नहीं ये आईवी स्टैंड का. Yeah, so there's one more, there's a good question. Just small trick about infiltration and liposuction. When you do infiltration in the flanks, whether it's the love handles or whether it's you do the back, don't infiltrate the gravitational areas first. Yeah, because you're doing basically tunneling, right? So infiltrate into the areas which are not where the fluid is not going to settle down first. Because if you infiltrate the other areas first, then the moment you create tunnels in the upper area, everything then just goes straight down. So always do the sides first and then go down towards the flanks.
Okay. And that is the most vascular area also.
Which one?
That flank and love handle and back to that.
Yes. And when you change direction, what is this? अच्छा पीछे का साइड का, this is not going to cause any problems. Huh? What is it? Okay. Yeah, बंद करो पहले. उधर बताओ.
Normally we use that infusion pump.
No, we use normal this thing only. Yeah, we don't have this. We don't have this. Yeah, it's a direct, just a cannula with multiple holes. बहुत ज़्यादा tight हो गया लगता है.
Why you prefer bupivacaine?
Yeah, it's faster as well, but this takes another 5 minutes more. It doesn't, not such a. जा रहा है ना? जा नहीं रहा. अच्छा, you've not opened it. Okay, so when you're changing directions, pull all the way out and then go back in. Yeah.
Yeah.
Your tunnels are perpendicular. Your tunnels are parallel to each other, and you're not creating any of the shearing that I talked about. Because
Okay.
when I do this and then I come in and then push around to this side, I'm actually creating a shear force. So pull out and then go back in again, and always bimanual. Always. However many liposuctions you have done, always bimanual. Yeah. So you are always feeling the tip of your cannula, whether it's infiltration or whether it's liposuction.
Why do you prefer bupivacaine?
Sorry?
Why do you use that bupivacaine infiltration?
Bupivacaine is later on. Bupivacaine is not now.
Okay. For post-op analgesia.
Yes, that's for post-op analgesia. See, when I'm changing direction, I'm always coming back out and going in again. Yeah, I'm not turning from side to side. कितना बाकी है?
Doing it deep to superficial.
Deep to superficial. In tummy tuck, really, we don't really do much superficial liposuction. We're always a little worried about the vascularity of the skin envelope. So we try to stay deep, and here really in such a lady, she's not obese by any sense of imagination. So this is basically to, do discontinuous dissection more than anything else. We're not going to get a lot of fat by liposuction. She's certainly not going to lose a lot of weight from the lipo.
So what is the difference of feeling that I am in superficial or deep in this hand?
No, deep means you are on the fascia. You have to be on the surface of the fascia. Absolutely on the surface of the fascia. So that is deep. And superficial is when you can actually see your cannula. See, this is superficial. Yeah, you can see the cannula. Yeah. So here, where can you see? You can just see the movement. So I'm actually directly on the surface of the deep fascia. 200 बाकी है बोला ना? Yeah, little bit I want on this side. Oh, sorry. Yeah, I'm
So
not used to this.
all of the infiltration is just done just above the fascia.
Yes. In tummy tuck, when I'm doing a tummy tuck.
Okay.
When you are doing liposuction, when the liposuction is going to be aggressive liposuction only, then you are going to do it in all the planes. You're going to come as much as almost, subdermal, because you want the skin to shrink, right?
Yes.
But here it's a question of vascularity more than anything else. So don't take too many chances, because you are going to cut right at the top. Everything is going to come from the bottom. So, and we are going to stretch the skin envelope as well. So, that fat envelope is also going to thin out. The last thing is the subscarpa fat is going to be removed. It's parasitic fat once we raise this envelope. So we are going to remove the subscarpa fat.
That will be transferred. Like a man, new umbilicus will be used. If you are doing this, there is every possibility to hit the umbilicus and.
No, I'm not going anywhere near the umbilicus, because here I'm not anywhere. This is an area where I'm not going anywhere. Yeah, so. Done, khatam? Oh, very good.
So you will be doing all infiltration from this one incision on one side, not from the.
No, it depends. If I'm getting access from one incision, yes, but otherwise, like I said earlier, access is the most important. Yeah.
Sir.
And in this case, just give me थोड़ा जो भी बाकी है वो finish कर डालेंगे. क्या हो रहा है, वो निकल रहा है क्या? So access is important. Here I'm able to do everything from one single access incision, so I'm using it. But this particular skin apron is going to all go off, so I can take the cut anywhere in the skin apron. The lower one, I mean, the infraumbilical.
Sir, any other favorable positions for incisions?
Yeah, so umbilicus is one. The
Sir.
actual 12 o'clock position of the umbilicus is a perfect area. You can also take in a female patient, you can also take in the inframammary fold. That's a very good area to take for the upper part of the abdomen. Chalo, done. Okay. So we have already done this almost 10 minutes ago. No, that's enough time. We'll just give it 2 minutes more, just for luck.
What is the waiting period? Means how much time?
So that's always a good question. Ideally speaking, you must wait at least 15 to 20 minutes. Yeah. Okay. So because as it is what we call the what is it called? What reaction is it called of adrenaline? It happens in the first 7 minutes. No, it's ulta. It's called some reaction that causes the adrenaline actually to cause vasodilatation, and then slowly after 7 minutes, the vasoconstrictive action starts. I've forgotten the name of it. It's called some reaction. You boys, young people should know, yeah. Right? MCH. Flare reaction. Okay. Flare reaction. So the flare reaction takes 7 minutes. चलो अभी ट्यूब कौन सा आप यूज करते हैं? ये कोलैप्स नहीं होता है ना? डजंट कोलैप्स ना? ओके, नहीं अभी चालू कर रहे हैं.
So how do you decide how much fluid is to be given?
Sorry?
How do you decide how much fluid is to be given? Is there any?
How much fluid to put in?
Yes, sir.
Yeah, so see, what we are doing here is what's called super wet lipo. So super wet lipo means approximately between 1.5 to 2 times what we are putting in. Tumescent is probably slightly more than that. Yeah. So you go into an area and you wait until you have lost resistance in that area.
Okay.
That is what super wet is. But when you do superficial liposuction, you will never lose resistance, because the dermal fibers and the subdermal fibers are such. So there you have to basically see for blanching.
Sir.
Yeah. Now again, there's a question straight away in Indian patients, how do you look for blanching? So you can't see blanching basically by just looking at it. So you have to press on that area and see whether it actually blanches or not.
Okay.
That's when you know that you have done enough superficial lipo infiltration in that area.
Sir.
Yeah, so that's tumescent lipo. Tumescent liposuction is not really necessary. Tumescent lipo, you might want to do a little tumescent lipo when you're doing under local anesthesia, because you can fill it a lot more with fluid, reduce the concentration of lignocaine in that area. But otherwise, tumescent lipo is not really, I mean, super wet is the best way to go. इनका hemoglobin कितना है? 12.8.
So like you said that you infiltrate in the gravitating position like last. Similarly, while suctioning also, do you have something of this sort that the area where the fluid will gravitate, you will not suck there
Yeah,
first?
yeah. So, see that's a really good question once again. You can liposuction in any area, no problem. Superficial, deep, you can go to the gravitational part, you can go to the upper part. But in the end, always go back to the gravitational part, what is called toilet liposuction, right? So that is where slowly after you finish everything, no, you will find that everything, whatever fluid is there, has gravitated there. So take those 5 minutes to go back to that area and suck once more. And what you're doing now is not really sucking, the fat so much as what has gravitated there and cause, the fluid accumulation there.
What should be the ideal blood pressure during liposuctions?
What should be the ideal?
Blood pressure.
Blood pressure.
Yeah.
Yeah, I would say probably 100, 110, not less than that. कितना है? No, 1 liter, no? 1 liter we infiltrate.
Body estimate.
500 का 2 किया ना?
Suction looks little bit bloody.
Sorry?
Liposuction you are doing now, that the tube is swinging.
Suction is bloody.
Yeah.
BP is? Okay. Yeah, it's okay. That it's not bloody really. It's a little on the orangish side. And flanks will always be like that. Flanks, if you start getting yellow, something wrong with the patient.
Yeah.
The upper abdomen, you will get nice and yellow, this thing. Yeah. So flanks, you'll always get a little bit of this thing. Ideally speaking, I wouldn't do the flanks first. But since right now I'm doing the lipo alone, I want to finish this off in the flanks and then go to the top. And the top also, we are not going to do a lot of liposuction. So this is the area which is actually quite concerned about, according to Dr. Jayan. So we are finishing that area first. Yeah, bus. Yeah. Yeah, bus. ठीक है.
So you always put some bolster like a thing on the back.
Behind, yeah.
Should be convex like. I think change the section part. If you do liposuction first for only abdomen,
No, there shouldn't be anything like abdominoplasty now. It should always be lipoabdominoplasty. Yeah, that is historical, really speaking.
better mobilization of the flap. Better mobilization.
There have to be some very specific indications why you wouldn't do lipo in an abdominoplasty. Okay, we'll come back to this area again. Let's here you might probably see, if you are lucky, probably see slightly yellower fat.
Yeah, that.
Yeah, I think we are already seeing better quality fat here. Planks are always a issue. You can't blame anyone except, never blame yourself for anything anyway. The other thing about liposuction, of course, it is your individual choice, but my opinion, for whatever it is worth, is that shouldn't use any cannula other than 3 millimeters in any liposuction. You have much better control. You have much better possibility of finesse. You just maybe require an hour extra or a couple of hours extra. But the big chunks of fat that you get removed with 4 millimeters and all that, you can avoid, especially if you intend to do superficial liposuction. Because very often you will find that you'll end up with contour irregularities because you use large cannulas.
Do you use that holes,
Anyway.
multiple holes on both sides, or?
It's not a good idea. You are unnecessarily, see, this abdominal, this is area is also practically where the upper part, practically where your perforators are, which are coming from the ribs. So it's not a good idea. You can always tell the patient that what we are giving you is removal of the skin and taking care of your divarication and all that, and it's not safe for you. You can always come back for liposuction after anytime after 6 months. We can do that for you because the fat apron has settled, blood vascularity has, the vascularity has re-established itself. Then you can do.
Different sitting it can be done.
Different sitting it can be done, no problem. But at the time of lipo, you would be very brave to do very aggressive liposuction in that area. You shouldn't do it. Yeah, so here is a place where she already has a dip. So I'm actually lifting up the tissue here and going only in the deep areas. Yeah, so that I don't create a further dip. I'm just creating a discontinuity of the fat apron so that it comes down.
How you decide how much fat has to be removed in particular area?
You see the contour and you see the skin pinch. And you see, like they used to say when we were training, as long as it's yellow, you can go ahead. When it starts becoming orange, just like at a traffic signal, it's time to pause. When it becomes red, it's time to run away, give it to your assistant and go away.
Okay.
Razor, I think less of.
Yeah, razor usually. Yeah. So again, I'm not coming superficial at all. My cannula is rubbing the surface of the fascia. So one way of making sure that you're not doing only the lower part is to turn.
Okay.
Yeah, this is there. The cannula holes are on the underside.
Yes.
So you know this is the thumb rest. So you turn and do lipo. So now we are doing the upper part.
Okay.
Yeah. And always buy manual. The tip of the cannula has to be felt by the finger wherever you go. By the time we come back to this area, you'll find that this is all swollen up. Yeah, especially the most dependent parts. So we'll do a little bit of toilet there. Yeah, this is a accelerator, the 5-hole cannula. It's quite powerful.
Is it 3 mm or 4 mm you are using?
They tell me it's 3 mm. Yes, it's maybe 3.2.
4 mm it is. 4 recovers.
So 4 mm cannula. Oh dear. Yeah. Okay. I've been telling you all this time not to use 4, and we have a 4 mm cannula here. I thought it was a 3.2. It didn't look like a 4.
No, power as it. Looks like manual. Power assisted writer use it. Yeah, looks like chadda wala. সেটা হাতের কন্ট্রোল রয়েছে ফিক্স ফিক্স
Fatigue, yeah, you do, but while you're operating, you don't generally. उसके बाद में ही चालू होता है. When the adrenaline rush wears off. But generally we operate from 7. We start. Generally finish at 4:35. So used to it.
So how much suction pressure is there?
Yeah, 7 means I reach this thing. By the time the patient is reduced, we start. It's 7:45 or so. Morning walk. वो क्या रहता है? Not really there. Not really.
Will you remove the fat of skin side like dermal side fat?
I can't hear you. What?
Will you remove the fat on the dermal side like skin liposuction?
Dermal side.
Yeah. Means you are superficial liposuctions. I mean.
Here you are saying in the flanks.
Yeah.
Yes. So I am superficial here. Can you see it?
Yes.
Yeah. But because here now I'm not worried about vascularity here, and I would like this to contract. No, okay. Now that we have started this, the tunneling has been done with this thing, no? So, yeah. So the other this thing is that when you do tunneling with cannula, you should use the same cannula for aspiration. Which? Before? Marking won't change. Why will it change? Tissue. No, she doesn't have any history of cancer, no? Yeah, so not necessary. And we have not found anything suspicious. Yeah. क्या उसको नीचे compression दिया है क्या? J और L के इधर just put a gauze pieces and compress it down so that it's flat there. बोला था मैं.
Sir, Dr. Chaudhary wanted to know how much is the suction pressure?
I would imagine it's a 1 full atmosphere, but anything more than 600 is fine.
Okay.
600 millimeters of mercury, anything more than 600 millimeters is okay. If you are harvesting fat for grafting, that's a different matter. Then I would actually not use such high suction pressures. 1. Number 2, I would probably use a 50 cc syringe to harvest fat. Or if I had to use Razor or something like that, I would probably put this thing at around 350, 400, not more than that.
Presently, are you using that central suctioning or any special suction
To be
system?
honest, I don't know what we are using. Central suction we are using.
Okay.
Which is absolutely, it's not completely ideal because central suction doesn't give you that kind of suction pressure. You need a good liposuction machine. Madela makes a beautiful liposuction machine. It's worth an investment. Again, I have no financial interest, but sorry, Madela.
Mitocon people, they are.
Mitocon is marketing it, is it? Okay. It costs around 2.5 lakhs, but it's of course manual, but it's excellent. You want manual and you don't want to spend on power assisted or a Vaser. I think manual is still a good, practically a gold standard.
Yeah.
Indian, no, it's a UK company or a European company.
It is manual.
Manual, but it's very good.
It is suction machine.
Yes, yes.
So what is your experience with the manual and power assisted advantages, comparison?
Yeah, okay. So between manual and power assisted, it's really the surgeon's effort that is the difference. I don't think there's any other difference at all. But when it comes to manual versus Vaser, skin contraction is definitely better with Vaser. There's no question. Power assisted is really basically you are reducing the surgeon's fatigue if you're doing mega liposuctions. You're reducing the fatigue. Otherwise, there's really no advantage.
Dr. Chaudhary is asking about ultrasonic liposuction.
Sorry?
Ultrasonic
Ultrasonic
liposuction.
is Vaser, no? Ultrasonic is Vaser. Vaser console costs, if you haggle with the person, console costs around 19 lakhs or something like that. If you buy it with the infiltrator and all that, then it comes to around 40. But you should be able to get it for 19-20 lakhs with a couple of cannulae and at least 3 Vaser probes. अभी शायद थोड़ा बढ़ गया रहेगा, but I'm talking about a couple of years ago. Okay, we are all right otherwise. Let's keep it more here. चलो मेरे को इन्फिल्ट्रेशन के लिए जरा 10 cc या 5 cc सिरिंज में डाल के मिलेगा. Let's do that. बाद में बाकी का liposuction थोड़ा 5 मिनट करते हैं और we just infiltrate and keep the incision ready. Yeah, उधर से can you do it from that side as well? Yeah, along this line. Marking pen है क्या? Yeah, along this line. Yeah, only the lower part. Huh? We don't need to do infiltrate the upper part. And that also, this last part we are going to take to avoid the dog ear. So you can infiltrate actually from here somewhere. Intradermal. Huh? इसका सिजेरियन का गायनेकोलॉजिस्ट कितना अच्छा है अपने को अभी समझेगा. How much scarring he or she has left behind. Yeah, it's always better with a smaller syringe. Yeah. Yeah.
26.
Just give me some more.
Give it 2 ml and
नहीं आप don't waste मत करो, अभी waste मत करो, तो हो गया. और सुबह से already बात हो रहा है, but ठीक है, doesn't matter. इतना ही बाकी है. इसमें है ना, ये क्या है? Okay, there is ना more. Why giving me 5? पूरा भर के दो ना. नहीं जरूरत नहीं, डोंट वरी. 26 गेज नीडल ऑन 10 cc सिरिंज मेरा तो दम निकल जाएगा.
Umbilicus.
So you are infiltrating around umbilicus, anything particular?
Sorry? Yes.
Infiltrating around umbilicus, anything particular? Yes.
No, just to prevent a little oozing that is irritating there, that's all. This is where we are going to split the apron into two parts. So might as well infiltrate it, otherwise it unnecessarily edge, the skin edges ooze a little bit. So we are, and basically we are giving it some time. Chalo, let's have the cannula again. One second. Liposuction का machine लिया नहीं ये department में? लेना चाहिए. You should have one machine. You must have. Power assisted. Okay, okay. No, manual lipo machine. You must have a backup always. Manual lipo. Yeah, anesthetists can also use it for normal liposuction if you like them. If you don't like them, it's a different matter. Yeah, so now what I'm doing is the toilet, right?
Yeah.
Just going to very quickly move and suck out. Not really intending to do any. And what you do is you press down. No, don't do that. You press down, so you're collecting the fluid above your hand.
Yes,
And you're sucking on it.
yes, sir.
The other thing we will observe is that the maximum edema will be in the most dependent area. Yeah.
Yes.
So if you have done decent liposuction there, you ignore it because once everything settles down, you know what you're going to get.
Yeah.
No point in agonizing over it. Kyare idhar वापस swelling क्यों हो गया?
Right.
See, this is toilet lipo. You can see the awaaz, no? So basically, we are just sucking out whatever fluid has gravitated down.
So.
It's the typical noise of a partially blocked cannula. कितना आया फैट अबाउट 500 cc आया 600 cc आया okay, that's not bad. That's approximately what we would expect. Yeah, we were not expecting any too much fat. They're basically giving her some nice contour. Chalo, thank you. Sure, we have waited enough. 15 number blade. So we are starting the tummy tuck now.
Yeah.
कॉटरी लिया है ना और एक आप किसी के हाथ में एक प्लेन फोर्सेप एडिशन ले लो so that you can catch and cauterize फटाफट as we अच्छा blade please. Yeah, in the end I might once more. Normal cautery नहीं है क्या? The flat one. Normal वाला देना, flat tip वाला. I'm not used to this this thing. You guys use this more? Yes. Okay, no, I'm not used to it. What is the advantage?
Final dissection cuts.
Okay.
Okay, sir.
Less current, sir.
Okay.
Colorado tip.
What is the level of dissection here?
Sorry.
What is the level of dissection over fascia scarpa or
Yeah, so we are going to go subscarpa.
Okay.
This is there. We will come back there. This is there. Sure. You hold that quadrise. Yeah, no, hold it lower down so that you're going to cut in that level. 40 बढ़ा सकते हैं थोड़ा सा please. 40 करो. Catch it again. 35 कर सकते हैं. Yeah, this one here. Yeah. Okay, that's our scarpa's fascia. Can you see it?
Yes.
Now there are some people who do really beautiful abdominoplasties as suprascarpa. Dr. Aditya Agarwal from Medanta is one of them. His results are really, really good and he does suprascarpa. We've tried that suprascarpa. I was not very successful doing it as well as him. So we reverted back to as Dr. Aditya has shown in quite a few presentations, the seroma rates are pretty low because he goes suprascarpa.
Yeah, but difficult to delineate that.
Yeah, so it's a difficult dissection. Quite obviously, he's a better surgeon. Can you hold that?
Skin के नीचे पूरा. Skin के नीचे पूरा जाना.
Okay, that was not scarpa. You might mistake this as scarpa. That is the superficial fascia. This is scarpa. You see that? See, now I'm cutting it correct. Okay, so let's go from an area where it's virginal because this the LSCS will be scarred. So let's go here. Can I get a tooth forceps now? Okay, now all the fat below the scarpa's fascia, we are going to keep as far as possible for at least 7 to 8 centimeters.
For better lymphatic drainage.
Yes. No.
Idea is to lessen the serum.
Yes. Here, because of the previous LSCS, we probably will be forced to go directly onto the
Fascia of the
onto the rectus fascia.
Yeah.
Probably. Let's see. Up till here, I can see a good scarpa. Up to here also, I can see a good scarpa. There is no good scarpa. Yeah, you just need to hold. Yeah. नहीं हाथ से मत पकड़ो. Just use a forceps ना. ये forceps मैं जैसे पकड़ा इधर scarpa के. Yeah, use this ना. Yeah, hold that. No, I don't like a cat's paw sometimes. You can definitely use. No question.
Anyway, that flap will be discarded. Are you not preferring to use that Alice?
Sorry?
Anyway, you will discard that portion of the flap. So are you not using Alice on that?
I don't know what he's saying.
Anyway, this portion of flap will be discarded. So we can use Alice to hold it. It will be easier.
What? Alice forceps. Yeah, of course you can. It's what you're used to. But it's an excellent suggestion. Thank you. Be very careful in the region of the LSCS scar, because you never know what the gynecologist has done previously. You can always go back and excise, go back and go deep and excise some fat. But wherever you can see fat, stay in that plane. You're almost past the scar now. Okay, now you can see the fascia is, rectus fascia is visible here. Okay, you have gone approximately about 3 inches, 7-8 centimeters. That is more than sufficient. You can also elect to go all the way to the umbilicus subscarpa, but it's not necessary. आराम से. Okay, let's see where the umbilicus is. We are still far away. Can you hold that?
Well, Dr. Milind,
Yes.
this is just a lighter sense because post lunch many are just enjoying the surgery. Obviously, Professor Dr. Suresh Gupta from Gangaram, he used to still tell this obstetrician that when I am going to stitch the cesarean scar that will happen after my stitching, my remuneration or fees will be 500 more than the obstetrician, because the rest of life she will be seeing this scar. If it is good, then she will relish. And what you do underneath beneath, after the delivery, people forget. So you rightly told
Okay, nice.
the scar by
Okay, chalo, we are almost there.
obstetrician,
Tooth forceps, please.
not that what you really put it.
Chota
So
wala? Yeah.
the revision of this, you can
Hold
make
at 6
far much
o'clock.
better than what has been done before.
Huh? Yeah. छोटा वाला है और एक एडिशन will be difficult for you. It's too fine. 15 number blade, please. Tooth forceps. दूसरा एडिशन है. ये tooth ही है. अच्छा. Just hold it. See whether you can. Okay. Okay. Now in the umbilical stalk, you should not have anything more than umbilical skin. When you have anything more than umbilical skin, that skin gives trouble. Yeah, because it actually belongs to the abdomen. So that is why the marking of the around the umbilicus. Huh? Yeah, sure. Can you hold the other side of the forceps? Yeah, this edge, other edge, here, this edge. Blade नया है. New blade, please. I'll take it. Yeah, just give me a new blade, please. Yeah, we do that. हम लोग को this is the way we do it, so I'm showing that. We can always do that, yes. Blade.
This question is in under the door.
This one.
Huh?
This one.
Upper portion has been undermined. You cannot undermine the lower one, because otherwise the mons will come up to the.
Keep holding.
Citation has been done. So have you got an experience with barbed features?
Yes.
And are they only marketing?
No, they are good. We routinely use Stratafix for closure. Abdominoplasties for the last 2 years, we have been using only Stratafix, single layer, straight. But it doesn't mean that you can't do without them. Yeah, everything has a. Stratafix, one suture is 1400 rupees. Just hold here. So what I do is we like to mark the 12 o'clock position with a small little cut, and we like to mark the 6 o'clock position with a small little cut, so that when everything is being replaced back and the fat apron has been pulled up, we are not twisting this thing. I need a steely scissors. नहीं जरूरत नहीं. There's no need. No need.
Looking like measurement. There is no difference. With the needle difference.
चलो. Okay. 15 number blade. Okay, now it's time to split the the skin apron. This is what I was infiltrating this area for. And if you remember your Gray's anatomy says that this is a watershed area. There should be no vessels coming across it. So the person who wrote Gray's anatomy had no clue what he was talking about. Pottery, please. There are routinely lots of blood vessels crossing the midline. In fact, when you do your DF flap, if you are looking to use anything beyond the lateral area, then you have problems with your actual perforator and your inferior epigastric. This is something that can save you. तुम मत निकालो और ये मत निकालो. Yeah, I want that to protect the umbilicus. Now you'll start seeing all your lovely periumbilical perforators. You see that there? थोड़ा ऊपर भी पकड़ेंगे. Okay, and one tip about the periumbilical perforators, never cut them at the level of the fascia, because if they withdraw inside, you're in trouble. So this is one area where you cut them on the apron. So you have something to hold on to in case the okay. So now we are going to try to protect the umbilicus only with forceps, not with your hands, please. Only with your forceps. Yeah. Yeah. No, just hold the edge. Hold the edge. Take a tooth forceps, hold the edge, and don't stretch or anything too much. It's yeah. Hold this, please. This is a nice perforator. Niche. Yeah. There's also a nerve in it. क्या पता क्या है? Okay, so now we are entering our lipo area, as you can see. Okay, at the moment, so let's go on this side. आराम से जरा ये अगर रिट्रैक्ट होता है ना तो लफड़ा होता है. Yeah, here perforator. We'll go as high as we need to so that the apron comes down. The moment level, yeah. So yeah, there you go. It's gone inside. एक mosquito मिलेगा, please. It is around above. ना जिफिस्टनम तक अगर लगेगा तो ही जाएंगे, नहीं तो जरूरत नहीं है. Mosquito, another mosquito, please. Plain forceps then. Just give me a plain forceps. Light थोड़ा सा मिलेगा इधर, little better light. Yeah, suck inside. Suck. We'll need a vicryl later on for this. Yes, if we need to go. Yes. Scissor, lateral, just paramedian, not more than that. Got it. Patient is okay now? Patient is fine? Yes.
So above umbilicus, you will go just paramedian up to the paramedians along the
Yes, the lateral borders of the rectus muscle. Some crap here. क्या था वो? Yeah, holding this now, use a mop. Yeah, if you are holding the edge, I am underneath now. Yeah, if you are holding the edge, use a mop. Light inside, please.
Light.
Yeah, now we are again in the area of the liposuction. No, no, it's good. Yeah, if you could, it'd be nice. Yeah, yes, आराम से just give a नहीं lateral border नहीं, medial borders, medial border of the rectus. You don't. भी बोला और मैं ही लफड़ा किया. Mosquito. Yeah, can you touch me? अंदर थोड़ा लाइट चाहिए, बेटर लाइट प्लीज. Okay, now one beautiful way of doing this, just using 3 fingers. Okay, what you do is put your fingers there and press. No. See the tunnel they've created? Can you see the tunnel? Yes, sir. Yeah, 3 fingers. This thing is intact, and you've done discontinuous dissection all the way up to the Zippis tunnel. Right? And now all you need to do is see whether the rectus divarication is extending up to there. If it is not, I can just decide where I want to stop. थोड़ा सा उठाना पड़ेगा. Sorry to make you do all the मेहनत, but seniority has its advantages.
The divarication, can you define from here?
Divarication I'll show you once muscle आया इसके साथ. Anyway, this bleeding seems to have stopped. Patient's BP is fine. मेरे को एक वाइक्रिल दे दो ना. Can you give me a Vicryl? We'll forget later on. बाद में BP बढ़ेगा तो उसका ये करेगा. 30 Vicryl if possible. Anyway, we'll go आगे ऊपर. चल, we are almost done. Yeah, just lift, pass. Okay, the divarication is up to here. Beyond that, there is no divarication. It's here. Okay, so now can I get a marking pen? Okay, now let's see. Bring this down. It will come, no problem. Now, only thing that you remember is that when you repair a divarication, this shortens, right? So we'll see how that works. And we will also hopefully. Do you have a deverse or something? नहीं तो एक काम करो. नहीं, हाथ से पकड़ेगा तो बेहतर है. But if you are feeling hard, difficult to do it, then a deverse.
No, Vishnu is strong.
Vishnu is strong. Okay, we're just going to clear some of this fat. If you're going to repair the divarication, I want at least the edges.
On the inlet area, fat lateral area. You turn it both sides. Yeah. Deep
Chalo, marking pen.
laterally you can
So,
go this and this.
नहीं चलेगा ये दिखता है ना. That is the limit of your divarication. Okay.
How you decide how much tightening you need?
Just medial edge to medial edge. That's it.
Okay.
Yeah. Number one loop suture. No, ethylon. Number one ethylon loop. See how the umbilicus lies. No, see, now you have no idea which is 12 and which is 6 o'clock. So this cut will tell you.
So will you be using any mesh for the weakness of the muscle?
You can feel that the muscle is there is nothing in between. Here you can feel a gap. Feel it. Can you feel the gap? Yeah, upar jao. There's nothing there. Round body पे है ना? चलो, okay, tooth forceps, लंबा वाला. Yeah. Sorry, people will have to lift a little bit for me.
So will you be using any mesh for to counter the weakness of the muscle?
Not at all. Yeah, it's strong. It's going to stay there and it's not going to give any trouble. Yeah, so there's no need for any sting. All you need to do is full.
So between prolinon and nylon, what do you?
Proline, knotting properties are quite poor, no? You have to take multiple knots. It slips. It's not a good this thing.
But foreign body reaction is more in case of ethylene than proline.
Yes, I guess so. But I don't think that's a bad thing to happen.
For contraction.
You want good scarring, no?
Yeah. He's using ethylene.
Sorry. Did I poke you? I tried. Not successful.
Have you come across any respiratory distress following surgery?
Sorry, what?
Respiratory distress.
Not with so much this thing. Okay, yeah, that's a really good question. This is one of my pet questions. You are always going to go to the medial borders of the rectus muscles, right?
Okay. Yeah.
There is never any rectus divarication which is so wide that when you close it, you're going to get respiratory problems. And the anesthetist always will tell you, maximum respiratory problems occur with a tight compression garment.
Okay.
It is not the internal tightening that causes the compression, it is the external tightening. And we are going to ask the anesthetist at the end of this thing. I hope that their machine has this thing. Sorry. Yeah, I can't see outside my circle, that is why. So be a little careful. आपका हैंड रहेगा ना तो मेरे को समझता नहीं है किधर है. But yes, in obese patients, that's why I said it's a good question. In obese patients, always anticipate respiratory distress and keep BiPAP ready and ICU ready after a tummy tuck.
Yeah.
Okay, now I'm going to show you a trick of how to continue this around the umbilicus. Not the general surgery variety of, how to. Because when you go around the umbilicus, you are otherwise going to strangulate the umbilicus.
Yeah, that will hamper the vascularity also.
Sorry?
That will hamper the vascularity also, that umbilical.
Yes, correct. Yeah. So what you do is you come close. Let us see what our umbilical this thing is. This looks like it's not being twisted. Hopefully, yeah. Dr. Rachana, can you see any twisting? Vishnu, any twisting? Sorry, I forgot your name. Kaushik, any twisting? Okay. So if there is any twisting, 3 people have told me there is no twisting. They are going to blame. Okay. Now this one, you don't.
Will put the knot, yeah.
Lock. Okay. Bring it around. Just lax. Okay. And then just go by the side of the umbilicus. Come back to the opposite side. I need 10 ethylon, please, after this. 10 ethylon. Yeah, again, just loose, no locking there. And then you go back to locking from here on. Okay. Because remember now this force is this direction. The locking is not pulling in that direction. Okay. Yeah. एक mosquito लगाएंगे इधर. Just hold that there. नहीं, उल्टा उल्टा. छोड़ दो.
Somebody tried it. Number 1.
Cut, please. I'll short. Okay, Vicryl, please. Oh, निकाल दो, please. Vicryl.
Finish the down one. Do it like.
You're going to bury all the way.
Yes.
Number.
Why are you putting Vicryl there?
Just burying the knot.
Okay.
Yeah, buried the knot. Not palpable anymore. Knot is inside. You always find tissue here.
Plication will not go down.
Sorry, what?
But plication you stopped there, you will not go
No,
down.
there is no divarication. Why plicate? What's the reason?
The abdomen
Divarication
looks
ended there.
lax. Abdomen still looks lax, so that's why.
Yeah, but see, this is where if you start making the abdomen tighter, this is when you feel good on the operation table and not so good at night. Neither does the patient feel so good at night.
Okay.
You should stop at this point. Okay, I need number 10 ethylon. Okay, so my second layer of suturing is going to be in the opposite direction. No, no worries, no problem. I need a mosquito to hold this, please. Yeah, hold it. Yeah, push it that side. Keep it that side. Just leave it that side. Once we take a couple of sutures, now we are just going to trim it off. Let it go. Let it just drop down. ये कटिंग पे दिया है क्या?
Anything specific, not putting mesh for countering the weakness of the muscle, there's
No,
laxity.
I don't think there is any weakness of the muscle. See, is there a hernia? The only reason for a this thing is a hernia. Divarication, why do you need a mesh? Caesar? बराबर उधर इसमें से गया ना, ये देना, just hold this up please. So we can just cut this off. Hopefully this is the problem with cutting here. ठीक है, no worries, चलेगा. Just hope and pray, believe in Lord Jagannath, and will not happen again. Two layers, yes. Yeah, but somebody had suggested, I think Dr. Raut had suggested that there is still some laxity, no further tightening. Yeah, so that is what causes problems. If there's a tremendous amount of tightening, laxity, then you do another line of suturing here. And yeah, plication on the two sides, but not there, not there. Yeah, it was a good question, but you know, we've had trouble too many times. It's continuously going through. नहीं, कुछ नहीं कर सकते उसको. का यही लफड़ा है. It will stop. Don't worry. It will stop. As long as it's not from the aorta, it will stop. Yeah, but then you know, then we will make Mainak responsible for the consequences, not the rest of us. Because he said even if it's from the aorta, it will ultimately stop. Yeah, I'll need a 30 PDS after this. Yes, please, round body. As regards that question somebody asked, I think the lady asked, my wife is a general surgeon, so sometimes she gets called on to do periumbilical hernias, and along with that, whenever there is a rectus divarication, they do what is called component separation.
Sir.
Yeah, and there they will put, in fact, she tells me, she prefers to put the mesh directly on the peritoneum.
Sir. Yes, sir.
Behind the rectus muscle on the posterior rectus sheath, and sometimes even below that, they create two flaps of the posterior rectus sheath, dissect out between that and the this thing, and then just put a mesh there, and they don't even suture it, which is where we have the arguments.
Sir.
But you can't argue too much with. No, I was going to say with general surgeons, not with wife. ओके, ये आपका सेंसर केन या लेवोबुप्रोकेन है क्या? वो एक 10 cc सीरीज में ले सकते हैं. लेवोबुप्रोकेन do you keep? Don't have. Sensor केन है ना? Yeah, 0.25% सेंसर केन. एक जरा, can you give me एक पूरा वायल दे सकते हैं? पहले झाइलोकार्ड डाला है. झाइलोकार्ड सेंसकेन इसमें डाला नहीं है. They are cut through. Yes. Yes, that's what it shortens. Yeah. Can you put a mosquito here?
Mosquito, please.
Here, here. Okay, छोड़ दो. Okay, out. Yeah, hold it to the mosquito again. No, both. Or this is soft ethylene. This is not going to cause any problems with the knot. Yeah. Chalo. Let's see now.
Come back.
Come back where?
From inferior to superior, because I think it's a fourth standard repair.
Yeah, no, but 2 layers is always better. Still bleeding?
Okay.
Okay, let's see. Okay, come. Can you come here? Okay, now let's see what is happening to the length, because we have tightened, but this also comes up very easy. Yeah, very easy, no problem. Okay, so now we will shorten the stalk of the umbilicus first. Now the thing to see is the umbilicus has 2 parts. It has a stalk and it has a funiculus, right? So the stalk is what anchors the umbilicus to the as a scar to the sheath. The funiculus is the funnel. Now, if the umbilicus has a long stalk, all you can do if you want to retain the umbilicus is to shorten the stalk and fix it to the rectus fascia. But if there's a long funiculus, then you can shorten the funiculus. Yeah. So let's see whether there is a funiculus or hardly anything. There's not much we can do about this. Yeah. So we are just going to leave it to, like I said, Lord Jagannath. चलो छोटा वाला मिलेगा या टूथ फोर्स Okay, so now this first stitch that we take, we shorten this further. And this is taken halfway up the umbilical stalk.
So what we are doing, we are reducing the.
We are reducing the stalk. We are fixing it to the rectus fascia at 12 o'clock and 6 o'clock. Yeah, short. ऊपर से ब्लीडिंग हो रहा है क्या? Where is the top? नहीं ना? Halfway up to the umbilical stalk. Yeah, the umbilicus is now fixed to the rectus fascia. वापिस चालू हो गया है. Stating है. नहीं उधर ये दिख रहा है. You can see the vessel there. Yeah, कट करो. स्किन आया.
Okay.
एक मिनट. नॉट जरा लूज हो गया. ठीक है. Let's see what that vessel is. You can see it oozing from there. On tooth. That's no worries. Okay. थोड़ा इसमें saline डाल सकते हैं. Can you just wet the fat with saline, please? Okay. I need the scale and I need a. Yeah. Nine and a half. Yeah, because this is retracted down. Yeah. So maybe around 10, 9.5 to 10. Okay. Yeah, just put fire. Okay. Is that sensor cane ready, please? Yeah. This rectal divarication is painful for the patient. Yeah. Is one of the player this thing? ये क्या है?
Yes, sir.
नहीं वो normal injection, normal needle. हाँ. Sensor cane है ना? 0.25. Yeah. You just inject a little bit of sensor cane again. Hopefully, this will not pierce any blood vessels. नीडल कितना साइज का है? 25. नहीं, ठीक है ना? It's okay. Yeah, this takes care of a lot of the pain. This is instilling. Yeah. Bus. Sure. Okay. 20 Vicryl, please. Any bleeding anywhere? Do you see anything? Yeah. Use a 14 number homoid. We'll be taking out from here in the arm. Yeah. Yeah. So do you want to show that Barudi stitches? We can do that. Yeah. So this is 20 Vicryl. We can use that only. Okay. So there is a request to show what are Barudi sutures. So you start from the bottom. So basically to reduce dead space. Now, while he is retracting, I am going to push forward. Okay, I am going to push forward here. No, pertinently means just bimanual. So I know where to take the stitch.
Only the this thing, not the
No, the rectus fascia say deep, yes, rectus fascia and this.
It's long artery.
Yeah. Okay, so this thing is fixed.
How many?
It'll take about 7 to 8 as we come progressively down.
Change the needle.
Can you cut that, please? उसका वो joint में बराबर वो अटक रहा है. We'll flip it around. Barudi. Barudi. Baroudi. No, I have switched the joint to the other side.
Especially if we do not want to put a drain.
No, we'll still put a drain.
So 1 inch or what? Then
Yes, approximately about a centimeter. This is basically reducing dead space.
So
The chances of seroma are less.
Pull-ups कट जाएंगे.
Hmm?
Pull-ups ही कट जाएंगे.
Flaps कट जाएंगे.
हाँ, pull-ups कट जाएंगे. अगर drain है तो.
Again, it's stuck. What will get stuck? The drain will get stuck.
Sir, we'll be putting a negative suction drain later.
Yes. I would still like to put a suction drain. Unless there's an objection and I'm overruled here, we are still putting a drain.
So this dead space can be
Sorry?
This dead space will be obliterated by the negative pressure.
Dead space, no. I mean, whatever seroma or whatever collection is there, we have done lipo as well, right?
Okay.
Yeah. So that hopefully will be evacuated by the drain. Once again, there is no harm in putting a drain for 24 hours.
Sir.
You remove it after 24 hours. You can sleep better at night. It's a closed system. There is no problem with infection or anything like that. The only thing that this does is going to make my life very, very difficult when I anchor the umbilicus. Very, very difficult. Yeah, now I need to push this down. Yeah, you can hold it. Yes, that's good enough. Yes, thank you. Sure. Because I won't have space, I won't have any this thing, but we will struggle. But life is a struggle.
Two in the midline and the one.
Yes, now I don't have space really on the sides. So I'm going to, ऊपर कुछ space नहीं था side में. It was only in the midline that I had space. It was a narrow tunnel. Okay, so you see the tunnel space has been, the dead space there has been obliterated. The chances of fluid collection, seromas and all is much less. And the flap will adhere much faster to the underlying. You have to push forwards, not because you break that. Okay, so every time I'm doing that, you have to push forward. Make sure I don't take it the same level, but slightly posterior to it. No, उठा मत, वो टूट जाएगा. This is a struggle, but it's always like that. You want to take Barudi stitches? No, this will find as a double loop. Two zero by. Yeah. So one of the places where you will not take Barodi sutures is that if you have done a rectal divarication repair and it has shortened your vertical dimension significantly.
Yes, sir.
Then the Barodi stitches will do it even more.
So
there you want to decide whether you want to take that chance because you don't want tension on your suture line. So what is the balance between tension on the suture line versus obliteration of dead space? What is your priority?
Tension.
This was coming very easily. So we got a little tempted. Let's see. Okay, so that at the end of this day, wonderful day, don't have to struggle to fix the umbilicus. I'm not going to take stitches in the midline. Ideally, I would take it somewhere close here. Okay, one I have space for. One I have space for here, not too close to the umbilicus. Yeah, but doing a tummy tuck, I don't want to do that. Yeah, pull it down, please. Yeah, lift it up again. Yes. Okay, so now the last stitches we are going to add. We'll see how it's sitting once again. Can you see the difference?
Sir.
It's coming still, but it is much tighter. But all this area now has been tamped down. Sometimes you in fact get dimpling here, but it's not an issue. Doesn't matter. Okay. I can still put one on the sides. Yeah, so we'll see that. We'll palpate it and we'll also take a measurement. Yeah, this is where the struggle is going to be when we make the hole for the umbilicus. Let's see what happens. The struggle is too much, then we'll compromise on the shape of the umbilicus. But let's give it a try. No, he's palpating that he's seeing there's some edema there, no, on the skin envelope. You can see the edema there. Sure. Okay. Yes, yes, very easily.
So you will not be defattening at the site of the umbilicus? Some
Yes,
defat.
we will, but I don't do it open. I do it once it's closed. See, the thing is with the Barudi stitches,
Sir.
that's practically impossible to do. If the Barudi stitches were not there,
Sir.
yeah, you pull on one side, it's in the wrong place. He pulls on one side. Yeah, pull it down, pull it down, pull it down. Yeah, at the same time with the other hand, you have to push this up. Yeah, the other hand, no, use this, your left hand, no? Use your left hand, with this you push up. Ek minute, I can't, I don't know whether I've, ek minute, I don't know what I've done with the knot. Single knot, ek minute. And not up, down, it has to go down. Mosquito, please. Out. We'll be taking switches by the side as well. Tooth forceps. They may or may not be temporary. We'll see if there's any bleeding happening from when we defatten the umbilicus. Then these are temporary. If there are not, then these are permanent. This side. Okay. Scale and marking pen. Now I need this thing as well. Yeah, no, we are going to do just a slit. Okay. Midline slit. Okay. So we are going to take at 9 centimeters.
That was a 7.
It was 10, no? 10 o'clock. 10 it was. Okay. Now that I marked here, I just check where I am. It seemed to be practically there only. Yeah. So you you have the midline now. You can see the midline. That's the midline. So you go half above, half below.
How much, sir?
What 1.5 to 2 centimeters.
Okay.
So that's what her umbilicus is underneath. Yeah, blade.
Have you kept two long sutures with the umbilicus?
No. Yeah, artery forceps. बड़ा वाला है क्या? Normal mosquito है? Yeah, now I need a catch paw if you don't mind. Catch paw. Yes, catch paw. Just put a catch paw on the two sides. No, at the center में जहाँ मेरा ये है ना, when my this thing is. Yeah. Scissor and forceps, please. एक जरा ब्लेड दीजिए, थोड़ा छोटा हो गया. Can you hold this? Scissor.
Bhati ke level will come, sir.
Yes.
And you're very much sure that the umbilicus underneath.
Yes, I checked. No, I checked when through this thing I checked.
So we are deflating now.
We are defatting. We are removing fat from here. Like I think one of the ladies said, I think Dr. Ruchi that was probably.
Yes.
She was asking.
Yes, sir.
Are we going to defatten that? Yeah, gauze piece, please. A mop rather. Yeah, I don't know whether you can see, but right there, half and half. Can you see the umbilicus? Right. Half below, half above. Yeah, perfect position. Allahu Akbar. Now comes the struggle, and Vishnu and Kaushik are going to be entirely responsible for the struggle because they made me take the Barudi stitches. So far, we have been lucky, and I think the anesthetist is keeping the blood pressure brilliantly under control. There is no bleeding here. Hopefully, the patient is with us. He is not okay. That works. Okay, so
Can I put a single hook?
no, just basically defatting. Okay. So now I have feel this. You can, unfortunately, the others can't, but feel this now. Go around there. Put your finger like this. No, other direction. No, A side mein. Yes. Aisa, Aisa. Huh. See, it's thinned out, right?
Yes.
Yeah.
Yeah.
It's thinned out. It's defatting. Yeah. So see, feel like this. Yeah, it's thinned out there. Same here, but there's a little more I can see myself on by visualizing. Here you can see this is thinned out. Here there is a little bit, so we'll just grab it. Can you see that? Get rid of it. And just hope and pray that there is no bleeding, and it shows immediately. So you can make out. And remember, this is subscarpa. This is parasitic fat. It usually does not bleed. Yeah, so we are done. Okay, the defatting is done. Feel here now. Same thing. Feel this side. You feel that sort of like a beveling. Yeah, from here to here. Yeah. Chalo. 30 PDS, please. This is going to be fun now. Yeah. So now what we are going to do is we are going to take a stitch through the rectus fascia and to the dermis under the tube and see what happens with the umbilicus. But it's easier said than done. So let's wish me luck. Yeah. Now what I will need from you is I will need you to be all the way down. Sorry. No, all the way down. Lying back. Yeah. छोटा लाएंगे ना और मेरे को लंबा टूथ मिलेगा नहीं नहीं इट बिकम्स ब्रॉड डोंट आई डोंट वांट इट
हाँ हाँ ठीक है
क्या हो गया
एक बार देख लेता हूँ हाँ I can't see then I'll put
ओके एक मिनट there is
आते सर तो क्या है
okay yeah so now first thing we do superb retraction by Archana and Kaushik Aparna and Kaushik yes same place I spoke too soon both sides of the rectus fascia yeah no, yeah you are pulling too much she's pulling too less that's the way yeah bus utna hi. A little more this side yeah
take one
yeah can you see the needle there yeah. Just hold it don't pull it out don't pull it out hold it hold it I will take it out with the needle yeah just hold it there I'll take it out with the needle this is always a struggle thoda wo side little bit that side yeah bus perfect please just hold it yeah can you see the needle just hold the needle don't pull it out please hold the needle I'll take it out bus chakas first class okay so now where are we are on one side can you hold the this with the mosquito okay so now we go
taken bite in the
rectus fascia now we go here under the dermis
of the
umbilicus at 12 o'clock across
then
okay and then we are down yeah so I have to go from up to down
how many
no so there is going to be one on the other side I've taken the easy one just now I have to take one on
tighten this one
no I will tighten it
sir फिर और भी कम है सर अगर उसको सिर्फ
God is great
सर umbilicus का dermis और ये ऊपर वाला abdominal dermis
okay एक मिनट
without taking the rectus
yeah give me that underneath
feed sir
yeah bas thank you okay छोड़ दो आप निकाल दो no छोड़ leave everything okay now this is the most important part just make sure that you cross because if you don't cross this is going to break okay and you just push all the way down can you see the dip coming in the midline can you see the dip
yes
sorry
sir
क्या हो गया
got impressed with that
yeah so patients really beg for this
yes that big
yeah short okay but this excitement will now depends on the next stitch again I need Aparna and Kaushik this is going to be difficult PDS 30 okay same thing at the bottom
round body
round body needle yes okay now that yeah this is going to be hard it's always hard but yeah your retraction is going to make the difference chalo gauze piece ek dalenge I can't see anything now on the rectus fascia yeah just put a gauze piece there little more this side एक काम करो एक सिंगल ये डालो ना छोटा अपना ये वाला रिट्रैक्टर थोड़ा ब्रॉड वाला रिट्रैक्टर डालो ये मत डालो इसका थ्रेड्स निकल रहा है बॉस इसको मत डालो yeah You need you to pull nice hard. Ek minute. Start coming there. Yeah, bus. Hold it like that. Yeah, just hold it like that, please. You get a lot of not lot, a little more space if without you don't do the Barudi stitches. But here there is no way to lift up the fat apron because the Barudi stitches are right there. But we will surmount. There is no light now. Yeah, 1 minute. Can you see the needle there? Yeah, perfect. Just hold it, Just hold it. No, it went through this thing, not the. No, don't do that. We don't have space here. This I need a little bit of a tight pull. Sorry. Yes. Yeah. Can you see the needle? 1 minute. Yeah, hold the needle, please. Don't do anything. Hold the needle. Bas. Yes. God is great. Yeah, take it. You can take this. Take it out. Yes, please. ये भी निकाल लो. Yes, just keep it on this side. This is easy. ये तो नींद में भी कर सकता है. It's the fascia that is important. That's what I just said. Now I can't see the needle. Oh, 6 o'clock and 12 o'clock. छोड़ दो. Okay. Now one last thing I need you to do: put a cat's paw at 6 o'clock position, just slightly away from the 6 o'clock position. So as I tighten the knot, here. As I tighten the knot, I want you to remove the cat's paw. Okay. Who's holding it? I'm holding. Okay. Always make sure that you have squared the knot, which I hadn't. Let's square it now. Ready? See the dip? Yeah, this is what actresses and models pay for. Okay, and some lady was asking me there, never remove a chunk of fat around, always bevel it. That is why it's easier to do it from the outside rather than from the inside, because inside you have a temptation of removing a big, long this thing of fat. So see, this is the dip that's being created, both
Yes.
here as well as there.
Yes, sir.
Good. Superb retraction, guys. Superb retraction. Bus. That's it. Now all we need to do is look at the edges of the umbilical and take some subcutaneous stitches. And this is the only place where we'll be using 6-0-ethylon, which I hope you guys can just do it, finish off for me. Huh? So this with Barudi stitches is an accomplishment. Yeah, and it's all because of the retraction, nothing else. Because it's very hard to do it. It's a struggle. Sometimes we do this for 15-20 minutes at a time. If you have taken Barudi stitches. Okay, now we'll need the drain. 14 number Romoac. Either just simple 60 stitches around the periphery. In the end, if you can just put that. ठीक. The umbilicus है ना, and this is round body needle. Unequal contest. So in essence, this thing for a Pitangi sort of this thing, a Mercedes Benz, it's not necessary. Just a nice slit. Give them the dip. They love the dip.
With some wrong body, it's a bit struggling.
It is a struggle, yes. But अभी क्यों unnecessarily वापस और PDS और निकालने का है तो इतना ही. कितना बजा? 6:30, 7. Okay, not bad. We finished in what, 2.5 hours. अभी है अभी बाकी. I'll need a marking pen now. Sanglam nice marking pen. And let's first put the drain before we forget. Any opinions about not putting the drain? Even in the audience?
Anyone for not putting the drain? Anyone for not putting the drain?
Yes. Last stitch में बराबर ये साला needle तकलीफ देने वाला है, round body.
Hold that tip.
बस, thank you. Yeah, थोड़ा उठा लो. Yeah. Now all that remains is to put a drain, remove the excess tissue. Just make sure there is no lateral dog here and steal. And I think these people will steal. Will they steal? Okay, sure. Yeah, so drainage. I have 100% record in causing bleeding during drainage insertion. Let's see whether today this thing is. Oh, too good, not bad at all. Important to be in the land of Jagannath Puri. Yeah, second one.
One more drain.
Actually, no bleeding. All is great. Yeah, or if you have 30 silk, or if you have just normal silk on a needle, that's good enough. Karega, we will fix the drain.
Yes,
Yeah.
What is it?
Yes, so this is the Scarpa's fascia, right? So you have to go underneath. It's an area where, it will not be visible. Yeah. Sometimes they can get a little painful scar there on the pubis. So, what chalo bleeding? नहीं हुआ. Something extraordinary. Sure. Let's pull it out to where the mark is. Yeah. Pull it out to where the mark is. Two layers. Yeah, vicryl and ethylene. Cautery. Yeah, vicryl and PDS.
Fix the drain.
Yeah, can you fix the drain? नहीं कर डालो भाई, फिनिश इट ऑफ. निकल आएगा तो लफड़ा हो जाएगा. Finish it. Vicryl 20. Cut it. Can you hold it up? एक नहीं ऐसा. Cut please. You cut this. इधर का थ्रेड निकाल देंगे. मस्किटो. चल हो गया. इसको कनेक्ट कर डालो तो just connect it to the just the tube, not the this thing. Just connect it to the tube. Chalo. So yeah. So now marking pen. Yeah. ये देना आर्टरी फोर्सेप दे दो. Dry gauze. Dry mop. Dry gauze. This was our marking, right? No, itna hi tha na. This the cut was here, so we have just done exactly where the cut was before. Yeah. So now you check, is this going to come all the way? Yes, it's going to come all the way. So this is your marking on this side. You check the same on the other side. That mark is already there. Just bring this along. Check, pull. Yes. Probably will come a little more above as well. Okay, just check there. Easily आएगा. In fact, इससे थोड़ा और आएगा. Yeah, keep something underneath. Right side, left side, which one you want to do first? Chalo, blade do. No infiltration, nothing here. Abhi time for all that rubbish is over. Pull down. With forceps to me. Now, when I cut this, you have to pull as much as you can. We need this flap avulsed. Yeah. So so we want the parasitic scarpa's fascia to come out. Yeah, cautery. Yeah, pull. Hold it with the hand. Hold it with the hand and pull. Yeah. खाली इसको मत तोड़ना बस. नीचे है कुछ? Just thumb that inside. Put it inside. Yeah. बस. Yeah, pull down. Don't worry. We'll take care of it when we finish removing the. नीचे definitely कुछ है ना? है कुछ नहीं है राजा. Okay, so that's our this thing. Let's check the ear. Do you have a plain forceps? Okay, sure. Now we have to make sure that there is no dog ear. We have to steal in this segment. Okay, now just finish off that as well. So is it okay if I just close the dog ear here? Will you close the rest? Sure. Properly. Yeah. 2 layers. Vicryl with the fascia. Bring it together. We'll take some of those stitches, and this thing. Just getting a catch in my chest. Blade, please. Yeah. Just make sure that something underneath. Bas, both okay. Good enough. Light. Chalo. Ready? Yeah. No. Down. We pull only after I cut completely. We just see the corner. Cautery. Okay. Now you have to pull. Keep that cloth underneath. Just pull. नीचे की तरफ. Okay, no undermining. You have to go straight vertically down. Pull. Kicho. Yeah. See that parasitic scarpa's fascia, no? That has to come out with. You see that coming out? Yes. Yeah, that has to be avulsed off. Once we just have to cut this. Okay, let's check that. Touch, please. और एक था ना, there was one Venus, this thing that इधर से आया था क्या? One Venus bleed somewhere. इधर कुछ है, नीचे देखो जरा, Venus कुछ bleed आ रहा था, यही रहेगा शायद। Let me इसको रहने दो, not a problem. Touch and go. Bas. Okay. So Vicryl, please, 2 Vicryl. Okay. Most important thing is to make sure that you don't have a dog ear in the corner. Yeah. So take this first 2 stitches and obliterate the dog ear. Forceps. Yeah, this is most important to get this corner right. So you don't have to extend the incision to cut the dog ear. So one this stitch and one more. Yeah. Now, whatever else you want to do, you can steal in this entire zone. But what, generally speaking, divided into the three elements that you have. You know, you have 1, 2, 3 elements. So isko chhod do. Just divide them. One side there will be 5, one side there will be 6. And then just close. Huh? We'll be able to do that, right? Yeah. Thoda excess hai, cautery. So 20 Vicryl here on this, and then 30 PDS this, on the subcuticular. If you think you want to use something else, you can use monocryl or whatever you want to. For subcuticular PDS if possible. Yes, continuous. Otherwise, आपको जो चाहिए वो monocryl कर सकते हैं, या you can take over and over with echelon, whatever you want to do. I'm just taking these corners. Just bring this forward. हाँ, exactly. So नहीं चाहिए वो. Preferably अगर आप इससे करते हैं तो, yeah, monocryl से. Normal dressing. Normal dressing. Yeah. Compression garment, if possible, you can put it on table only, operation table. Yeah, if before she gives, she's got a catheter in place now. Yeah, so you can put the compression garment on the table itself. There's nothing like it. Okay, make sure there is no dog here. Yeah. So anything else you do here, you will have problems. Problems in the sense it will be up and down. There will be mismatch, this, that, all of that settles. The dog ear is the part that does not settle. So always take that area first. And then now, no, not like this. You just have to divide it into halves. So yeah, so it's like that. So it is 6 here, a little more here, a little more here, like that. Karke, you just close it off. करेंगे? Okay. चल, thanks so much. इधर 60 लेने का है. हाँ, 60 एथिला. चलो, thank you so much. Thanks. Sorry to leave you with the laborious work in the end.
Thank you, sir.
Yeah, thanks.
Thank you, sir.
Oh, okay, sure. We'll go little bit that side so she can take.
Any post-operative protocol for this lipoabdominoplasty you follow? Already was. DBT, cure. DBT stocking.
Thank you. नहीं कुछ नहीं, no worries. Red? कितना बजे? 7 बजे. No problem. नहीं करते ना, विल डू सर.
थोड़ा 1-to-1 डिस्कशन ही करते हैं.
चलेगा. Sure.
Should be very नहीं छोटा कुछ बोल रहे सर. नहीं 1-to-1 डिस्कशन नहीं हो पाएगा.
Sure.
कुछ पीपीटी होगा तो उन लोगों को दे देंगे. हाँ. नेफरोप्लास्टी हम लोग करते हैं.
Yes, Abhi, whatever you say. Thank you. Thank you very much. दिख रहा है वहाँ पे.
Actually, we have And what they want, they are giving so much of money. They are saying to. वो तो डिक्लेयर करने वाला जो एपटे क्लिक करो सीट तो पूरा फाका कहीं और जाओ ना हाँ आइडी तर पास आ हम से भी बोले नहीं सूर्यांश कौन भी कौन थे सूर्यांश जी है तुम्हारा शिवन के लिए ନା ଆଉ ଗୋଟେ ହେଲେ କଣ କହୁଥିଲେ ନା ଆଜି ତ ତାଙ୍କର ଆଉ ଗୋଟେ ଲାଗିଛି
ମୁଁ ବି ଦେଖିନି କେତେ ଖଣ୍ଡେ ବାହାର କରୁଛି ଦିଟା ତମକୁ ଖୋଲି ସାରିଲାଣି କହିଲେ କହିଲେ
ଦୁଇଟା ଖାଲି ଥାଉ ସିରିଏମ୍ ଟା ଖୋଲିଦା ସରିଲାଣି ଡାକ୍ତର ବି ପଳେଇଲେଣି ଖାଲି ସିଲେଉଛନ୍ତି ସୂର୍ଯ୍ୟାଂଶ ଯିବାକୁ ପଡିବ ବା ମତେ ଏଇଟା କଥା ମୁଁ କହିବି ଆଉ ଏଠି ତ କେହି ନାହାନ୍ତି କଣ କଲେ ବି ଦେଖୁଛି କି ଖାଲି
ଖୋଲା ହବନି ରହିବ କାଲି ଅଛି ପ୍ରୋଗ୍ରାମ ପଡି
ଜଣେ ପଚାରୁଥିଲେ ଯେ ମୁଁ କହିଲି ଏମିତି
इधर ये देख लो सिस्टम तो हमारा रहेगा ना एलईडी वाले से मैं लॉगिन दिया पिक्चर तो हमारा मेरा कोड करो जो बाकी को दिखा अरे सॉरी 1 मिनट मुझे बड़ा यार तो थोड़ा चीज बहुत जा रहा ଅଛି ଗୋଟେ ଦିବି ଦୌଡାଇ କହିଲ ଆଣ୍ଟି ସେଠି ନେଇଥିଲେ ଗୋଟେ ଏଠି ଲାଗିଲା ଗୋଟେ ତାହେଲେ ମୁଁ ଛଅରୁ କହିଦଉଛି ଆସିଲେ କେତେବେଳେ ସବୁ ଖୋଲିକି ନେଇ ଆସିବା ଆଉ नहीं पूरा ଭିତରେ ଯୋଉ ଚନ୍ଦ୍ର ଦେଖିଲ अरे भाई कौन तो
ସେ କୁ ଫୋନ କରିଥିଲି ମୁଁ ତ କହୁଛି ଆମ ଏପଟ ସିଷ୍ଟମ ବନ୍ଦ କରିଦେବା ସେପଟେ ସିଷ୍ଟମ ଚାଲୁଥିବ ତମର ନେଟରେ ହଉଥିବ ଏପଟେ କଣ ଏପଟେ ତ କିଛି ଶୁଣିବ ନା କହିଲେ ମୁଁ ସେ ମ୍ୟାଡାମଙ୍କୁ ପଚାରିକି କହୁଛି ବ୍ୟାଗ ଏଇଠି ରହିବ ସାଇଡ୍ ଗୁଡା ହେଲେ ଭଲ ଲାଗିବ ପୁରା ଏଇଠି ଚଢେଇ କରିବି ପୁରା ଉଠିକି ରହିଲା ବେଳେ ଦେଖିବ ଯୋଉ ବ୍ଲୁ କେବୁଲ ଟା ତମର ଥିଲା ନା ପୁରା କଣ ସେ କାଢି ଦଉଛି ଗୁଡା Huh? 20. Just over. You know what? Right there, sir. Hundred. No gas is no gas is only.
ନାଇଁ ନାଇଁ ଖସିଗଲେ ଚାର୍ଜ ଦେଖେଇବନି ନା ପରସେଣ୍ଟ ଦେଖଉନଥିଲା ପରସେଣ୍ଟ ଦେଖଉନଥିଲା ଚାର୍ଜ
Then what will happen? None of the we have this 3, 4, 5. Or 4, 0, whatever. Ramesh, bro. 3, 0.
What is it? Monocril.
That's zero.
Any problem? No. You have closed it better than I would have closed, no? मैं इधर को बाउंड कर देते हैं तो बाउंड एक लाइन में बाउंड कर देंगे तो हम जीवन में चीज लिखे हैं